Morning, everybody. Welcome to this online CMA series being conducted by the Kerala Society of Ophthalmic Surgeons. This is the 19th in the series. This is yet another project of our president, Dr. Meena Chakravarti. This is going to be on PG orientation for the freshers. Even though I say freshers, it's applicable to all the postgraduate students. It's going to be very basic, and we have eminent speakers who are going to talk on the basics of ophthalmology. And you're going to get a wonderful advice from a very senior teacher, Dr. Charles Sakriya sir, from his vast experience. I've structured this program in such a way that I've included all the youngsters in the teaching institutions, both from the medical college and the private sector. But you might ask, how come Mahadev sir, Sahasranama sir, Andrew sir is among the youngsters? Yes, they are still young. They have their own passion for teaching, their own style of teaching. So with these speakers, this program, I think it's going to be a wonderful program. And we have only one invited faculty from outside, that is Dr. Asim. He's a very good friend of mine. Just like any other program, we have an invited faculty. Out of this 30 speakers, we have only one outside KSOS, that is Dr. Asim. He's from Brunei. He's an excellent speaker. I've seen him present the practical use of slit lamp, and it is fantastic. I thought I should introduce him to this freshers about slit lamp. Slit lamp is one of the most important thing in ophthalmology. So then I should thank Sahasranama sir for guiding me to plan this program and to choose the right person for the right topic. Thank you so much, sir, for accepting my request and helping me out in this program. And I thank all the speakers who have accepted to participate in this program without any hesitation. I didn't find even a single person refusing to do it. So I thank all the speakers for accepting my invitation. So with these few words, I request our president, Dr. Meena Chakravarti madam, to inaugurate this program and to say the inaugural speech. Madam, over to you.
Am I audible? I have put a name for you, which is yes, the young eye surgeons, the portals of a very hallowed career in ophthalmology. The young eye surgeons includes not only the junior residents, it will include the senior residents, the fellows, as well as young ophthalmologists in the first 5 years of their career in ophthalmology. With this orientation program, the Kerala Society of Ophthalmic Surgeons plans to provide you with a meaningful content targeted at your knowledge level so that your clinical skills can be honed to initiate an interest in you in this subject so that you can carry it forward by reading more on what you have heard here today. We have 30 experienced teachers participating in this program on PG orientation, postgraduate orientation. And from experience, all of us know that what they are going to share with you is from their past experience, and it will have a lot of learning value. So make use of what you hear here today. In this lockdown period, we have been faced with a webinaria, too many webinars on anything under the sun. Some of them are very good, some of them are good, some of them are mediocre. In addition to that, there is a lot of material on YouTube, but please bear in mind that none of this is peer reviewed. So before you sit down to watch a program, take the advice of your teachers who will know definitely the track record of the speaker that you're going to listen to. Make a list of all the programs that you have listened to or you're planning to listen to. It is not enough just to listen. You have to sit down, think about it, assimilate what is it that you have heard, read about it, make your own notes. Before you sit down for the exam, it is your own notes that will have more weight than any of the webinars that you have listened to. So it is not enough just to listen to a webinar. Assimilate, read, make your notes, and anytime you can go back to the recorded program and listen. This is my personal advice to you. In addition to your daily routine, carry a small book with you in which you write down the interesting cases or even the mediocre cases that you see daily. Go back and read. Reading a forgotten art right now is what carries most weight in your career. You will remember only what is it that you have heard and read. In addition to that, I would like to give a word of advice to the youngsters here. We are in a profession which is a hallowed profession. Even if you are beaten up by the patients, bystanders, it is still a hallowed profession. We have a special position of trust in the society. As a consequence, the society gives us certain privileges, and for us to still be trusted, we have to behave in a particular way. And this is known as the Code of Medical Ethics. A Code of Medical Ethics implies that we should have a reasonable amount of professional skill. And to attain that reasonable amount of professional skill, right from this stage in your career, it is necessary for you to read. This is my advice to you.
Madam, our phone on the
I would like to take this opportunity to thank the Scientific Committee Chairman, one of the key pillars of my team, for organizing this 19th in the CMA series. And I also take this opportunity to thank Dr. Sastranama, who has given a lot of advice in the planning of this program. With these few words, I invite you to listen to Dr. Charles Karyaskar, a teacher of vast experience, who will be sharing his experience with you. Thank you very much for your patient hearing.
Good morning to everyone. Am I audible?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Okay. I'm very happy to be part of this orientation course for the postgraduate residents organized by the Kerala Society of Ophthalmic Surgeons. I congratulate KSOS for organizing such a novel program, and may I take this occasion to thank the Scientific Committee Chairman, Dr. Rajiv, for inviting me to be part of this orientation course. Going through the topics in this course, almost all the important topics has been covered and in this two-day event, and I wish all success for this program. At the outset, let me congratulate all the residents for choosing to specialize in ophthalmology. Welcome to this fascinating world of ophthalmology, which is fast progressing with a lot of recent advances. It is really difficult to keep pace with the progress. Postgraduate learning is a process of self-learning under the guidance of your teacher, who is your mentor. The aim of postgraduate training is to transform you into a comprehensive ophthalmologist with a sound theoretical base and capable of diagnosing and treating all ophthalmic problems. This process of guided self-learning during the residency training is physically, emotionally, and intellectually challenging and demanding. You should have a positive attitude and determination and put in more than 100% dedication to meet these challenges and succeed. There is always a starting problem when you are in a new phase of your career and in a new atmosphere. When to start, how and what to start is always a dilemma. Theoretically, it is always better to start from the basics and then go to the advanced. But practically, it's never going to be like that. You may be exposed to the most advanced topics and difficult case scenarios even before you start the basics. But don't get confused. Whatever you see, whatever case you see daily, and whatever is being discussed in clinical discussions and seminars, make it a point to read that topic the same day itself. Never end your day without reading and learning that topic. Simultaneously start learning the basics from day one. It is always better to start from known to unknown. So start reading the books that you have used as an undergraduate student. I personally prefer Parsons' Disease of the Eye, as this is an abridged version of the 15 volumes of textbooks on disease of the eye by Duke Elder, which was my textbook of choice during my postgraduate course. You should also start reading a core comprehensive book like Kansky's Clinical Ophthalmology, which covers common topics comprehensively, but not exhaustively. The current trend among the residents is just to read Kansky only. I am not against Kansky. It's a very good book with a lot of illustrations and photographs, but it's not covering the topics in depth. You can include next level of books like Principles and Practice of Ophthalmology by Peyman, Albert Jacobi, Yanov, American Academy of Ophthalmology, Basic and Clinical Series. If the comprehensive books are not covering a topic exhaustively, later on, as you advance in the course, you can read the reference books. Basics of ophthalmology can be studied from Wool's Anatomy, Adler's Physiology, Ocular Pathology by Vishwas, Refraction by either Duke Elder, Elkington, or Khurana. Each subspecialty like cornea, eyelids, uvea, retina, glaucoma, cataract, and neuroophthalmology, squint, etc. have separate books which every resident is supposed to read in their course. It's a long list of books. My first PG student in Amala Institute of Medical Sciences, Dr. Amanda, has recently published an article titled Textbooks for the Beginner Ophthalmologist. It's a very good article. The link, if necessary, will be provided by the organizers. Use the library facility to the maximum. Spend more time in your library than in your hostel room. I used to prepare my own notes after reading the textbooks and reference books. Now the textbooks and thousands of PDFs are available online. So buying these books are not really necessary. So you may take photocopies of the books or the chapters which are useful. Always make your own notes on very important topics. In the early part of your course, one way of refreshing your basic undergraduate knowledge is by attending all the academic programs for the undergraduate students, like theory classes, seminars, symposia, and clinical discussions. Now, what are the basic gadgets you need to buy to start learning proper examination techniques? Of course, you need an indirect ophthalmoscope with a condensing lens, a streak retinoscope, a gonioscope, condensing lens for the slit lamp biomicroscopy of the posterior segment like a 90D or a 78D. The use of direct ophthalmoscope, although limited, you may buy if necessary. Learn the correct examination techniques from your seniors under supervision by your mentor. If you learn the wrong technique, you are likely to continue this wrong technique the whole of your career. Plenty of educational videos are available which can be utilized to learn the examination techniques. Video assisted skill transfer courses are there to help you to master slit lamp examination, slit lamp biomicroscopy of posterior segment, indirect ophthalmoscopy, gonioscopy, applanation tonometry, etc. Start doing all this from the first year itself and practice it daily. Don't be an observer only, do it yourself. Refraction is one area students are neglecting now. Learn streak retinoscopy and do subjective refraction regularly, and you should be confident to prescribe a glass comfortable spectacle when you pass out. You should learn the basics of orthoptics also. Kindly note that refraction carries 20 marks for the practical examination. The assignments given to you like seminars, symposia, journal presentations, and case presentations will help you a long way in building up your knowledge. Present your topics after reading all the relevant material from the standard textbooks and reference books. Never do cut, copy, paste from the presentation of your seniors or use SlideShare from the internet. Exposure to diagnostic modalities depend on the center where you are being studied, where you are studying. You should be able to do and learn to interpret ultrasound, A scan, B scan, automated perimetry, OCT, fluorescent angiography, etc. If your center is not having all these facilities, you can be assigned to a center where such facilities are available and get an exposure. You should have performed treatment procedures like capsulotomy and iridotomy. Must have observed and assisted retinal laser procedures. At the end of the course, you should be able to perform cataract surgery, either a small incision cataract surgery or a phaco surgery, eyelid wound repairs, suturing of corneoscleral wounds, etc. You should have assisted trabeculectomy, squint surgery, and vitreoretinal surgeries. You can learn suturing on thermocol or pig eyes and use your wet lab for your surgical training. Virtual simulation for surgical training is now available to learn each step of surgery, promoting surgical confidence and patient safety. Immediately after joining, you will be assigned a faculty to guide your thesis. You will have to select a topic of research and register with the university after clearance from the research committee and the ethics committee. the thesis has to be submitted to the university 6 months prior to your final examination. Finish all the thesis works by the end of the second year. Don't carry forward the thesis works to the last minute. Attend maximum number of continuing medical education programs, postgraduate training programs in regional institutes or other centers of reputation. Attendance in national and state conferences and scientific paper and poster presentations in the national and state conferences are mandatory to appear for the examination. Publications in index journals is an important criteria assessed by the examiners and Medical Council of India. Kerala Journal of Ophthalmology and Indian Journal of Ophthalmology are index journals, which gives ample opportunity for the postgraduate residents to publish your work. You are expected to maintain a logbook, which carries 20 marks for your examination. All details of your daily academic activities should be available in the logbook, properly signed by the concerned faculty and the HOD. The examiner can easily spot a logbook that is cooked up just for the examination purpose. Kerala Society of Ophthalmic Surgeons and All India Ophthalmological Society are conducting various academic programs exclusively for postgraduate residents. All postgraduate students should become associate members of Kerala Society of Ophthalmic Surgeons. All the districts are having district ophthalmic clubs. You must join as an associate member and actively participate in all the academic programs by presenting cases and scientific conclude by wishing you all a smooth sailing in your postgraduate course. Practice PPE protocols and stay safe in this COVID era. Thank you very much.
Thank you, sir, for the excellent advice from A to Z, from entering to leaving this college. Now I request Mahesh to say a few words before we go into the program. Mahesh, can you unmute yourself?
Thank you, Rajiv. Welcome to the KSOS Freshers PG program. Charles sir has given most covering, advice based on his 30-40 years of experience, which has covered almost everything. I also stressed few points. Yesterday there was a Guru Vandanam program. The highly successful people were appreciating their teachers, how they helped in formation of their life. So it is the duty of the postgraduates to read and actively participate in the discussion and involve. There is no spoon feeding in postgraduate training. So if you go and ask a doubt to the teacher, he will be 100% ready to explain it and teach you. The second thing is start from the basics and grow, and build a thing over it. Recently I saw one PG who was making a lot of PC rent. When I looked from the side scope, the PG was not focusing properly. So the basic focusing of the microscope also is important. So basic you start and then go. Then the last thing I advise is write notes. If I remember, Mahadevan sir has joined. Mahadevan sir used to make small notes on anatomy. And when we were doing post-graduation, he used to come in the evening and teach us small topics on anatomy and basics. He used to have his own drawings and he will teach us like that. And even now we remember most of the anatomy he has taught. So that is how make your own notes and don't do this Google search and find out what is happening. It will not stay in your memory for a long. Anyway, Charles sir has noted, given wonderful advice for all the postgraduates. So I don't have to add anything. Over to Rajiv. Sasnam sir wants to tell anything?
Yes, definitely. I want him to say a few words before we start, because we have time also.
Yeah.
Sir, unmute, sir.
No, I just, Rajiv, I just only want to appreciate the whole team of KSOS who have made this wonderful platform. Because, I find that like in the yesterday years we had that region-wise PG orientation classes, and I think this is going to be a better thing. So COVID has its own good things, and one of the good things is happening is what we are seeing now in the academics. And I think this is going to be a better show than what we had in the years of PG guidance. And what I want to say is my words of appreciation to the whole team of KSOS who are doing this job. Thank you.
Thank you, sir. Mini Madam, shall we move on to the scientific program? If all the speakers are ready, we can move on. Over to you, man.
Good morning all. Now it's time to go to the first session. The first session is on applied anatomy. The session will be chaired by Dr. Mahadevan, and Dr. Neeta Siddhan will be the moderator of the session.
Thank you. We'll straight away start the session because we are expecting some delays and then extension of the program. Now, this anatomy, I would like all the PGs to listen very carefully, follow the speakers well. Only my talk has got a video and I'll be doing a running commentary along with it. All the others will show good PowerPoint presentation, short presentation. So we will straight away go to the first session, first talk by Babita. Babita, please start. Yeah, start sharing your screen and then start talking.
Good morning to all. First, I thank KSOS for this opportunity. My topic is applied anatomy of lid. The functions of lid include protection of the eye, and it keeps the eye moist, and it has an important role in the facial features of an individual and give awareness about the state of wakefulness of an individual. First, we can discuss about the embryology of the eyelid and congenital anomalies. Embryologically, the upper eyelid develops from frontonasal process and lower lid from maxillary process. First, this eyelid folds appears in this upper eyelid fold appear in the frontonasal process and lower lid fold in the maxillary process by about 6th to 7th week of gestation. Incomplete development of this eyelid folds leads to ablepharon and microblepharon. Then this eyelid folds has to fuse by about 8th to 10th week of gestation. Then defective fusion leads to eyelid colobomas. Maybe either upper lid coloboma or lower lid coloboma or both slit lid having coloboma. Maybe associated with iris coloboma, lenticular coloboma, and chorioretinal colobomas. Then meibomic glands and eyelashes differentiate from a common pilosebaceous unit by about 2 months of gestation. The defective differentiation leads to congenital dystichiasis. It is characterized by an additional row of eyelashes, and these lashes are directed towards eyeball and cause irritation of the conjunctiva and recurrent erosion of the corneal epithelia. And the treatment for this include epilation. Then the eyelid structures develop by about 3 to 4 months of gestation, and their defective development leads to congenital ptosis. Congenital ptosis is characterized by absence of the upper lid crease. If the congenital ptosis is severe, that is, the lid covers the pupillary area, there is a chance of development of amblyopia. So, it is an indication for early treatment for congenital ptosis to prevent amblyopia. Then this fused eyelid has to be separated. This eyelid distinction takes place by about 5 to 6 months of gestation. Its defect leads to ankyloblepharon, that is attachment between upper and lower lid, or blepharophimosis, that is narrow palpable fissure. And about the extent and position of the eyelid, the upper eyelid extends from the eyebrow to the upper border of palpable fissure, whereas lower lid from the lower border of palpable fissure to cheek. Normally, the upper lid covers the upper 1/6 or 2 millimeters of the cornea, whereas the lower lid is at the level of inferior limbus. and the vertical fissure height is about 10 to 11 millimeters. As age advances, this vertical fissure height decreases, become 8 to 10 millimeters in an elderly patient because of the development of aponeurotic ptosis. And the horizontal distance is about 30 to 31 millimeters. These are the positional anomalies of the lid. This include ptosis, that is drooping of the eyelid, ectropion, outward turning of the eyelid margin, or entropion, inward turning of the eyelid margin. Then these are the lid creases. The upper lid crease is formed by the fusion of LPS aponeurosis with the orbital septum. In Asian population, it is seen about 2 to 5 millimeters from the lid margin. Therefore, the orbital fat is more anterior and gives an appearance of fullness to the upper lid. Whereas in European population, this upper lid crease is around 10 to 12 millimeters from the lid margin. Then the malar and nasojugal creases limit the spread of blood and fluid from lid to cheek. Thus, this edema is confined to the periorbital area itself. The lid margin is divided into lacrimal and ciliary portion by the opening of lacrimal punctum. And this lacrimal portion is devoid of lashes. And the dense plexus of nerves and vessels are seen around these follicles, hair follicles of the ciliary portion, and is responsible for the tactile sensitivity of the lid. 100 to 150 cilia are seen in the upper lid, whereas 50 to 75 in the lower lid, and they are arranged in 2 to 3 rows with the glands of Z's and moles in the base of this hair follicle. Therefore, chance of lid infection is more in the upper lid. This is a case of Odiola externum characterized by pus pointing at the hair follicle, hairline, and this has to be treated by epilation. Then gray line is the eyelid margin projection of orbicularis muscle known as rheolin muscle. It has very important role in the lid, full thickness lid wound suturing. In wound suturing, first we have to align this gray line to get a better apposition of the wound. Then this is the structure of the eyelid. This from anterior to posterior, skin, subcutaneous tissue, orbicularis muscle, LPS muscle, molars muscle, tarsal plate with the meibomian gland, submuscular tissue, and the conjunctiva. These are the eyelashes. The skin of the eyelid is thinnest and highly mobile, and the skin laxity increases with age, and which leads to dermatochalasis. The subcutaneous tissue of the eyelid is loose areolar tissue devoid of fat, so easily distensible with the fluid and blood. So, periorbital edema may be the first manifestation of nephrotic syndrome or angioneurotic edema. Then about the striated muscle, there are two striated muscles in the eyelid. They are orbicularis oculi and levator palpebrae superioris. This orbicularis oculi muscle has three parts. They are orbital, preseptal, and pretarsal. The pretarsal portion is responsible for involuntary closure of the eyelid and normal drainage of the tears. And the orbital fibers are responsible for forced closure. And this orbicularis oculi muscle is supplied by seventh nerve. And the facial nerve palsy, there is a chance of impaired lid closure, which may lead to exposure of inferior cornea and conjunctiva and the exposure keratitis. To prevent exposure keratitis, we have to tape the lid in the case of seventh nerve palsy until the nerve recovers. The levator palpebrae superioris is the retractor of the eyelid supplied by oculomotor nerve. The ligament known as Whitnell ligament is seen in this muscle, which separates the muscle into muscle belly above and the aponeurosis below. And this ligament has an important role in ptosis surgeries. And the aponeurosis is inserted into medial canthal tendon, posterior lacrimal crest, lateral canthal tendon, skin, tarsal plate, and conjunctiva. And the lateral aspect of this aponeurosis divides the lacrimal gland into orbital and palpebral portion. Disinsertion and dehiscence of this aponeurosis leads to development of ptosis. The non-striated muscles seen in the eyelid are Muller's muscles, and they are arising from the posterior aspect of the LPS tendon and is inserted into the tarsal plate. There is sympathetic innervation, and the peripheral arterial arcade is seen at this level of Muller's muscle in between this and the LPS. The sympathetic denervation of this muscle leads to Horner syndrome, which is characterized by ptosis, meiosis, and anhidrosis. Then the submuscular connective tissue, they split the eyelid into anterior and posterior lamella. The nerves and vessels are seen in this layer, and local anesthetic agents are given to this space to get a better anesthesia of the eyelid. Then orbital septum arises from the superior and inferior orbital rim. which act as an anatomical barrier for spread of infection, hemorrhage, and edema. Therefore, preseptal cellitis, that is inflammation confined to the area anterior to the septum, and orbital cellitis, the inflammation is spread behind the orbital septum, and there is chance of spread to the intracranial areas in cavernous sinus, leads to cavernous sinus thrombosis. And the visibility of the orbital fat in lid injuries means the orbital septum is injured, and therefore there is a chance of injury to deep structures including the eyeball. About the tarsal plate, it is well developed in the upper lid compared to lower lid. The upper lid, the vertical height of tarsal plate is around 10 to 12 millimeters, whereas in the lower lid only 4 millimeters. And the horizontal length is 29 millimeters. Near the medial and lateral canthus, there is two tarsal plate joints, and the medial lateral canthal tendon is formed. It has a rigid attachment to the periosteum of orbital wall. The meibomian glands are arranged in this tarsal plate as vertical perpendicular to the lid margin. There are around 30 glands in the upper lid and 20 in the lower lid. The chronic inflammation of the meibomian gland is known as chalazion. The treatment for this is incision and drainage. When we are putting the incision from the conjunctiva side, we usually put vertical incisions to prevent injury to multiple meibomian glands. From skin side, usually horizontal incision to reduce the scar formation. The orbital fat, upper lid, the orbital fat is seen between the orbital septum anterior and LPS tendon posteriorly, whereas in lower lid, it is anterior to the capsula palpebral fascia. And this orbital fat has a thin, fibrous capsule. The upper lid, there are two discrete fat pads, nasal and central. Some orbital surgeries, lacrimal gland is mistakenly identified as orbital fat pad. The lower lid, there are three fat pads. They are nasal, central, and temporal. And the inferior oblique muscle run between the nasal and central fat pad. There's an importance in the inferior oblique surgeries. The canthi are the area of the junction between upper and lower lid. They join at an angle of 60 degrees with each other. In lateral canthus is in contact with the eyeball, whereas medial canthus is separated from the eyeball by the plica semilunaris and the caruncle. Normally, lateral canthus is at the level of or within 2 millimeters of the medial canthus. If the lateral canthus is more than 2 millimeters higher than the medial canthus, it gives an appearance of monkloid slant to the face. Whereas if the lateral canthus is at a lower level, it gives an appearance as an anti-monkloid slant to the face. The medial canthal tendon, the anterior part of it arises from the anterior lacrimal crest. Then it's split into upper and lower part to enclose the lacrimal canaliculus. And it gives shape to the medial canthus and enclose the caruncle. And the posterior part is seen behind the lacrimal sac. During rhinostomy and dacrocystectomy, we cut this medial palpebral ligament from the anterior lacrimal crest to expose the lacrimal sac. Then angular artery and vein pass medial to the medial canthal tendon, artery being more medial to vein. The knowledge of this anatomy is very important to save this vessels during DCT and DCR while putting the skin incision. Fracture of the medial canthus leads to lateral displacement of the medial canthal tendon and appearance of telecanthus. And the medial canthal tendon is at the same position of cribriform plate. The conjunctiva has a keratinaceous squamous epithelium, and we can see the opening of accessory lacrimal glands like gland of Wolfram and gland of Crossendis palpebral conjunctiva. Then artery is applied. Upper eyelid is applied by the branches from the internal carotid artery, whereas lower lid from the branches from the external carotid artery. These two vessels form a rich arterial plexus in these lids. Upper lid, there are two arterial arcades, whereas in lower lid, only one arterial arcade. This is the marginal arcade and this is the peripheral arcade. This rich collateralization between these two systems is responsible for rapid wound healing of the lid wounds and low incidence of infection following lid surgeries. Venous drainage. The pre-tarsal area is drained to angular vein and superficial temporal vein. The medial aspect to the angular vein, which in turn to internal jugular vein, whereas lateral aspect to superficial temporal vein, external jugular vein. And the post-tarsal area through the ophthalmic vein to the cavernous sinus. Therefore, there is a chance of spread of infection from the lid to cavernous sinus and leads to cavernous sinus thrombosis. Lymphatics from the medial 1/3 of the upper lid and medial 2/3 of the lower lid drains to submandibular lymph nodes, which in turn anterior cervical lymph nodes. Lateral 2/3 of the upper lid and lateral 1/3 of the lower lid to preauricular lymph nodes and parotid nodes, which intend to deep cervical nodes. About nerve supply, motor supply by oculomotor nerve and facial nerve. Sensory, ophthalmic division of trigeminal nerve supplies the upper lid and maxillary division to the lower lid through its multiple branches. And sympathetic supply to the Muller's muscles. Then glands, meibomian glands and Zeiss glands are the modified sebaceous glands seen in the eyelids, and Moll's glands is the modified sweat gland. These glands of Croce and Wolfram, the axillary lacrimal glands, are responsible for the basal secretion of tears, which keep the eye moist always. This is about the applied anatomy of eyelid. Thank you.
Thank you, Dr. Babita, for the excellent presentation. I call upon the next speaker, Dr. Farsana, for her presentation on cornea, conjunctiva, and sclera.
Can I start?
Yes.
I will be speaking on the applied anatomy of the cornea, the sclera, and the conjunctiva. First, let's start with the cornea. The cornea is a spheroid, and as any spheroid, it can be of two shapes. It can be oblate or it can be prolate. Oblate means that it is flat at the center and steep at the poles. And oblate corneas are seen in animals like frogs, whereas prolate means that it is flat at the poles and steep at the center. And prolate corneas are seen in animals with superior vision like eagles. So we humans are very lucky to have prolate corneas. Next, the size of the cornea. For practical purposes, what we do is we measure the horizontal corneal diameter using a caliper. And if the horizontal corneal diameter is less than 9 at birth or less than 10 after 2 years, it's called as a microcornea. If it is more than 11 at birth and more than 13 millimeter after 2 years, it is called as megalocornea. Then all infants with megalocornea do rule out congenital glaucoma. The thickness of the cornea is thinner centrally than peripherally. And this is especially important when you are measuring the intraocular pressure, because if the central corneal thickness is low, you get a lower intraocular pressure, and in thicker corneas, you get a higher intraocular pressure. So if you do not take into account the central corneal thickness, you may err in your diagnosis of glaucoma. I'm sure all of you know the layers of the cornea. Embryologically, the epithelium is derived from the surface ectoderm, from where the skin and hair and nails are also derived. So just like them, it can regenerate. Whereas the endothelium, which is from the neural crest cells, once lost, are lost forever. The corneal epithelium is stratified, squamous, non-keratinized. The youngest cells are at the bottom, the columnar basal cells. Then comes the wing cells, and the oldest cells are compressed at the top, the surface cells. And all these cells have innumerous intercellular connections. These include the tight junctions, the desmosomes, and the hemidesmosomes. So all these together constitute the epithelial barrier, and it is this epithelial barrier that prevents the entry of water, molecules, and microbes into the cornea. And this is why when we do a fluorescent staining, we find that the fluorescent stains the tear film. However, the cornea does not stain. But if the epithelial barrier is breached, the fluorescent will encounter the higher pH of the stroma and it will take up the stain. Similarly, if you have an abnormality in your desmosomes and hemidesmosomes, you are likely to get recurrent corneal erosions. So I've told you that the epithelial cells regenerate, and how does this take place? There must be a source, and the source of the epithelial cell regeneration are the pluripotent stem cells, which are located at the limbus in horizontal ridges called the palisades of Vogt. And how does this regeneration takes place? In the first step, the limbal stem cells will migrate horizontally to the center and form the basal cells. In the next step, these basal cells will divide by mitosis and move vertically and become the surface cells. At this point, the older surface cells will desquamate into the tears. So this three-step process is called the XYZ hypothesis, where X is the vertical migration, Y is the horizontal migration, and Z is the loss into tears. So for your normal corneal epithelial function, Z must be equal to X plus Y. However, in conditions like limbal stem cell deficiency, this horizontal migration is affected. And so there are persistent epithelial defects and conjunctivalization of the cornea. Similarly, in epithelial dystrophies, the vertical migration is affected and the cells can no longer desquamate into tears. So they become intraepithelial cysts. That concludes the epithelium. Next is the Bowman's membrane, which is the anteriormost part of the stroma. The Bowman's membrane, once injured, cannot regenerate. So any disruption or a wound or an ulcer will result in a corneal opacity. The stroma constitutes 90% of the thickness of the cornea. It is comprised of collagen, glycosaminoglycans, and cells like keratocytes. The collagen is type 1 and is arranged uniformly in lamellae. And this is very important because that is why the cornea is transparent. The cornea is transparent because the collagen fibers are uniformly arranged and the distance between these fibers is less than the wavelength of light. So that if there is any raw ray, it is immediately destroyed by destructive interference. And another feature about the packing in the stroma is that in the anterior stroma, the collagen fibers are very tightly packed, whereas in the posterior stroma, it is less so. So if ever there is any edema, the fluid is unable to move anteriorly. So it goes posteriorly. This results in undulations in the Descemet's membrane, and these are seen as Descemet's membrane folds. How does the stroma repair itself after injuries? It is by activation of the keratocytes, which migrate to the site of injury, transform into fibroblasts, and produce scar tissue. And if there is at all any interference in this process, it will result in a corneal melt. The Descemet's membrane is thin but very strong, and it can maintain the integrity of the cornea even when the stroma is lost, such as in a descemetocele. Here are two conditions where the Descemet's membrane is damaged. Here, this is a complication of cataract surgery. You can see an area of focal edema, and if you zoom in, there is a Descemet's membrane detachment. And here you can see an ectatic cornea with surrounding haze. This is due to rupture of the Descemet's membrane that occurs in acute eye drops. So in both these conditions, you can find that the Descemet's membrane is damaged, but in most of the time, it can be resolved with conservative treatment. This is because of the ability of the endothelium to synthesize fresh lamina identical to the Descemet's membrane. The endothelium, at birth, we have about 3,500 cells. It decreases every year by 0.6%, and by adulthood, we have about 2,400 cells. And the endothelium is important in maintaining the corneal transparency because of the presence of pumps which constantly pump water and solutes out of the cornea and maintain the state of relative dehydration. So if your endothelial cell count falls below 500, you will get irreversible corneal edema. So how does the endothelial cells heal? As I've told you, it cannot regenerate. So what happens is if there is an endothelial damage, the surrounding cells will enlarge and it will fill up the deficit. And this enlargement of the cells is called as polymegathism, and the change in the shape as a result is called as pleomorphism. So here you can see dimpling of the endothelium, and on specular microscopy, there are dark gaps. These are guttae, characteristically seen in Fuchs endothelial dystrophy. And here is a dreaded complication of cataract surgery, an edematous vascularized cornea. This is pseudophakic bullous keratopathy, occurs after prolonged, difficult surgery, especially in those with low endothelial cell count. So it's always prudent to look at the endothelial cell count before surgery. Finally, just a few words about the pre-Descemet's or Dua's layer described by Dua and his colleagues in 2013. They found that just before the Descemet's membrane, there was a layer which was very strong, acellular, impervious to air, and could withstand high pressures. And they call this the pre-Descemet's or Dua's layer. They said that by including this layer in lamellar corneal surgery, we could vastly improve our surgical outcomes. Finally, about the blood supply and innervation of the cornea is avascular except for at the periphery, which is why in immune-mediated diseases, we get peripheral corneal ulcers because the antibodies can reach only the periphery. They can't reach the center. So the antigen-antibody complexes are formed in the periphery, which results in corneal ulcers at the periphery. And the cornea is richly innervated, which is why never underestimate the pain of a corneal epithelial defect. So next, the limbus. I'll be just mentioning a few words about the surgical limbus. So the surgical limbus is a 2 millimeter wide zone and it has the following landmarks. The anterior limbal line corresponds to the termination of the Bowman's membrane. The mid-limbal line corresponds to the termination of the Descemet's membrane or the Schwall baseline, and the posterior limbal line corresponds to the scleral spur. Between the anterior limbal line and the mid-limbal line is a blue zone. The blue zone is widest superiorly. Between the mid-limbal line and the posterior limbal line is the white zone. The white zone is 1 millimeter throughout. So in whole, the surgical limbus is widest at the widest superiorly, which is one of the reasons why the superior incision is so popular. So on surgical section, this is how it looks. And this area is the blue zone. And here you have the white zone. This coming to the sclera. Both sclera and cornea are composed of collagen. However, the cornea is transparent while the sclera is not. This is because of the irregular arrangement of the collagen in sclera, leading to scattering of all the wavelengths of light, giving it an opaque appearance. The sclera may not always be white. Blue sclera is seen in collagen disorders like osteogenesis imperfecta and Marfan syndrome. Yellow sclera is seen in conditions like jaundice. Yeah, but physiologically also, sometimes in children, you can get a slight bluish discoloration of the sclera. This is because of the thinness of the sclera. And in elderly, sometimes you may get an yellowish discoloration. This is because of the deposition of lipids. The thickness of the sclera is thinnest at the insertion of the extraocular muscles and at the limbus. This is why in trauma, the globe rupture, the common sites are at the insertion of the extraocular muscles and the limbus. And while doing a surgery, whenever you're passing sutures close to the extraocular muscles, do be extra cautious. Remember, this is very thin. The blood supply and innervation of the sclera. Sclera is relatively avascular. Whatever supply it receives, it's from the episcleral bed and the choroidal vasculature. And the contribution from the episcleral bed is slightly more, which is why the anterior scleritis is more common than posterior scleritis. Again, sclera is very richly innervated. This is why in scleritis, there is severe pain that wakes the patient up from sleep and does not respond to analgesics. And it is because of the extraocular muscle attachment to the sclera that there is pain on extraocular movements. And what happens to the sclera whenever there is raised intraocular pressure? In infants, it leads to the stretching of the sclera, leading to bullseye or ophthalmos. In adults, the scleral is more rigid because of the increased collagen diameter. So what happens is at the lamina cribrosa, where the optic nerve fibers, here it bows backwards, and this results in optic disc cupping. We finally come to the conjunctiva. The conjunctiva, mainly three parts: the bulbar conjunctiva, the phoenicial conjunctiva, and the palpebral conjunctiva. The bulbar conjunctiva is very thin. It is loosely attached everywhere except at the limbus, where the conjunctiva, tenons, and sclera fuse. This is why surgeons love to hold at the limbus. The phoenicial conjunctiva is loose, flexible. It is what provides motility to the eyelids and the eyeball. So whenever there is any symblepharon, that is any adhesion between the palpebral and bulbar conjunctiva, the fornix is obliterated. So there is decreased motility and also dryness and keratinization. The palpebral conjunctiva is thin, very vascular, and has fibrous septa anchoring it to the tarsus. It also has the highest number of antigen-presenting cells, which is perhaps why there are conditions like papillae. Papillae are elevated, flat-topped lesions with a cobblestone-like appearance. They are red at the bottom and pale at the top. And they're characteristically seen in allergic conjunctivitis and also in contact lens users. Another condition is follicles, which are discrete nodules. They're red at the top, pale at the bottom, and they're characteristically seen in viral conjunctivitis, so can be seen in bacterial conjunctivitis also. The sulcus subtarsalis is a groove 2 millimeter from the lid margin, and it is the most common site of lodgement of foreign body. So always evert the upper cell conjunctiva before saying there's no foreign body. The conjunctiva also has some vestigial parts, just like the appendix. These are the caruncle and the plica semilunaris. They are remnants of the third eyelid or the nictating membrane seen in birds. So in birds, this nictating membrane helps them to keep the eyes open while flying. The histology of the conjunctiva, there is a fibrous layer at the bottom. This fibrous layer, which contains the accessory lacrimal glands. Then there is the adenoid layer, which contains the conjunctiva-associated lymphoid tissue, which is responsible for mucosal immunity. And finally, the epithelium. The epithelium contains the goblet cells, which secrete mucin. And it is this mucin that provides stability to the tear film. So any loss of goblet cells, you will get ocular surface disease and severe dry eye, such as in xerophthalmia and Stevens-Johnson syndrome. So I hope I've said just the right amount, not too much, not too little. Thank you.
Oh, thank you for the wonderful presentation, Dr. Farzana. Well, it was very well, the concepts well explained and beautiful illustrations. Thank you. So we go on to the next topic on uvea by Dr. Gargi Satish from
Yes.
Kottayam Medical College.
Yes. Can I share screen now?
Yeah.
Dr. Nita?
Yeah, yes. Yeah.
Okay. Okay. Good morning. Very good morning, Dr. Mahadevan, sir. And good morning, Nita. Good morning, all seniors here. A warm welcome to yes, sir. A warm welcome to all the budding ophthalmologists. You have chosen a fascinating specialty. Welcome and congrats on choosing ophthalmology and all the best on your journey through ophthalmology. Now, since I have to cover iris, ciliary body, and choroid, so it's a rush, a sprint. So sprint with me. You can see the grapes there, and why uvea is connected to grapes. Actually, no time to explain. The Latin word uva means grapes. And what is the relation? Please go and check for the fun of it. Fine. It's not going to the next slide. Yes, fine. Now, the parts of the uveal tract, other than iris, ciliary body, and the choroid, you should also know that anterior uvea means iris and the anterior ciliary body. Intermediate uvea means the posterior ciliary body pars plana and the anterior part of the retina, choroid, and the hyaloid here. And posterior uvea is the choroid, because that is how we classify anatomically the standard classification of uveitis. You might be knowing it from your MBBS times. Now, coming to the beautiful iris, in your undergraduate and postgraduate presentations, you will always be telling about iris pattern. Now, what is this iris pattern? There is a collarette here, which divides the iris into a ciliary zone and the pupillary zone and a ciliary zone. So pupillary zone, you can see there is a pigment ruff there, pupillary ruff there, which is actually the posterior iris pigment epithelium peeping out. Then you have the radial streaks. You have small crypts there, both centrally and peripherally, and you have these contraction furrows. So this is the iris pattern which you are mentioning about. And you next time under slit lamp, you look for these, and these are going to be altered in conditions like uveitis. A collarette is having embryological significance. The fetal pupillary membrane is attached to the collarette, and you very commonly see persistent pupillary membrane, such filiform things attached to the collarette of the iris. Now, iris crypts, most of us spend quite a lot of time in your glaucoma clinic trying to find a peripheral iris crypt to perform a laser iridotomy, because it is very thin there and you need a very less amount of laser energy to open the iridotomy. Coming to the microscopy, you have an anterior limiting layer, then the stroma here, which contains the all-important sphincter and the dilator muscles, and the two pigment epitheliums. The anterior limiting layer is actually a condensation of the stroma itself, and other than the routine cells seen in any stroma, it contains lots of melanocytes. And the pigment epithelium is pigmented in all individuals. It is the amount of melanocytes in these two layers which determine the color of your iris. So the most sought after blue iris will have lesser pigmentation. Our brown iris has lots of melanocytes. Now, the dilator pupillae and the anterior pigment epithelium go very close together. It is having a new rectodermal origin, so that is very significant. Smooth muscle cells arising from the root of the iris going towards the pupil. And always remember that it is a sympathetic supply which is important there, and the sympathetic supply is via the long ciliary nerve. Now, the sphincter pupillae is a circular sphincteric muscle near the pupillary margin, deep stromal level. And the innervation, you all know, just brush up. It's just a revision for you, just inciting you further into the clinical parts also. That's all. So parasympathetic from the Edinger-Westphal nucleus via oculomotor nerve and the short ciliary nerves. And left and right, we use drugs, atropine, phenylephrine, pilocarpine. These all act on these muscles, cholinergic, anticholinergic, and adrenergic. Now, the pigment epithelium, the posterior pigment epithelium is actually cuboidal cells with plenty of melanocytes and very smooth. So when you mention iris pigment epithelium, it is this posterior pigment epithelium that we talk about. And if you talk about the continuity, this continues behind as the non-pigmented epithelium of the ciliary body. And if you trace it further behind, it goes and continues as the neurosensory layer, the inner major layer of the retina. Okay. Now, one significance, maybe you can, in certain individuals, pigments get dispersed abnormally from this pigment epithelial layer, causing what is called a pigment dispersion syndrome. You can see the pigments on the cornea here, and this causes a secondary sort of glaucoma. So you will encounter these in your further years in ophthalmology. Now, coming to the next main star, which is the ciliary body. Ciliary body is triangular like that in cross section. The apex will point towards the ora serrata, and from the base, the iris starts like this. And the only place where it is actually attached to the sclera is here at the scleral spur, which is at the angle of the anterior chamber. It has two parts, you all know, the anterior pars plicata and then the pars plana, totally around 6 to 7 millimeters. And from the outside, if you see, it starts from around 1 millimeters behind the limbus and goes 6 to 7 millimeters posteriorly. The functions everyone knows, very important functions of aqueous humor formation and lens accommodation. Now, microscopically, it has got 5 layers. So the anterior limiting layer of the iris continues here as the supraciliary lamina. Then you have the stroma, and then you have the outer pigmented epithelium and the inner non-pigmented epithelium and the internal limiting membrane. So the outer and inner should always strike you. Outer means it is towards the sclera and inner means it is towards the aqueous humor. Okay. Now coming to pars plicata, it is the anterior 2 to 2.5 millimeters of the ciliary body thrown into radial folds called the ciliary processes, around 70 of them in each eye. And the zonular fibers of the lens come and attach to the valley between these processes. These are called the valleys of Kundt. Now this is a model. If you see from behind, this is how it will look beyond the iris. You can see how much surface area has increased because of this arrangement. Each process around 2 millimeters long, 1 millimeters in height, and 0.5 millimeters in width. Now rarely, if the root of the iris is deficient, like say in an iridodialysis, when you put a gonioscopy mirror, I hope you have seen a gonioscopy mirror used by your seniors to view the angle of anterior chamber. So through that, in the deficient area where there is no iris, you may sometimes see the ciliary processes. Now this is a ciliary process. It contains all the layers, the epithelium, stroma, and it has got the scapulary plexus with the arteriole draining venules, and the capillary endothelium is having so much fenestrations and pores. Now our intraocular pressure depends on the regional blood flow, the surface area there, the hydrostatic pressure there. All this affects aqueous humor production, and all our so many of our anti-glaucoma drugs which suppress aqueous humor, carbonic anhydrase inhibitors, all these act on the capillaries there, the epithelium there. Fine. Now the outer pigmented. So outer is towards the stroma and the sclera. It is, you can see it is densely pigmented cuboidal cells. The inner non-pigmented is very important, more columnar. Lots of organelles are there because very busy producing aqueous humor. And you have got what are called tight junctions or zonular occludence between these cells. That itself shows you that nature is trying to prevent all the components of the blood here in the capillary to reaching the posterior chamber, and that constitutes what is very importantly called as a blood aqueous barrier. So blood in the capillary has to pass through the endothelium here, through stroma, through the 2 pigment epitheliums and the tight junctions to reach the aqueous humor. So ultrafiltration and only the required things reach there. So we have a crystal clear, optically empty aqueous humor, and in conditions like uveitis, neovascularization, this barrier is broken and we get a turbid aqueous, and we can see flare and cells in the aqueous humor. Now coming to the stroma, the most important component will be the ciliary muscle. Ciliary muscle has got 3 layers. You can see the outer layer here. See, the main bulk is the outer layer, the longitudinal fibers from the scleral spur here towards the aura. The inner fibers are the circular fibers which goes round like the sphincter muscle, and you have the oblique and the radial muscles here. Okay, and you have to think about parasympathetic. Ciliary muscle means parasympathetic via short ciliary. In fact, around 97% of these short ciliary supply the ciliary muscle, and very few go to the sphincter pupilla. So that is because it is important for the most important part, physiology happening there called accommodation, which you have to read. It is an essay in itself. And presbyopia is basically related to changes in the lens and anterior lens capsule, but there are age-related changes occurring in the ciliary muscle also. And you know, cholinergic drugs, we have already said, they will contract the ciliary muscle. So you can see here, when it contracts, it will pull on the spur here, and the spur is attached to the meshwork. So the meshwork channels will be opened up a little. So that is of use in angle closure glaucoma. When you put pilocarpine, it may open up the trabecular meshwork. And the reverse is also true. We need to paralyze the ciliary muscle sometimes, or many times, like in for refraction, and you use anticholinergics like atropine. Now, supraciliary lamina is just a condensation, and beyond that you have a potential space. It continues behind as a suprachoroidal space also. So fluid and blood can get collected there in lots of pathological process and cause detachments of the ciliary body and choroid. So it is a potential space, and nowadays we are using it also for many purposes like drug delivery, but basically it's a potential space. Now, pars plana is very important in your retina clinic. It is all about pars plana. It is a relatively avascular area, smooth and pigmented, around 4 millimeters wide. See, it is the safest posterior surgical approach to the vitreous cavity. So you can see the needle piercing into the eye through the pars plana. You can see vitrectomy being done, and ideally around 4 millimeters from the limbus is where you get a safe pars plana area. And through that, if you go, there is a least chance of damage to the lens and to the retina. Now the choroid. Now choroid is the main nutrition of the outer layers of the retina. So outer layers nutrition is from the choroid, and it's so thin, just 0.25. Talking all very, very thin layers, 0.25 millimeters, and it will increase in thickness in inflammations like in posterior uveitis. Now, histologically, choroid consists of what is called a Brooks membrane, very close. These layers are very close. This is a retinal pigment epithelium and the Brooks membrane. Then you have a layer of choriocapillaries. Then you have a layer of smaller vessels called the Sattler layer. So smaller for Sattler, you remember like that. And the larger vessels are the Haller layer. And finally, the suprachoroidal lamina. As an OCT, so nowadays you have enhanced depth imaging OCTs, whereby you can see a little bit of the choroid also. Earlier it was all the retina. So you can see the blood vessels here. That is OCT, optical coherence tomogram. Hopefully you have started seeing OCTs in your places. Then you have the suprachoroidal lamina. Already I mentioned it has a potential space between it and the sclera. And it is through that space that the posterior ciliary vessels, long posterior ciliary vessels, reach anteriorly. Now about choriocapillaries, they lie in a single plane like this along the RPE, and the walls are very thin and fenestrated. The larger vessels are thicker and not fenestrated. The importance is that fluorescein, we inject fluorescein in fundus fluorescein angiography. It will diffuse very easily through the endothelium of the choriocapillaries, so that this is FFA, early FFA. The vessels of the retina are not yet filled, but you can see that the choriocapillaries have started leaking. So this retains throughout. That's a background choroidal flush and choroidal hyperfluorescence because of this choriocapillaries. The lobular pattern is also very nice. You can see one artery here, capillaries here, and a venule here. So it supplies segment, not a continuous segment supply, which is very evident when there is an ischemia. So a small ischemic area will look like this in FFA. And this is very typically seen in what is called an anterior ischemic optic neuropathy, where there is ischemia of the short posterior ciliary artery. Yeah, you're going to come across all these in your coming years. Just to start you off on your journey, go and read further. Now, choroidal stroma will have abundant melanocytes. So it is the retinal pigment epithelium and the melanocytes in the choroidal stroma which gives this beautiful appearance of the fundus. So if they are absent, you will get it like this. And you can imagine how it will be without the dark interior of a camera. It will cause chaos with your vision. So this is albinism. Now, Brooks membrane, a it is composed of actually a fusing of the RPE and choriocapillary basement membrane. Both the membranes of the RPE and choriocapillary fused with an middle inner collagenous elastic and outer collagenous layer. So this is Brooks membrane. And Brooks membrane is of lots of significance in many diseases nowadays. So it can be broken. You can see these are all breaks in the Brooks membrane, which is seen in pathological myopia, trauma, and many other syndromes also. Just finally ending with mention, it is a vascular supply to the eye. So what are the vessels? You should remember there are around 20, all comes from ophthalmic artery. Short posterior ciliary around 20 will pierce around the optic disc and supply the choroid. The long posterior ciliary are 2 in number on either side. They will travel through the suprachoroidal space, go anteriorly, reach the root of the ciliary body here. The anterior ciliary arteries are all coming from the muscles. You have the 4 recti and they are supplied by the ophthalmic artery. From there, the anterior ciliary artery comes and it pierces the sclera, and at the root, both these anastomose to form the major arterial circle, and they travel radially to the pupillary root for causing the minor arterial circle. And just a mention of the venous drainage called the vortex veins, beautiful vortex veins around 4 to 7 in number. And vortex veins, you can see the next time when you start seeing indirect in lightly pigmented iris, you can see the vortex veins like this. And it's an important landmark. It is near the equator of the eyeball. So if you see the vortex veins, it means you're somewhere near the equator of the eyeball. Thank you. It was a sprint, I know. Hope you had got enough interest to look further into the anatomy of the uveal tract. Thank you.
Wonderful presentation, Gargi. Now, all these young ladies
Sir, your voice is breaking, sir.
matured into voice is breaking.
Yes, sir.
Hello, is it audible now? Yeah, now you're going to see the 4th speaker, another wonderful speaker, Neeta Sidhan. She will speak on lens, zonules, and acne.
So good morning, everyone. At the outset, I'd like to thank KSOS, Rajiv Sukumaran sir and Sahasnaman sir for giving me this opportunity. So coming to my presentation. The lens, as you all know, is a transparent crystalline biconvex structure. Its shape has also been referred to as an asymmetric oblate spheroid, like what Dr. Farzana explained before. It is positioned, as you can see in the figure, in the posterior chamber in a saucer-shaped depression termed as the patella fossa. And it is suspended by the ciliary zonules here. And posteriorly, it is attached to the vitreous by a circular ligament known as the Weger's ligament. And it creates a space here. The attachment creates a space here known as the Berger's space. So the unique thing about the lens is that it continues to grow throughout life and it does not possess any blood or nerve supply. So coming to some of the important dimensions of the lens. So the lens has got both an anterior and posterior curved surface. The anterior surface is less convex than the posterior. And the center of these surfaces is referred to as the anterior and posterior pole. The distance between the poles is measured as the anteroposterior diameter or thickness. So the importance of this dimension is that as the lens grows in size, with age, it is this dimension that increases in size. Then coming to the next important dimension, that is equator. So equator is generally measured from the nasal to the temporal aspect, and equator actually refers to the marginal circumference of the lens. It is about 6.5 millimeters at birth, and it increases to about 9 to 10 millimeters in adult life. And after that, it remains constant. So a few points regarding the embryology. The lens development begins as early as the first month of gestation. It is supplied by the hyaloid artery, which forms a network of capillaries, especially over the posterior surface, known as the tunica vasculosa lentis. So this structure eventually regresses towards late gestation, but you can see remnants of these on the posterior lens capsule as dot-like opacities. Here you can see this is the Mittendorf's dot, or sometimes you can see them as pigmented small lens opacities over the anterior lens capsule. These are the epicapsular stars. Now, these are examples of other developmental anomalies. Here you have the lenticonus, where you get a conical protrusion of the lens surface. This is anterior protrusion and this is posterior protrusion. Now here you have the lens coloboma, where you get a defect in the sectoral defect in the margin of the lens with associated zonules. This is typical inferior location with iris coloboma. So this is another anomaly. Now coming to the lens anatomy, it is composed of the lens capsule, epithelium, and lens fibers. The unique thing about this lens capsule is that it is the thickest basement membrane in the body. And it is thickest near the equator, where you have the attachment of the ciliary zonules, and thinnest at the posterior pole. So this thin nature of the posterior pole makes it vulnerable to tear and rent formation at the time of cataract surgery. It also possesses a highly elastic property, which is especially evident in children and young adults. So these properties of the lens should be kept in mind while performing continuous curvilinear capsular excess or any other capsulotomy procedures at the time of cataract surgery. So coming to the lens epithelium, over the anterior surface of the lens, you have the simple cuboidal epithelium that secrete the lens capsule throughout life. Then towards the equator and pre-equator, you have the germinal zone. Here you get actively dividing cells, which with a high mitotic activity, which elongate and form the columnar E cells. So the clinical significance of this is that very often remnants of these cells following cataract surgery can migrate posteriorly and proliferate, leading on to posterior capsular opacification. Like you can see here in this figure, this is Elschnig pearls and this is the fibrous type of opacification. So the E cells, they differentiate finally to form the lens fibers. And these fibers are concentrically arranged in an onion layer kind of pattern, with the older layers towards the center and newer fibers on the outermost aspect. Here you can see the lens sutures being formed here, both anterior and posterior, due to the interdigitation of the anterior and posterior tips of the lens fibers. So these are the Y sutures. The lens may be divided into different zones based on the time period during which each layer is formed. So here you have the outermost cortex, which is of a softer consistency and which is composed of recently formed fibers. And you have a central nucleus, which is of a harder consistency. And the innermost part of this nucleus is the embryonic nucleus, which is laid during the first to third month of gestation. Then surrounding it, you have the fetal nucleus, followed by the infantile nucleus, and then the adult nucleus. Then in between the two, you have another intermediate zone, that is the epinucleus. So the anatomical aspects of this lens zonules are important while performing hydro procedures at the time of cataract surgery. This is hydrodissection, where you have the jet of fluid injected just beneath the capsule, cleaving the capsule from the rest of the nucleus. And here in hydrodelineation, the fluid is injected into the lens matter, cleaving the nucleus from the epinucleus. So these features are also important in congenital cataract, where you typically get cataractous changes affecting the zone of formation at the time of insult. So coming to the biochemical composition, so a major part of the lens consists of water, that is 64%, and 35% is protein. And the unique thing here is that the protein content is highest among the body tissues. And it consists of the two fractions, that is the water soluble fraction, which consists of the crystallins, the alpha, beta, gamma crystallins, and the water insoluble fraction, which is mainly the membrane proteins. So it is seen that with age, and especially in nuclear cataract, the percentage of this water insoluble proteins increases. Now, lens pump mechanism is another important feature of the lens, which maintains the water and electrolyte balance across its membranes and keeps the lens less hydrated. So these are the important anatomical features that maintain the transparency of the lens. So to add to it is the lens pump mechanism, and also the antioxidant properties of glutathione, ascorbic acid, and vitamin E, which prevent oxidative stress and protein denaturation. So derangements in these mechanisms can lead on to lens opacification and cataract. So here you can see the types of senile cataract, the nuclear cataract, the cortical cataract, and the posterior subcapsular. Now, these are examples of cataract in systemic diseases, in diabetes, the rosette cataract in trauma, in Wilson's disease, and in galactosemia. So coming to the next subtopic, that is on lens zonules. So the lens zonules, they originate from the pars plana, about 1.5 millimeters from the ora serrata. And along its course, it can be divided into the pars orbicularis, the zonular plexus. Then you have the zonular fork, that is at the site of the ciliary processes. From here, the fibers, they interdigitate into three limbs, that is the anterior, equatorial, and posterior. Then they insert at discrete points on the lens capsule, about 1.5 millimeters anterior and about 1.25 millimeters posterior to the equator. Here you can see that the zonules are again divided into secondary zonules, and close to the ciliary body you have the tension zonules, and these have an important role in accommodation. Then out here you have the hyaloid zonules, which are connected to the anterior hyaloid face. So these zonules are arranged in bundles of 2 to 5 fibers, and these fibers are again composed of microfibrils and are rich in fibrillin. So the clinical significance here is that mutations in the fibrillin gene can occur in Marfan syndrome, which typically causes a supratemporal subluxation of the lens, as you can see here. Now, in homocystinuria, you get an inferior subluxation of the lens with disintegration of the zonules. Now, this is microspherophakia with a small globular lens, well seen on in the dilated state, and this it predisposes to pupil block glaucoma. Now, here this is pseudoexfoliation with the regenerated zonules here, and this is the oil droplet appearance of an anterior subluxated clear lens. So coming to the angle of anterior chamber. So the angle of anterior chamber, it's actually a recess formed between the posterior surface of cornea and the anterior surface of the iris, bounded from anterior to posterior by the Schwalbe's line, then the trabecular meshwork followed by scleral spur, and posterior most the ciliary body band. Now coming to the aqueous humor outflow, it mainly occurs, that is in 83 to 96%, it is through the conventional pathway. That is, the outflow occurs through the trabecular meshwork into the episcleral and subconjunctival veins. And in 5 to 15%, it drains out into the suprachoroidal and the supraciliary space. So coming, let us take up each structure in detail. That is the Schwalbe's line. So it represents the termination of Descemet's membrane. And on gonioscopy, it can be seen as a fine white ridge just anterior to the trabecular meshwork. And it is better identified when you do the corneal wedge technique of gonioscopy, where the anterior and posterior corneal beams meet. So pigmentation is very common here because this represents the point of transition from the scleral to the corneal curvature. Now here you can see the pigmentation anterior to the Schwalbe's line. This is in a scalloped manner. This is the Sampo-Lesy line, which is a feature of pseudo-exfoliation syndrome and sometimes also seen in pigment dispersion syndrome. Now this is the anterior displaced Schwalbe's line or posterior embryotoxon, which is a feature of anterior segment dysgenesis, and it's also seen in 10% of the normal population. So coming to the next structure, the trabecular meshwork is a sieve-like structure that is located between the Schwalbe's line and the scleral spur. It is a pale tan to dark brown in color on gonioscopy, and the pigmentation varies with age, race, and pigment dispersion. It is divided into 3 portions. The innermost, you have the uveal meshwork that is shaded in blue. Then you have the corneoscleral meshwork, that is the middle layer shaded in red. And the innermost, you have the juxtacanaliclar tissue. I'm sorry, the outermost. Then outer to that, you have the Schlemm's canal. So the uveal meshwork, as you can see here, the trabeculae are arranged in rod or cord or rope-like manner with large pores for the aqueous outflow. Here you can see iris processes on gonioscopy. These are actually the extensions of the uveal meshwork, and very often it is mistaken for peripheral anterior synecdoche. Now, the corneal scleral meshwork, the trabecular sheaths have smaller elliptical pores and they decrease in size as you go to the deeper layers. The ultrastructure of the trabecular meshwork, so both these layers have a common structure, that is they have it is composed of 4 concentric layers. The central core of connective tissue consisting of collagen, followed by elastic fiber layer, glass membrane layer, and finally enclosed by the endothelial cell layer. So this endothelial cell layer is important because it has important properties. It is joined by leaky gap junctions for the flow of aqueous and also possesses contractile and phagocytic functions. So the outermost is the juxtacanaliclar tissue. It provides the most resistance to aqueous outflow. And it again, unlike the other 2, it has got 3 layers. The trabecular endothelium on the inside, the middle layer of connective tissue, and the Schlemm's endothelium on the outside. So again here, this has got significant morphological features like giant vacuoles and pores with leaky gap junctions, which enable both a transcellular and a paracellular outflow of aqueous. So the trabecular outflow system is characterized by aqueous outflow pump driven by flexible trabecular movements, phagocytosis, fibrinolytic activity, and hence overall it behaves as a self-cleaning filter. So derangements in these mechanisms lead on to pathologies like primary open-angle glaucoma, steroid-induced glaucoma, etc. So next structure outermost to the trabecular meshwork is the Schlemm's canal. Now this is an endothelial line channel with a diameter of about 190 to 350 microns that runs circumferentially around the globe. It has a single lumen, but occasionally it can form a plexus. So here it is perforated on the outer aspect by 25 to 35 aqueous collector channels, which are drained to the episcleral plexus by a complex system of intrascleral channels. So coming to the clinical aspect, blood reflex in Schlemm's canal is an important feature of raised episcleral venous pressure, which is seen in CCF and AV fistula. Here what you see on gonioscopy is a red band across the trabecular meshwork, as you see here in this picture. Then anatomy of the Schlemm's canal is also important while performing glaucoma surgeries like trabeculotomy, canaloplasty, and viscocanalostomy. So the scleral spur is the next structure, posterior, and it is seen as a prominent white line between the ciliary body band and the trabecular meshwork. So finally, posteriormost, you have the ciliary body band. On gonioscopy, it is seen as a gray or dark brown band, and the width depends upon the point of iris insertion. So it is wide in myopes and narrow in hypermetropes. And here you can see the irregular widening, which occurs here due to the tears between the ciliary body muscle fibers following traumatic angle recession. Now, this is a cyclodialysis cleft here. This occurs due to disinsertion of the ciliary body at the scleral spur. And this is visualized as a cleft with the sclera visible underneath that. And it often leads on to hypotonic due to increased uveoscleral outflow. So we've come to the end of the presentation. It is difficult to cover all the clinical aspects due to the short of time. I hope this presentation will stimulate you in further elaborate reading of the topics. Thank you.
This is only an introduction. So
yeah,
the presentation has been well covered. In fact, you have covered many pathologies as well.
Yeah.
So good presentation. Now we'll go to the next topic by Sunil. He'll talk on retina and vitreous.
Dr. Sunil, can you unmute? Can you unmute? You're not heard.
I'm audible now, sir?
Yes, now it's sir.
Yeah. First, I want to thank KSOS for giving me this opportunity. I will try to stick on to my time. We see, I will be talking on applied anatomy of the retina and vitreous. See, to understand this lecture, I just want to bring your attention into this particular picture. See, look at this. This is lens. This is the retina. The space between this lens and the retina is occupied by a gel-like optically transparent medium, and that is called the vitreous. It has many functions, but its primary function is to maintain the shape of the eyeball. You know, it is an optically transparent gel. It is tightly adherent to the surface of the retina, that is the internal limiting membrane of the retina. Just understand it is the surface of the retina. And you know, it is strongly adherent to the optic nerve. It is strongly adherent to the fovea. It is strongly adherent to the blood vessels, and it is strongly adherent to the peripheral and the anterior-most part, that is the vitreous base. So anatomically, it is strongly adherent to 4 areas: optic disc, fovea, vessels, and the vitreous base, that is the anterior-most. Understand that is the anterior-most part of the vitreous. It is also tightly adherent to the retina in some pathological state. For example, a pigment clump occurring in the retina as a result of the inflammatory diseases. Inflammation, the choroid and all, when it heals, there are only pigment clumps in the retina, and to these particular areas, it is tightly adherent. You must also have heard about retinal degenerations. You must have heard something called lattice degeneration. Retina, the vitreous is tightly adherent to these areas of retinal degeneration also. So it is physiologically adherent to certain areas, that is the optic disc, fovea, vessels, and this the vitreous base, and is pathologically adherent in certain situations. In pathology, it is tightly adherent in certain pathological situations like pigment clumps and over retinal degenerations. So I just want to bring your attention to this part again. That is the space between the lens and the retina is occupied by an optically transparent gel-like thing. That is the vitreous. The peripheral most aspect of this is called the cortical vitreous. That is adherent to the retina. That is called posterior cortical vitreous. That is the one which is adherent to the retina. Now, as age advances, what will happen is small areas of liquefaction of this gel occurs. This is called synchiasis. You can see here. These areas of synchiasis now become multiple. So what will happen? This is like gel, this is like ice. Now it is melting. And what will happen? Its volume decreases. You know, when the ice melts into water, its volume decreases. So what will happen? It tries to collapse from this adherence to the retina. And this collapse of this vitreous cell, as a result of syncysis, is called a syneresis. That is a collapse. So that the posterior cortical vitreous, which is adherent to the retina, now collapses and comes more anteriorly. And that is called acute posterior vitreous detachment. This is a part normal aging process. This is a part of the normal aging process, and it also can occur in some pathological conditions like trauma, inflammatory disease, etc. But it occurs as a result of aging. So what will happen now? This vitreous, which has collapsed, which is optically transparent, now is come more anteriorly and become more condensed. This itself can cast shadows on the retina. So this is appearing as floaters or black spots moving in front of you. Or the patient will appreciate small flies moving in front of the patient, and wherever he looks, it also moves. That is floaters. So the cause of floater is the collapsed vitreous. Or it can also be due to, you know, it is tight. I told you it is tightly adherent to the vessels. When it collapses, it may tear a blood vessel, causing hemorrhage, bleeding into the vitreous, which is casting shadows on the retina, and that is floaters again. Or it may pull out a piece of retina as such, and this piece of retinal tissue may float in front of the retina, again producing floaters. Or while it separates, it will pull out the glial tissue around the optic disc, and so that will also float in front of the retina. That is called the V's ring, which is a complete sign of an acute posterior vitreous detachment. So it can be due to the vitreous itself, the floaters can be due to the vitreous itself, or it can be due to the blood, or it can be a piece of retina, or it can be the glial tissue. Anything can produce floaters. So I told you, when the vitreous separates from its attachment to the retina, it actually produces some pull on the retina. You know, the photoreceptors are stimulated by light, but take it from me, it can also be stimulated by pressure. That is why when you press over your lid, you will see light. So it can also be stimulated by your pull on the retina. So when the acute posterior vitreous detachment occurs, it pulls on the photoreceptors and it produces light, and the patient will appreciate flashes. Mind you, these flashes and floaters are actually a process of, it is actually the part of the normal posterior vitreous detachment developing as a process of aging process. But I told you, it can also produce problems like vitreous hemorrhage and also the break in the retina, which may subsequently lead on to retinal detachment. So many patients complaining of flashes and floaters, you should be very careful to inspect the retina to rule out these pathologies. So these problems are occurring because of the inherent nature of the vitreous. You know, I told you the posterior vitreous, which is adherent to the retina, can also act as a support for the retinal nerve vessels to grow into the vitreous. So this acts as a scaffold for the retinal vessels, which are occurring as a process of any neovascular process to come into the retina. You can see here the new blood vessels. Here actually you are seeing the edge of the posterior most edge. The white thing that you see is the posterior cortical vitreous, which is giving a support for the vessels to grow. Just like the creeping plants creep, the vessels also will creep on the posterior surface of the cortical vitreous. When the cortical vitreous separates now, you are actually seeing the separated cortical vitreous here. It is pulling the retina, and the vessels will also be pulled. This results in the bleeding. So because of this peculiarity of the posterior cortical vitreous, you get tractional retinal detachments. Again, I want to bring your attention into the this picture again. See this particular part of you know, this is the cornea, and this is continuous behind the sclera. This junction is called the limbus. Just beneath this area of at the limbus, you see just underneath the sclera, you see a structure called the ciliary body. And the ciliary body has two parts. The anterior 2 millimeters is called the pars plicata, which has the ciliary processes which secretes the aqueous humor, and the posterior 4 millimeters, which is relatively avascular, which is the very important as far as the people who do surgeries on the posterior and the retina and vitreous. Actually, this pars plana actually act as a window for these surgeons to look into the vitreous and the retina. You know, this is we can put in needles, instruments, endoscopic cameras, everything into the vitreous through the pars plana. I told you the pars plana lies immediately behind the and immediately underneath the sclera, the limbus. What will happen? This pars plana is continuous posteriorly as a choroid, and the retina fuses anteriorly with the ciliary body. So all these are important. So the pars plana, what is important is retina extends little more anteriorly in your nasal aspect. So this is why you have a temporal wider field. So your pars plana is little narrower nasally, but your pars plana is little wider temporally. It is little narrower temporally because your retina extends anteriorly nasally, and so you have wider field temporally. And the pars plana is little wider temporally, and it's little more, and that too infratemporally. So it is best to give intravitreal injections in the infratemporal aspect of the globe, because your pars plana is little wider there. Again, I want to bring your attention into this particular picture. You see, this is a junction of the pars plana and the retina, and this part is called the ora serrata. If you look at clearly now, this retina has little extensions into the pars plana in these processes. These are called dentate processes, and it is more prominent on the nasal side and less on the temporal side. What is important is this anatomical landmark is the landmark for you to convince that you have examined completely a fundus. So while you do indirect ophthalmoscopy, to be sure that you have examined the fundus completely, you have to visualize the ora serrata. Again, another important anatomical thing is, you see again the junction between the pars plana and the retina. So here the vitreous is tightly adherent at the junction between the pars plana and the retina, and that particular part is called the vitreous base. It is around 3 to 4 millimeters, very tightly adherent. At the initial part of my lecture, I told you this vitreous is tightly adherent at the vitreous base. So I also told you are putting instruments through the pars plana. So very important to put only sharp instruments through the pars plana, because otherwise, if you are putting blunt instruments, this tightly adherent vitreous base will pull the peripheral retina also when you put blunt instruments. So it may produce a small breaks or retinal tissue loss, which will subsequently lead to disastrous complications like retinal detachment. So that is also important. Again, I just bring your attention into this particular picture. You see, when you see the fundus, especially young patients, less pigmented people, you will see two horizontal lines. These are long posterior ciliary nerves. These long posterior ciliary nerves are there when you do laser photocoagulation. That is, you are ablating the peripheral retina, for example, in diabetic retinopathy. You may damage these posterior ciliary nerves. These posterior ciliary nerves come subretinally and come more anteriorly to supply the ciliary body. So what will happen if you do laser in a young patient? These posterior ciliary nerves may get damaged, and the patient's accommodation will be lost. You will find difficult to read after your laser. So that is long posterior ciliary nerves. So you should be careful about it. Now, another thing is you are having these vessels accompanying these long posterior ciliary arteries. It comes more anteriorly. So what will happen? You may have to do a surgical procedure called encerclage or scleral buckling procedure for retinal detachment. You may tighten your buckle, that is coming over the sclera. You may tighten your buckle. When you compress this, when you tighten it too much, sometimes the occlusion, sometimes these vessels may get compressed, and it may result in a complication called anterior segment ischemia. You know, anterior segment ischemia can be very painful to the patient, even cause necrosis to the anterior segment of the patient. Now, again, bringing your attention, as Dr. Gari has told you, that there is something called vertex veins. The vertex veins are actually are draining the inner side of the retina, inner side of the eye. You see small vessels joining together to form small veins. These veins are there. At least one vein is there in each quadrant, and there may be more in number. So these veins will come out of the sclera at the equator of the eyeball. That's around 14 millimeters from the limbus. So these vertex veins actually marks the surface anatomy of the equator of the globe. So these veins may come out, and again during your procedure called scleral buckling procedure, where you put a buckle around the eye, you may compress these veins, and again may result in occlusion of these veins. A compression of this vein, this is called venous stasis, subsequently cause capillary stasis, and that will lead on to anterior segment ischemia. Again, these veins may get damaged when you hook out the muscles or during skin surgeries or during retinal detachments, scleral buckling surgeries, you have to hook out the muscle. You may inadvertently damage these vertex veins. So all this has to be important because of the anatomical location of these veins. So now I just want to bring your attention to normal retina. This is a normal retina. When you start seeing fundus as in your early part of your career, you will write this as optic disc is around 1.5 millimeters. Then you will as vessels. You will write 2:3. That is the ratio of the weight to the artery to the vein. And then you write the macula. Macula is an area of around 5 millimeters, and in the center, which is centered around the fovea. So this is another structure called the fovea, which is around 1.5 millimeters, and this is almost, that means this fovea and the discus are almost the same size, and it is located around 1.5 disc diameters. So one disc diameter, half disc diameters, temporal to the macula, temporal to the disc. So this kind of fovea may have the same size. Or you have another area called the foveola, which is around 3.35 millimeters. And there is something called foveolae vascularis, and I don't want to confuse you all this, but I just want to convey this message, that is the optic disc fovea has got almost the same size, and that is it. So when you see the fundus of the patient's direct ophthalmoscope, initially you will be seeing writing disc, vessels, macula, and background retina is this particular part. So you will be able to see only 30% of the retina when you see a direct ophthalmoscope. And when you are seeing 90D, you will be seeing around 70% retina. Mind you, 30% retina is beyond your observation if you see with 90D examination. So the peripheral 30% of the retina, which can only be seen by indirect ophthalmoscopy. And so you have to masterize this technique of indirect ophthalmoscopy to see the entire retina. So, retina has many 10 layers, which extends from the retinal pigment epithelium to the internal limiting membrane, the ILM, inner limiting membrane. So this is a histological appearance. This is a schematic diagram. You see 3 layers which are having nucleus. This layer is a ganglion cell layer. The middle one is having the nucleus, so the bipolar cells, Muller cells, and the innermost one, the outermost one is the layer of the photoreceptors, very important layer. So all these layers, which is schematically given here, can be detected by an instrument called optical coherence tomography, which can delineate all the retinal layers. And very important to look at these layers. This ganglion cell layer, this is the layer of Muller cells, and this is the layer of the photoreceptors. So you look at this picture now. And you look at the fovea. It has got see this particular part here. It is a ganglion cell layer. This is a Muller cell layer. This is a photoreceptors. Look at this particular part and look at this particular part. Now let us think that a ray of light is falling here. It has to pass through all these inner retinal layers to fall into the photoreceptors. But look at it is falling on the foveola or the fovea, center of the fovea. It can directly fall on the photoreceptors. That is why your visual acuity is maximum in the fovea. So the fovea has got photoreceptors and on a very thin layer of the what is called the Muller cells. So what will happen? The light falling on the fovea has to can escape from all the scattering effects of the inner retinal layers. So you have maximum visual acuity on the fovea. It is another important. See, the inner retina, all these up to the Muller cells, is supplied by the central retinal artery. Imagine the central retinal artery is occluded. What will happen? That area got ischemia. It will become pale because of the cloudy swelling. And the color of the retina that you see is actually the color of the choroid, vascular layer choroid, through you are visualizing it through the transparent retina. So when a central retinal artery gets occluded, the surrounding the fovea, it will become pale, but you will visualize the normal retina, normal choroid through the thin fovea. So that is called the cherry red spot, which is nothing pathological. Cherry red spot is nothing pathological, but you are actually visualizing the normal choroid through, and you are appreciating the contrast because the surrounding retina is become white because of the lack of blood supply. The connecting fibers, so the connecting fibers of the what you call as the photoreceptors are called Henle's fibers layers. It is also become horizontal in the fovea. So what will happen when the fluid gets accumulated? It will get accumulated between these fibers, and it will appear as a cystic, round cystic cystic areas. That is why you see the cystoid macular edema, the fovea, because of this anatomical peculiarity. I have told you this, the embryologically, this particular part of the retina, that is the sensory retina, is different from the retinal pigment epithelium. They are embryologically different. So there is a potential space between this sensory retina and retinal pigment epithelium, which is not seen normally. But imagine there is a retinal break in the sensory retina, and a fluid inside, that is liquefied vitreous, may go back through this break in the retina and goes behind the sensory retina. It will get accumulated between the sensory retina and the retinal pigment epithelium. So this space, which is a potential space otherwise, will open up in retinal detachment. This also occurs because of its anatomical peculiarity of embryologically difference in the sensory retina and the retinal pigment epithelium. I will just conclude my talk asking you one question. You must have started writing your case sheets, and because your seniors must have asked you to write case sheets, and you will write disc vessels. Disc is normal, vessels AB ratio 2:3, fovea, macula, foveal reflex plus, background retina is normal. What is this foveal reflex plus? I cannot put a picture and show you what is foveal reflex. This is actually the reflex of light that you see from the fovea when you examine the fundus of young patients where there is no media opacity. There is no cataract, no corneal media, corneal opacities, etc. You see some light reflex from the macula. So this,
Sunil, I think you overshot time.
Yeah, so
quite a bit.
Yeah. This has to be seen to be appreciated. Actually, you see foveal reflexes because this particular part of the fovea acts as a concave mirror, so that whatever light that you are throwing through the direct ophthalmoscope has reflecting back from the fovea, because this acts as a concave mirror. That is a foveal reflex that you see. Thank you.
Yes, thank you, Sunil. Now I'll be speaking now on from the eyeball to orbit. So can I start? Yeah, the slide is being shown by Rajiv Suman, and you follow me as the line goes. I will describe whatever I am drawing. So to start with, I will draw the important dimensions of the orbit. It's a pyramidal shaped thing. The base of the pyramid is what is opening outside. So it has got a depth which goes till the apex, which is about 45 millimeters. And now that is the apex, 45 millimeters from the base to the apex. That is from the frontal plane to the apex. And horizontally, it is about 40 millimeters, and vertically, it is 35 millimeters. That's what I am drawing now. And you have got the relationship there. The superiorly, it is the frontal sinus, and inferiorly, it is the maxillary sinus. So with this itself, we can describe various lesions coming in, encroaching, and the cause of proptosis when the bony orbit itself is small by development due to premature synostosis. There will be proptosis. Now I am drawing a simple circle to start with, and then modifying it. See, then I'm modifying it. I'm drawing the tubercle of Whitnall. Then you mark the 9, 3, 12, 6 o'clock position, so that you will have you can draw these fissures and the foramina in the proper proportion and perspective inside the orbit. So that is the orbital foramen, and now I'm drawing the lesser wing, the superior ramus, body, inferior ramus. The palatine bone has been drawn as a small triangular piece of bone. Now I'm drawing the ethmoid and marking the posterior and anterior ethmoidal foramen. So the way I'm drawing it on the blackboard is that to display to you that you can draw it the same in a similar way on your answer book. So there goes the various bony sutures. Now the infraorbital fissure is converted into a canal, and the infraorbital foramen is there. I am drawing it just outside. Raju is the overlapping of the pictures. I don't know why it is not very smooth. Now I have drawn the pulley there in the upper part. the trochlea, and now I'm drawing these the tendon of Zinn, starting from the tubercle of Zinn, and now I'm marking all the muscles which arise from the tendon of Zinn. Tendon of Zinn, the lateral rectus, superior, medial, inferior, and now I'm drawing the in superior oblique, which is going through the pulley and it'll be reflecting back into the globe. What you see on near the zygomatic bone or temporal to the orbital foramen and the fissure is the greater sphenoidal wing. You've got the lesser wing, medial to the fissure, greater wing, lateral to the fissure. Now I am marking the bones, that is the ethmoid. You see I am marking the origin of the inferior oblique there, just inside the tubercle there, inferiorly. Now I am drawing the interosseous membrane across the supraorbital fissure, and a small part is free for all the nerves and veins to come out. That is the lacrimal, facial, and trochlear, and then you have got the space there for superior ophthalmic vein, which is a constant vein. And at the tip of the supraorbital fissure, I have drawn a small circle that is a communicating artery between the lacrimal artery and the middle meningeal. And now I have just drawn the inside the circle of Zinn, I have drawn the abducent nerve, the two branches of the oculomotor, and then the nasociliary I have drawn there. Now I am detailing the optic foramen. I have drawn the optic nerve as such, and then there's a small indentation there to allow the central retinal artery to come out, ophthalmic artery and central artery to come out. I'm marking the lacrimal fossa there. To save time, I am also growing at breakneck speed. That is the middle palpebral ligament I am drawing, and then I have drawn the outline of the lacrimal sac. Now I am drawing the zygomatic nerve, which goes to zygomatic-temporal and zygomatic-facial. It comes out, and it also gives the parasympathetic branch supplied to the lacrimal gland. The anterior lacrimal crest, now I am marking. That is the posterior lacrimal crest. Now I am marking the posterior lacrimal, which lies on the lacrimal bone. Now I am marking the lateral orbital tubercle Bittnall, from which arises so many structures. The LPS, the lateral palpebral ligament. Now that I am marking the tubercle of Zinn, which I already told you. So although it is a difficult diagram to draw, you can learn it by rehearsing and drawing it. And this drawing by me is just giving you a guide how to do it. See, this is a very composite diagram. You can display all the walls of the orbit through this one diagram: the roof, floor, middle, the apex, the medial wall, the lateral wall. Everything can be drawn. It can be displayed in one diagram. So if you are asked a question on any of these structures, you simply draw this one diagram and label the parts well. That is all. If you can draw a good diagram and label it properly, there is no need for any textual description. So that saves a lot of time. I am marking the body of the sphenoid there, the superior ramus, inferior ramus, the lesser wing a little above, and temporal to the fissure is the greater wing of sphenoid. So I am almost nearing the end of the drawing. I'm growing very fast. I don't know, the video is running very fast. Almost finished there. You can see all the parts they marked there. And there'll be one last diagram to complete. That is the frontozygomatic suture that will complete the diagram now. So that is it. So I'm sure you'd have followed it. This is difficult, but not that difficult, not impossible. Just learn it well. This will be a very easy thing to do at the examination. This will hold you good. All the walls are there, the apex is there, and then some more details are there I have drawn in that. And also look at the
Stellart's eye surgery, there also you see a diagram there with all the muscles displayed and the nerves going through it. So you can combine both and learn to draw a good orbital diagram. Now I'm going into the anatomy of the extraocular muscles. You look at the first picture that is shown to you now. See the now can I go to the previous slide? Yeah, that one. Now that one you can see the ciliary ganglion. This is a good composite diagram again within the orbit, how the eyeball and the muscles are disposed. You can see the superior oblique going under the superior rectus, the inferior oblique going under the inferior rectus. So that is an important dictum to remember. Now we'll go to the next slide. The next slide. Now the two types of muscles, voluntary muscles, is 7 in number. Involuntary muscle is the Muller's muscle. All the others are voluntary muscles. Now the next slide, the motor unit of the muscles are 1:1 because it is not like the ballistic movements that you make with the hand and leg, but here you make fine homing movements from one object to the other, the saccades and pursuit. So the one nerve supplying one muscle fiber, one myofibril. That is the ratio. So you got medial rectus, the largest muscle with about 20,000 fibers, and you got 20,000 fibers coming from the oculomotor nerve supplying it. So that is the ratio. Oculomotor nerve, it consists of about 32,000 nerve fibers. The lateral rectus is about 6,000 muscle fibers. Next slide. And you can go fast because all these are available in the books. I'm telling something out of the book, actually, from the anatomy. The trochlear nerve is still thinner. It's got only 4,000 fibers, and the muscle has got only 4,000 fibers, and the nerve itself has got only 4,000 fibers. So these two muscles, these two nerves are liable for equal easy compression when intracranial pressure rises. So you get this lateral rectus palsy as a non-localizing sign of raised intracranial pressure. Then you got the common tendinous ring, which actually I drew in the orbit, and the muscles are arising from it. The superior oblique and the LPS arises a little outside the ring. And hence their nerve supply is also like that. The trochlear nerve is actually outside the ring. The nerve supply to the superior rectus, actually the nerve supply to superior rectus continues to supply the LPS. So there's a common supply from the superior branch of the third nerve. Next slide. Now I'll show you how they are inserted. Next slide. Now this is basically the circle of Zinn in detail, more detail. I already drawn that by hand there, and you can see it. Right. They originate from the common tendinous ring. Next slide. Next slide. See, now this is the average distance of the insertions from the cornea, from the limbus. Is like this. So when you join them, you'll get a spiral of Tilla, as though it is not exactly in the same circular plane. So it's a spiral of Tilla. The superior rectus is far behind, and when we do cataract surgery and we want to fix the globe, we catch the superior rectus, bridle it first, or even in retinal detachments for scleral buckling, we bridle the superior rectus first because it's farther away. And all the other muscle insertions are nearer the limbus and easy to catch. Next slide. And what you have to understand roughly is that these insertions correspond to the ora serrata underneath. So that gives you an idea. That is a very important landmark. So just underneath these insertions will be the ora serrata. Bear in mind. So going through the pars plana from outside is very easy if you know these anatomical measurements. Now, superior oblique, I have shown you the arises just outside the tendinous ring, and then these fibers go towards the trochlea, the curve round, come back, and then get attached to the superior posterior temporal part of the globe, so that it acts as a rotator basically. But in various positions of the eye, it can act as a depressor as well as a abductor, right? Next slide. Now, again, inferior oblique, I showed you in the orbit diagram where it arises from. It arises from the floor of the orbit right in front and then goes behind, goes backwards under the inferior rectus and goes to attach to the posterior inferior temporal part of the globe. Again, it's a rotator, it's an elevator, and it can also cause, it is an abductor. Yeah, it can, abductor. Next slide. So I'll keep the time. Next. Yeah, nerve supply. Now the nerve supply comes from the third nerve, and except for the lateral rectus, it is from the abducens nerve. So all the muscles are supplied by the third nerve, and the one lateral rectus by the abducens nerve. And there is a mnemonic there for you all to remember. Levator palpebral superior is actually a huge muscle. It arises far behind near the apex and then fans out in front. And it is the one muscle that has got some aponeurotic fibrous tissue, whereas all the other extraocular muscles, they are mostly muscles. Very little tendon, fibrous tendon is there. You get that only very close to the eyeball, and when you do squint surgery and you disinsert, you'll know only a very small portion is fibrous tendinous tissue. Next slide. No, that is about the further structure of the muscles. Nerve supply. I already told you the nerve supply. These muscles help to move the eyeball in all directions. Whatever way you are doing now is all because of this peculiar insertions of the muscles on the globe. Some are inserted in front of the equator, some behind, and some have rotatory effect, some have elevation effect, like that. So it's a beautifully engineered structure, the whole eye and the muscles, and that's why you're able to move the eye in all directions. And blood supply basically comes from the ophthalmic artery. You've got the anterior ciliary arteries going along with the muscles. Next. Now, all that venous drainage has been already told. When the eyeball, the muscles have got their corresponding veins going along the arteries. This is coming to the spiral of Tillog. It is coming late in the talk, which should have been presented first. So this is a spiral I told you. These insertions, when you draw in one circle, they don't join together. There's a small disparity there. But that's the beauty of it. And we have utilized that the distance from the limbus for approaching the vitreous cavity through various sclerotomies. Thank you very much. I hope I have stuck to time and I helped you to make diagrams. In ophthalmology, the whole structure of the eyeball can be made into a diagram by you in the exam. Please learn the diagrams that has been shown to you by the other speakers about the angle, lens. The diagrams are fantastic. The choroid, the mosaic structure, the blood supply, the three layers of the choroidal blood vessels. Thank you very much, and hope you enjoyed this session from us.
Thank you.
Thank you.
Thank you so much for that wonderful presentation. And overall, the session was very good. It was being watched by about 250 people live, and more than 500 have already seen this, and this is going to remain in the YouTube forever. And we'll move on to the next session. I request Dr. Mini to invite the moderator of the next session.
The next session is on vision testing. Dr. Andreos will be the chairperson and Dr. Nina will be the moderator of the session.
Good morning. So thank you, Dr. Rajiv and Dr. Mini. Dr. Mahadevan has a wonderful job explaining the anatomy first section. So we are now going to the vision testing. We have 5 speakers. Dr. Nina will be talking on Snellen's chart, and Dr. Simon will be on trial set. Dr. Dahlia will be on talking on the binocular vision and test. And Dr. Sujata will be talking on ocular alignment test. And finally, I will be talking a little about the use of phoropter in ophthalmology. So the first talk will be by Dr. Nina. She is the moderator also. As you know, Dr. Nina is the senior consultant and head of the pediatric ophthalmology, strabismus, and neuro-ophthalmology at the Giridhara Institute, Cochin, for the last 10 years. And she has also vast experience in the field. So over to Dr. Nina for talking on the Snellen's chart. So I think Nina is ready. You can upload.
Thank you, sir. I'll share my screen now.
Yes.
So is my screen visible to all?
Yes.
Okay. So good morning, everybody. The first talk on visual acuity testing is on 3 topics: Snellen's chart, logma chart, and color vision. So we start with the Snellen's chart. As we all know, Snellen's chart is probably the most common and most widely used visual acuity chart we use in ophthalmology. It was first developed by Herman Snellen, a Dutch ophthalmologist. It's used for testing the distant visual acuity. As you can see here, it's a series of black capital letters which are arranged in lines, progressively diminishing in size, and each letter fits into a square. So with a detailed separation of 1/5 letter size between the letters. So what is the basis of Snellen's testing? It is based on the understanding that 2 distant points can be visible as separate only when they subtend an angle of 1 minute at the nodal point of the eye. So if you look at this picture, you can see that the entire letter subtends an angle of 5 minutes, and each limb and each breadth of the line will subtend an angle of 1 minute at the nodal point, if you test it at the distance of 6 meters. So let's come to the procedure of testing. So we're all aware of the how it is tested. For the sake of the first year postgraduates, I'll elaborate on that. The patient is seated comfortably at a distance of 6 meters from the chart. You should have a properly illuminated chart, and patient is asked to read the chart with each eye tested separately. Okay, so how do we interpret the chart? So what is normal visual acuity? So this chart has got the topmost line is supposedly to be read at 60 meters, the next line at 36 meters, the next 24, 18, 12, 9, 6, 5, 4 meters, so on by a normal person. So since we are testing at a fixed distance of 6 meters, the normal person should be comfortably able to read the 6x6 line. So that's the normal visual acuity. Now, how do you record the visual acuity of a person? So it is recorded as a numerical fraction. So for example, the numerator is the distance of the patient from the chart. It is usually fixed at 6 meters. And the denominator is the smallest line of letters, which is accurately read by the patient. For example, patient is able to, let's say, is able to read this line. That is up to this OLAF line. It is denoted as 6/18. So it is a line-by-line scoring system, and count a line as seen if more than 50% of the optotypes are correctly identified by the patient. What if the patient misses a few letters of a line? For example, let's say the patient reads up to the CTPALO line, but the O is read as D. You denote it as 6/9 minus 1. Suppose he reads it as CTRAID, but all of the 6/12 line is correctly identified. You can denote it as 6/12 plus 3. So what if the patient is not able to read the topmost line of the Snellen's chart at 6 meters? Then you ask the patient to walk towards the chart till he can read the top line. Suppose he reads it at 5 meters, you record it as 5/60. If at 4 meters, 4/60, then 3/60, 2/60, 1/60, accordingly the distance at which he reads the top line. If he's still not able to see, the patient is asked to count the fingers of the examiners at 3 meters, 2 meters, 1 meters, or close to face, and vision is recorded accordingly as CF 3 meters, 2 meters, CF 1 meters, or counting fingers close to face. Suppose the patient is not even able to count the fingers, the examiner moves his hand close to the patient's face, and if patient appreciates it, it is recorded as hand movements close to face. If patient is not able to see the hand movements, then you have to check for perception of light, which is recorded as PL positive, and if it is or PL negative. If the perception of light is positive, then you have to again check for projection of rays in all the 4 quadrants and mark them accordingly. Okay, so that was that about the Snellen's chart. Now we come to another chart which is commonly used. It is gaining popularity nowadays, especially in research and studies, because of its more accurate estimate of the visual acuity. And that chart is the logMAR chart, or the logarithm of minimum angle of resolution. It is also called the Bailey-Love chart, and it is also used in the, also known as the ETDRS chart, because it was used in the ETDRS study. So standard testing distance is 4 meters. But nowadays we have digital logMAR charts which can be adjusted to use at 2 meters, 3 meters, etc. So the acuity, the visual acuity becomes less as the logMAR value increases. As you can see here, so logMAR of 0.3 has a better visual acuity than a logMAR of 0.6. And the brightness decreases line by line, and it's a better estimate of visual acuity than the Snellen's chart. I'll tell you why later. So how do you come to this logMAR chart? How do you assess this logMAR chart? So here, the visual acuity is scored with reference to the minimum angle of resolution. So that means a resolution of 1 minute of visual angle is taken as logMAR 0, because log of 1 is 0. So I'll come to that later and explain to you in detail. So now you look at this logMAR chart. Suppose you interpret this visual acuity testing by the logMAR chart. So each letter of the logMAR is about 0.02 log units, and each line is 5 letters. So the difference, the score for each line is 0.1 log units. So between the 2 lines, there's a change of 0.1 log units. And the geometric progression of size and spacing is 0.1 log unit or 4/5. So how do you calculate the score of a patient? For example, let's say the patient reads the entire 0.4 line, but reads only 2 letters of the 0.3 line. So how do you calculate it? So this is the formula. logMAR visual acuity is equal to logMAR value of the best line, which is partly red, that is 0.3, plus 0.02 into the number of optotypes missed in that line. So 3 optotypes were missed. So 0.02 into 3 will be 0.06. So it will be 0.3 plus 0.06 will be 0.36 will be the visual acuity of that patient for that patient in logMAR. So what is the advantage of logMAR over the other charts? So you can see there is a logMAR chart and a Snellen's chart, which is kept side by side. The advantage of logMAR is, if you can see that each line has the same number of letters, 5 letters in the logMAR. As it comes down progressively, also 5 letters are there. Whereas in Snellen's, the number of letters differs in each line. And also the font is Sloan font, which is easier to understand. Sans serif. Sans serif means there is no stroke of the letter. So some letters are easier to identify than the other letters in the Snellen's chart. We all know children can sometimes memorize the entire chart and read it by heart, whereas the logMAR is more difficult to memorize and difficult to bluff. And the letter size varies from line to line logarithmically, as is the space also. So between the 2 letter space is the width of a single letter, and between 2 line space is the height of the lower line letter. And also this chart can be available in Landau C, tumbling E, as well as in numbers also. Okay, so now how do you notate the visual acuity? So when you're beginning to write the visual acuity, we all routinely write it in Snellen's. But when you start writing papers or you're going to do research, most of the people follow the metric system, a fraction in feet or in decibels or in logMAR. So you should know how to convert Snellen's visual acuity into as a fraction in meters. So this is a 6/6 in meters, can be converted into 20/20 in feet, and decimal is 1. And log of this decimal, log 1 is the logMAR, which is 0. So a Snellen's score of 6/6 indicates a logMAR of 0, because log of 1 is 0. Similarly, Snellen's score of 6/12 or 20/40 in feet corresponds to a log of 0.3, because log of 0.5 is approximately 0.3. And some of them can be expressed as percentage visual acuity also. So that was about, in a nutshell, about the Logmar and the Snellen's chart. Now we come to the color vision. So color vision, we all know, is the ability to distinguish the various colors, and it's a function of cones. So we know there are three types of cones. We have the rod sensitive cones, erythrolates, or the long wavelength cones, the green sensitive ones, the chlorolates, or the medium wavelength ones, the blue sensitive pigments, or the cyanolates, the short wavelength sensitive cones. So our eyes are programmed to see colors between a wavelength of 400 to 700 nanometers, and below 400 is the ultraviolet, and above 720 is the infrared, which is beyond our visibility. So there are various theories of color vision. You need to know them for understanding some of the color vision abnormalities. The famous one is the Young-Helmholtz trichromatic theory, which says that a given color is an admixture of three primary colors in different proportion. And then you have the Hering's opponent theory, which says that some colors are mutually exclusive, and there is no, for example, there is no color like the reddish green. So in a nutshell, I'll just tell you the types of color blindness. So this picture on the left shows you the normal vision of a group of color pencils, which is shown. Then you have protanopia as in protanolomalies, in which there is, various degrees of level of absence of rod cones, red cones. Then you have deuteranopias, where there is a there is an abnormality of the green cones in various levels. Deuteranopia and deuteranomalies are grouped in this group. And then you have the tritanopia, when there is blue cones are deficient. So this is how the person with the particular color blindness will see the picture. So what is the basis for the testing the color vision, or why do you want to test color vision? So basically they can be grouped as screening tests, grading tests, diagnostic tests, or vocational tests. So screening tests are for quick diagnosis using the plates like the pseudo-isochromatic plates of Ishihara. Grading tests need to assess the severity of the defect like the Farnsworth-Munsell 100-hue test. Then you have the diagnostic test to precisely classify a defect using the anomaloscope. And you have certain vocational tests to simulate environment encountered on the job like the lantern test. So I'll just tell you briefly. So the commonly used test is the plate test of the pseudo-isochromatic chart of Ishihara. The advantage is it's inexpensive, durable, and readily available, an efficient screening tool for congenital red-green defects. But the disadvantage is you cannot grade the severity of the color vision defect. So prototype is the Ishihara's test designed by Shinobu Ishihara. It's a series of cards in which a figure is printed in multiple colors against a multicolored background. It's called pseudo-isochromatic because there is a vanishing figure to the color defective. The color plates are circles in multiple patterns, and the figures are recognizable to most normal trichromats, whereas they are camouflaged or vanishing to those with the color vision defects. So let's see, it is available as 38 plate edition. Usually, sometimes it can have a 24 or a 14 plates. So this is the entire 38 plate chart of the Ishihara's. The plate 1 is the demo plate or the number 12, which can be read or easily by all patients in spite of the fact whether they're colorblind or not. And it's not considered for making a score. Then you have 2 to 9 plates, which are transformation plates. So individuals with color vision defect will see a different figure in these transformation plates. Whereas then you have the 10 to 17 plates, which are the vanishing optotypes. So here only the normal person can see the figure, whereas the person with the color vision may not see the figure. Then 18 to 21 are the hidden digital plates. So only individuals with color vision defect can recognize the figure here. So that those with normal color vision will not see the figure. And then you have plates 22 to 25, which are the diagnostic plates. These are intended to determine the type of the color vision defect. For example, whether it's a protanope or a deuteranome. So protons, so for example, if you look at this plate, the protanopes will only see the number on the right, that is the 6, whereas the deuterans will only see the number on the left, that is the number 2. So then you have certain tracing plates from 26 to 38. So instead of reading the number, the subject is asked to trace the line, which is visible across the plate. So how do you test for color vision? Patient is seated comfortably with adequate daylight. and preferably done before the dilatation of pupil with full refractive correction in place. Each eye is tested separately and the plates are kept at 2/3 meter from the subject at right angles to the line of vision. And you give about 3 to 5 seconds per plate for analyzing the plate. So now you have various other tests like the arrangement test called the Farnsworth-Munsell 100 hue test. So this is a very detailed, exhaustive test. You have colored caps of fixed color and value, and there are 4 boxes. Each box consists of 1/4 of the color circle, and total about 85 color samples are there. And between the caps, there is a very small difference in the colors, and the patient is asked to arrange randomly placed caps in the natural order of color. And patient requires good color vision and chromatic discrimination to perform this test. And finally, it is recorded as in this chart. So we have a smaller version of this known as the Farnsworth-Munsell D15 color vision test. It's a single tray with 15 independent color hues, and the primary purpose is to identify the color vision defects and not to grade it, basically the red, green, and blue-yellow color sensing deficiencies. So word about anomaloscope. So it is used to basically to grade the color vision defects. It's quite accurate, basically for the red-green color vision defects. So here you have a telescopic barrel through which the subject looks at a circular field, and he has to match the upper and lower field by mixing a combination of red and green light. So the disadvantage is that it's quite challenging and you need a trained technician to interpret the color vision defect. So thus it's not very frequently used, though it's quite accurate. Now we come to certain tests which are used in certain vocations like lantern tests. So they are commonly used by the railway industries, maritime and air industries to screen their employees. So it measures the subject's competency to recognize colored light signals in the particular environment. And the subject is asked to name the colors presented to them, and individuals with defective color vision make a certain characteristic color vision mistakes in naming the colors. And based on this, the test is interpreted. So that was in a nutshell about the various color vision tests and the visual acuity charts commonly used. Thank you.
Thank you, Nina, for a wonderful presentation. You have covered 3 topics: Snellen chart, Doppler chart, color vision. I now invite Dr. Simon George from RIO Trivandrum to talk on the trial set and trial frame. Dr. Simon, ready? Simon not seen?
Simon was there, now he's
he was there.
Okay, we'll move on to the next topic.
And then Dahlia, ready?
Okay, sir. Shall I say?
Okay, over to Dahlia. She will be talking in the binocular vision testing. We'll wait for Simon later. Okay, Dahlia, you can start.
Okay, so okay. My slides are visible, no?
Okay, visible.
So
you can start.
Okay, thank you, sir. My topic is binocular vision testing. So before going into the topic proper, I think we'll go through the basics. What is binocular single vision? We can go through the definition of binocular single vision, what is written here. So in simple, what it means that each eye is perceiving 2 separate images, and these 2 images are seen as a single one with a 3-dimensional picture with the ability of fusion and stereopsis. So these are the 3 grades of binocular single vision: simultaneous perception, fusion, and stereopsis. So simultaneous perception is the most elementary type of binocular single vision. It is the ability to see 2 dissimilar objects simultaneously. Here you can see the right eye seeing the parrot, the left eye seeing a cage, and you'll be seeing both together, and that is simultaneous macular perception. In fusion, it is the same, slightly dissimilar, same image what is being seen. So the right eye sees the house with a pot on the right side. The left eye sees a slightly dissimilar image with a pot on the left side. When these two images are fused together, the patient with binocular single vision will see the house with pots on either sides. Similarly, this is the picture of the rabbit also with the bunch of flowers. And in stereopsis, the patient slightly horizontally disseparate retinal elements are stimulated, and the patient appreciates a three-dimensional picture. Now, what are corresponding retinal points? Retinal points are the two eyes which share a common subjective visual direction. You can see the fovea of the left eye and the right eye has got a common visual direction in space. So the fovea of both eyes are corresponding retinal points. But when it comes to the extrafoveal point, a temporal point on the right fovea corresponds to the nasal point on the left eye. So these two are corresponding retinal points. So this again can be of two different types. Normal retinal correspondence, when both fovea has got a common visual direction, as you see in the picture. And anomalous retinal correspondence, or ARC, where the fovea of one eye will be corresponding to an extrafoveal point of the other eye. This usually occurs when there is a small angle manifest squint. So those are normal retinal correspondence and anomalous retinal correspondence. And what is diplopia and confusion? Diplopia occurs when non-corresponding retinal areas, as you can see in the picture, the fovea of the left eye and an extrafoveal point on the right eye is being stimulated by the same object. So this is stimulating the right fovea, left fovea and an extrafoveal point on the right eye. So this right eye extrafoveal point has got another visual direction. So that will be seen as the same object will be seen as double, that is diplopia. In confusion, it is corresponding retinal areas are stimulated by two different objects. The left fovea is stimulated by the circle, the right fovea by the triangle. Both are having a same primary visual direction. The patient will be seeing both circle and the triangle. So he will be confused which one he is seeing. So this is again of diplopia, extra non-corresponding retinal areas being stimulated by the same object. Now, this is always difficult to patient. Both confusion and diplopia are difficult for the patient. So there will be an active inhibitory mechanism where the image of one eye will be temporarily inhibited. To avoid confusion, one fovea will be inhibited, and to avoid diplopia, the extrafoveal point will be suppressed. So that is suppression. Now coming to the proper binocular single vision test, the aim of which is to assess the presence or absence of normal retinal correspondence or ARC, suppression, simultaneous perception, fusion, and stereopsis. I hope all of you have understood what are all these terminologies. Now these are the binocular single vision tests, various tests what you have, which is commonly used, Burke-Fodot, Begolny, Redfield after image, 4 prism diopter base out test, stereo acuity. I will go through the simpler ones which is commonly used in this limited period of time, and these are the stereo acuity tests which are available. We'll go through each of it. Now before doing a binocular single vision, it's always mandatory to check the visual acuity of the patient, because a reasonably good vision in both eyes is required to have a proper binocular single vision. Always assess the fixation in the squinting eye and the direction and size of deviation also. Now coming to the Burke-Fodot test, this is a commonly used dissociation test which can be used for both distance and near fixation. It helps to differentiate BSV, anomalous correspondence, and suppression. The procedure is the patient wears a red-green goggle, and by convention, red before the right and green before the left, and the patient views a box of light with four lights, 2 red, 1 green, and 1 will be white light. So the results how it is interpreted are, if the patient sees all the 4 lights, if the patient is says he is seeing all the 4 lights, red, 2 green, and the white, which is a mixture of red and green, that means the patient is having binocular single vision, provided he doesn't have any squint. If the patient says he is seeing the 4 lights, but he has a small manifest deviation, then that is anomalous retinal correspondence. If the patient sees 2 red lights alone, that means he's not seeing with his left eye. So he's having a left suppression. Seeing 3 green lights, then it is right suppression. Suppose a patient says he sees 3 green lights and 2 red lights, that means he's seeing with both eyes but separately. So that is diplopia. And some patients may tell alternately they are seeing the green lights, and then sometime they are seeing the red light. That means the patient is having alternate suppression. In case this occurs in cases when they are wide angle squints with which is freely alternating. Coming to the Begolini striated glasses, which again helps to differentiate VSV, ARC, and suppression. And the Begolini glasses has got two lenses. Each lens has got fine striations, which will convert a point source of light into an oblique line. And the lens is placed as 45 degree and 135 degree in front of each eye. And the patient is asked to fixate at a small light source. Each eye will perceive an oblique line of light, which is perpendicular to either eye. So if this eye sees an oblique line and the left eye will be seeing a perpendicular oblique line. And how will you interpret the results of the test? If the patient says he sees two streaks as an oblique cross, that means the patient is having binocular single vision, provided he doesn't have any squint. If he's seeing the cross in the presence of a small angle squint, that means he's having anomalous retinal correspondence. If the patient sees a cross with a small gap in between, there's a small gap in between in one oblique line, then the patient is having microtropia. The patient, if he says he's seeing two lines but not as a cross, seeing two lines but not as a cross, that means it is diplopia. And if the patient sees only one line, it is either left suppression or right suppression, depending upon the direction of the line. So that is Begolini's test. We'll go to the stereo acuity test, which Sir wanted me to speak more of it. Synoptophore, I think it will not be possible to cover it in this 10 minutes. So I'll go through the other test. The TNO test, which uses the red-green goggles for dissociation. The Randot and the Titmus fly stereo test, which use Polaroid spectacles. And the Lange stereo test and Frisbee test, where no dissociation glasses are used. The Lange stereo test, no haploscopic glasses are used. So the advantage of this is that the eye movements of the patient can be better observed by the examiner. Especially this is useful in pre-verbal children. And the dissociation without this haploscopic glasses is ensured by half cylindrical lens laminated on the surface of the test plate, which make only one image visible to either eye and which can be fused together to create a three-dimensional vision, provided the patient has got binocular single vision. Now, these are the Lange test plates. You have the Lange stereo test 1 and Lange stereo test 2. In 1, you have 3 objects visible, a car, a cat, and the star. Depending upon which the patient is, only patients with BSV will identify this. So depending upon which image the patient is identifying, the stereo acuity can be graded from 1,200 to 550. Actually, patient with 550 has got a better stereo acuity. In Lange stereo test 1, you have 4 objects, a moon, a car or truck, an elephant, and a star. And the star will be visible to all patients, even with monocular vision. Those without binocular vision will also see the star, but only patients with proper binocular single vision, depending upon what is the grade as it is given here, they will see all the other pictures. The Titmus stereo acuity test uses the Polaroid spectacles, and it is a near stereo acuity test which is done at 40 centimeters. Actually, you have to measure the distance 40 centimeters and keep the test plate there. And this is a test plate, what you see. On the right side of the test plate, you have a fly, the picture of a fly. You should ask the patient to pinch on the wing of the fly. That is what you ask the patient. Some patients may either pinch it on the surface and some may pinch it in the air slightly away from the plate. So if the patient is pinching it in the air at a distance from the plate, that means he has got a gross stereopsis of 3,500 seconds of an hour. Suppose he is pinching it on the surface of the plate, that means he doesn't have any stereopsis. Now you check for other grades of single binocular vision for the patient. You ask the patient to say whether any letter is visible at the bottom. If the patient says he's seeing the L, that means he's having right suppression. If he says he's seeing R, that means it is left suppression. If he sees both, that means he doesn't have stereopsis because he was pinching on the surface of the plate, but he has fusion. Now, after this, if the patient has some amount of stereopsis, you go to the left side of the test plate, which has got circles, which are called the word circles, and these word circles There are 9 sets of circles, and each set will be having 4 circles, and one of the circle will be projecting forwards towards the patient. You ask the patient to touch on the circle which is projecting out, and it then test the range of stereo. Suppose a patient, ranges from 800 here to last test plate will be 40 seconds of an hour. Suppose one patient is telling that he can identify the circles projecting out up to the 5th one, that means then his stereo acuity is 100 seconds of an hour. In children, you can use the lower one, which is the animal test. You ask the child to touch on the animal which is projecting towards him, and depending upon that, the range of stereo acuity from 400 to 100 seconds of an hour can be found out. In random stereo acuity test, which is again using Polaroid spectacles and done at 40 centimeters, again a near stereo acuity test. Here you use Julius random dot background, which shows geometric figures like square, circles, triangle, and star, etc. These are devoid of monocular clues, unlike the animal and word circles. And the range of acuity tested here is between 500 to 20 seconds of an hour. These are the geometric figures, what you get in the chart. And this is the stereo test, random stereo test chart, what you're seeing. In TNO test, you use the red-green goggles for dissociation. This is the red-green goggle. Here again, you use the geometrical figures, and the range of acuity tested is between 480 to 15 seconds of an hour. In the Frisbee stereo test, you are again not using any haploscopic glasses. Here you have 3 sets of plates of varying thickness, that is 6 millimeter, 3 millimeter, and 1.5 millimeter. Each plate has got 4 squares. Each plate has 4 squares, and of this, 3 squares have got random pattern of blue triangles. And in the 4th plate, there will be a circular area which is devoid of these random pattern. So in that area, suppose you have a plate here in the central, one square has got a circular area which is devoid of the plate. On the other face of the that plate, you have this corresponding to that circular area. You have these pattern put over there, and the plate is held.
Please wind up the idea.
Okay, sir. 2 more minutes. The plate is held in front of the whiteboard, and the patient with stereo acuity will see the circle projecting out. And altering the thickness and distance of plate from the subject can assess different stereo acuities. So the patient viewing it from 30 seconds, if he is viewing the 6 millimeter plate, it is 600, 3 millimeter, 300, 1.5, and the range of acuity tested is from 600 to 20. Now the recording of stereo acuity, whether it is for near or distance, if it is without correction, it is SC, with correction, it is CC, and it is seconds of an hour for the last correct response for 2 consecutive incorrect responses. For the circles, if the patient was seeing the 5th one, it is 100 seconds of an hour. If the patient doesn't identify any target, it is no stereopsis, and always record the name of the test. For example, stereo at near without correction, 60 seconds of an hour, and TNO test is used. The smaller the stereo acuity value, better is the stereopsis of the patient. With 100 and 600, 100 patient will be having better stereo acuity, and the normal value is 40 seconds, which may go even up to 15 seconds in some patients. And the refractive correction should always be worn by the patient. The room light should be goodly illuminated. Always instruct the patient what to do and allow sufficient time to perceive. Do not touch the test plate, which may manipulate it. And the patient without deviation, always, if they have no stereo acuity, suspect micropropia. And you perform at least 2 stereo acuity tests for better interpretation of your patient. So the take-home message is, binocular single vision anomalies are common and it can affect any age. It is mostly considered to be an anomaly and not a pathology. Even though it is not sight-threatening, it can affect the quality of life of the patient, including scholastic performance and even the daily routine activities. Always when and whom to do the BSV test has to be chosen of. Do a comprehensive ocular examination with history, refraction completely, and check accommodation and convergence before you take the patient for your binocular single vision test. Thank you.
Thank you, Dr. Dahlia. Nicely presented the binocular single vision. I know it is a difficult topic to explain. So, sorry, I think the Simon is ready.
Yes.
Okay, you can start. We're talking on trial set and trial frame.
Good morning. Can you hear me?
Yes, Dr. Simon is
Found answer that.
Only
I'm sorry
ophthalmic
for the delay. I'm sorry for the delay. It was raining out here. The internet got cut, and I thank KSOS for this opportunity. Now we have been listening to your ophthalmology for the last 2 hours. So I'll start with a photo to test your general knowledge. In this photo, you can see late Pranab Mukherjee, who passed away just 1 week back. You will see him holding a briefcase. This photo was taken when he was a finance minister in 2010. What do you think this briefcase contains? Is it money? No. This is a finance minister with the budget documents, which will be trying to improve our nation's economy. Now I'll show you another photo. You are seeing an ophthalmologist with another briefcase. Does it contain money? No. It contains, it's what's called a trial set or a box. It's also known as trial box or a trial case, which is used to try to improve the patient's vision. Now suppose you open this box. What will you see? You will see numerous trial lenses, both concave and convex. You will see prisms, and you will see some accessories, which are the trial frame. You will see other accessories, which I'll cover in the next few slides. So let's now go to each one. We'll talk about lens. Before I talk, any trial lens can be of two types. One is reduced aperture lenses, where the diameter of the lens part is around 20 millimeters, and it is mounted in a metal or plastic rim, making the total diameter 38 millimeters. Now, there's another type of trial lens, which is called a full aperture lens. Here, the whole diameter of the lens is 38 millimeters, and the rim is very thin. This is the type of trial lens which was seen in the old trial sets, but the present trial sets, most of them have reduced aperture lenses. The full aperture lenses are slightly heavy, but they will allow you, the whole lens to be used for refraction. Here, the central part contains a lens, and there's a rim which obscures the peripheral part of the field. But still, this is what is usually used in most of our trial sets. Now, each spherical lens has got the power which is same in all meridians. And there are around 32 pairs of spherical lenses in each trial set. Each spherical lens will have a handle for the doctor to hold and place inside a trial frame. You have got plus lenses, which are known as convex lenses because they converge light. And we have got minus lenses, which are called concave lenses because they diverge light. And the power ranges from plus or minus 0.12 diopters to plus or minus 20 diopters. Now the variation is actually graded from 0.25 to 4 diopters. The increments in the trial lenses are 0.25 diopters, while from 4 to 6, it is an increment of 0.5 diopters. From 6 to 14, increment of 1 diopter, and from 14 to 20, the increments is of 2 diopters. That is, in high powers, you get increments like 14, 16, 18, 20. While for lower powers, you can get 4.5, 5, 5.5, etc. Okay. Now, where are the lenses placed? If you open the trial set, the lenses which you see here in the left side, I have marked it a red circle, are the concave lenses. And these lenses have either a red color or a golden color rim. These lenses, because they are concave lenses, they are thinner in the center and they are thicker in the periphery. And when you look through it, the images which you see through look smaller and further away. And these are lenses which are used for myopia correction. Okay. Now, if you look at the right side of your trial set, you will see another set of lenses which have a silver or black rim. They are thicker in the center and the images look larger and closer. And these lenses are the ones which are used for treating hypermetropia. Okay, so these are the two main types of spherical lenses which are present inside a trial set. Now coming to the next type of lenses, these are known as cylindrical lenses, and these are the lenses which are present in the central part of the trial set, which I have circled with a red circle. 90 degrees or at 180 degrees or some specific axis. It is not, the power is not seen in all meridians. This is the difference between a cylindrical lens and a spherical lens. And the axis where the power lies in is marked on the rim of the lens. You can see there's a line here, there's a the line which is there on the rim of the lens will help you to know which is the axis in which the power acts. There are 19 pairs of cylindrical lenses, both plus and minus, and their power ranges from plus or minus 0.25 diopters to plus or minus 6 diopters. So up to 6 diopters is only present in a trial set. And the variation from 0.25 to 3.5 diopters, the increment is 0.25 diopters, while from 3.5 to 6 diopters, the increment in the different lenses is 0.5 diopters. Okay, so you will get 3.5, 4, 4.5, etc. While here you get shorter increments, 0.25, 0.5, 0.75, etc. And these lenses are the ones used to correct astigmatism. From the examination point of view, any of these lenses can be put, and you will be asked to identify the lens. You look through the lens and see how the objects are seen. And you can also feel the lens, and you can say whether it's a spherical lens, concave, convex, or whether it's a cylindrical lens. Now let's go to the prisms. Where are the prisms seen in the trial set? The prisms are seen in the left side, but towards the end, okay, towards where it folds up. Okay, this area which is marked with the red circle shows the places where the prisms are placed. What is a prism? A prism is a refractive media where you've got two plane surfaces which are inclined at an angle. Okay, and so you will have an apex and a base for any prism. And the power range which is present in the trial set is you have got a 0.5 diopter prism, then you've got 1 to 6 diopters in 1 diopter steps, and 6 to 12 diopters in 2 diopter steps. And what is these prisms used for? It is used to correct and measure the squint or the angle of deviation of the visual axis. Okay. Now coming to the accessories, there are numerous accessories which may be seen in the trial set. These accessories are seen in the right-hand corner. Okay, so the prisms are seen in the left-hand corner, while in the right-hand corner near the fold is where you get all these accessories. You have got planar lenses, and all these accessories. I just give one sentence each in the next few slides. So let's go to the accessories. What is a planar lens? The power of the lens is 0. These lenses help you to test for malingering. See, when your patient comes with defective vision, and when you test, you think that he's malingering or just telling the complaint just to get some sympathy, you will put this lens and then see whether he says his vision has suddenly improved. You know that the power is 0, but the patient doesn't know that the power is 0. And if his vision improves with a 0 power lens, then you have to consider malingering as one of the possible diagnoses in this patient. So this lens is used for that purpose. Now, what is an occluder? Occluder is an opaque one is being tortured. And so the occluder will help you to close one eye while the other eye is being tested. It will also help the eye which is closed, the accommodation becomes relaxed, and you can also dissociate fusion when you put an occluder. Now coming to the pinhole, this is sometimes asked in your viva during the examination. A pinhole is an opaque disc with a small hole in the center, which is roughly 1 millimeter in diameter. This small hole allows only the central light ray to pass through it. And so the peripheral rays of light are cut off, and only the central rays will fall directly onto the retina without any change in its pathway. So it will help you to determine whether the defective vision which the patient has is due to a refractive error or due to some pathological cause like cataract, etc. For example, I have to explain. See, suppose a patient has got defective vision due to cataract. When you put a pinhole, the vision doesn't improve when the patient looks through a pinhole. But suppose the patient has a refractive error like myopia. When you put a pinhole, when the patient looks through the small hole, the vision should improve. So you are able to differentiate between a refractive error or a pathologic error as a cause of defective vision. And this is also said to be used as a macular function test because the central lateral rays are falling on the macula. As Dr. Sunil mentioned, macula is the most sensitive part of your retina. Now coming to a synoptic slit, here instead of a hole, you get a slit, which is a 1 millimeter width and around 15 millimeters length. It allows only a strip of light to pass through it in one meridian. So it helps us to find out the axis of the cylinder, which is used in the treatment of astigmatism. And it's also used in a test called Finchham's test, which is used to differentiate the halos which are seen in corneal edema and in immature cataract. Okay. Now coming to red and green filters, as Dalia Madam has already mentioned, the red filter is put in front of the right eye, and green filter is put in front of the left eye. Okay, and this is used for color dissociation, and it is used to test binocular vision, to test for suppression, diplopia, and Madam has already mentioned these two tests. At least the word for dot test has already been mentioned by Dahlia Madam. Now coming to the Maddox rod, you see a series of red parallel cylindrical lenses which will convert a point source of light into a line image, and this is also used to test for any horizontal or vertical deviation in squint patients. Now coming to what's called a Jackson's cross cylinder, this will be covered in your afternoon session between 2 to 2:30 or 3:30. You have got a session just on refraction. The Jackson's cross cylinder will be explained in detail out there, but I just tell you the main things.
Please wind up.
Yes, sir. You have got two cylinders which are our same power but at 90 degrees to each other. And then there's a near vision chart where you have got different letters of different sizes and you test whether the near vision is correct or not. And you use it for refraction testing. You can use it in the hospital. You can take it to the camp because it's just like a briefcase. You can do squint evaluation. You can test binocular single vision, and you can do diplopia charting. Now the last part, the trial frame. This is the frame on which you put the different lenses while you test for the vision and rule out refractive errors. You can see there are two circles, and there is a frame with some knobs by which you can adjust the interpupillary distance and also the position of the nose rest. Here you can see the occluder has been put in front of one eye and the lens has been put in front of the other eye. Okay. Now it's usually lightweight, non-allergic, and you can adjust the distance between the interpupillary distance and also the nose position. There is a full aperture frame which is used for a full aperture type of lenses. There's a reduced aperture lens which is used for a reduced aperture lens, and you've got a half eye trial frame. Now the last slide. Now if you look at each frame, you will have a main frame which is connected to the ear, etc., which is marked with a red arrow. You can see the red arrow out here. Behind it there is one compartment where you can put lenses. Then just in front of it you have got the second compartment, and that is separated between the green arrow and the red one. The green arrow out here and the red one. And in front of it is marked by the blue arrow is a frame where you can get the axis is marked. You can see the 90 degrees marked here, 180 degrees marked here. And it is in this third compartment that you're going to put the cylindrical lenses. See, the spherical lenses are put in the second compartment, which is just in front of the main frame. And the cylindrical lenses are put just behind this frame where the markings are put. And in front of it, with the yellow color, I have marked another support where you have got the fourth compartment. So you can put all these accessories, high power lenses, etc., in either 4 or 1. 2, the second compartment is definitely used for only spherical lenses, while a third compartment is used for the cylindrical lenses. Thank you for your patient listening, and my best wishes to all the freshers for their academic life and future.
Thank you, Dr. Simon. Wonderful basic well explained. Now I invite Dr. Dahlia. Another topic that is.
Dr. Dahlia is already spoken. Dr. Sujata.
Ocular alignment.
Thank you, sir. May I start the presentation? Thank you.
Yes, yes, already late. Start.
Good morning. Thank you, KSOS, for including me in this program. My presentation is about ocular alignment tests, which are a group of basic tests to be done in all patients after visual acuity is assessed. Ocular alignment literally means that eyes are in the correct relative position. We say ocular alignment is present when visual axis of both eyes are aligned. And then what is this visual axis? It is a line connecting the fovea to the fixation point. And when a person looks at an object, the visual axis of both eyes usually meet at the point of fixation. And that is not happening in this patient, as the visual axis is misaligned. So this misalignment of visual axis is also called squint or strabismus. This patient has a ESO deviation or a convergent squint. So why is it necessary to look for the alignment test. It's very important in children. You can see the child with a significant ESO deviation getting corrected with appropriate refractive correction. In adults also, so neurological diseases like third nerve paralysis, myasthenia, thyroid eye disease, and trauma like blowout fracture is associated with ocular misalignment. There are 4 groups of tests for ocular alignment. They are the corneal light reflex test, cover test, dissimilar image test, and dissimilar target test. Of this, the first 2 are of importance, and that will be dealt in detail. Coming to corneal light reflex test, Hirschberg test, Bruckner test, modified Krinsky's test, and tests based on synaptophores can be used. And of this, Hirschberg test is the commonly used test for acute assessment of alignment, and it is useful in all who cannot cooperate for cover tests and also having poor central fixation. So here, patient is asked to look straight ahead. Light is thrown into the center of the forehead at the distance of about 50 centimeter. Now, the light reflects in both eyes. Sorry, the reflection of light in these both eyes are compared. Usually, they are usually central and symmetrical. But suppose it is displaced temporally, it means that eye is deviated in, or there is a convergent deviation. If it is displaced that's nasally, it means that there is a exodeviation. And similarly, it can be displaced superiorly or inferiorly in vertical deviations. This test can also be used to quantify the amount of deviation based on the assumption that 1 millimeter of decentration is equal to 7 degrees of deviation. So this is 15 degree isotropia, this is 45 degree isotropia, and so on. But though it's a very simple test, there are certain disadvantages. It's basically a subjective test, and it's also of no use in certain patients with pseudostrabismus, where there is an influence of angle kappa. So then what is this angle kappa? It is the angle between the visual axis and the pupillary axis. And usually, as the fovea is slightly temporally displaced, you get a nasal reflex. So usually you have about 4 degree of angle kappa. But sometimes this reflex can be displaced nasally or temporally. When it is displaced nasally, it is called a positive angle kappa, as seen in this patient with who had retinopathy of prematurity and dragged macula, having a very nasally displaced reflex. This simulates exodeviation. Similarly, if it is displaced temporally, as in case of high myopia, it will simulate an isodeviation. So in such cases, Hirschberg test is of not much use. The another light reflex test is of importance is Bruckner's reflex. That is especially very useful in young children, and it is performed by visualizing the red reflex in both eyes simultaneously after dilatation. And you can easily see that in the deviated eye, the light reflex is brighter and lighter. The Krinsky's test and tests based on synaptophore are basically used to more to measure the angle of deviation, and will be discussed in the orthoptic class in the next session, next Sunday. So moving on to the cover test. These are the most objective and accurate tests to demonstrate ocular misalignment. There are 3 types. They are the cover test, cover and cover test, and alternate cover test. There are certain prerequisites like central fixation. Patient should have good vision and reasonable range of ocular motility. So these are the things to be done before starting the test. And most important is proper covering of the eye and making sure that the other eye is looking always at the fixation target. These are the pictures of equipment, occluders, and
Dr. Sujata, you're muted.
She's not audible. She's not muted. She's not audible. Madam, can you check your connection?
moving out to take up fixation, indicating that it was previously in a convergent position. So, you know, there is a esotropia. Second part is that you remove the cover, still looking at the left eye. There are two possibilities. One is that eye will fixate centrally or suddenly go back into the deviated position. This child has exotropia. And when you cover right eye, you can see the eye going in to take up fixation. You are removing the cover, still the right eye is remaining central in fixation. So the test is repeated in left eye also, and the patient is having alternate divergent squint. Then cover uncover test is usually used to detect any latent deviation. Here your eyes is prevented by the property called fusion, and you are now covering the left eye. So fusion is broken, and suddenly you remove the cover, noting the position in the left eye itself. You will see that the eye has moved out to take up fixation, and indicating previously it was in a deviated position. And you will say that patient is having esophoria or latent deviation. And speed of recovery movement is very important. You can see in this patient, to start with, he's having straight eyes. But when you disrupt the fusion by covering, you can see exophoria being manifested. Note the manifest exophoria and speedy recovery movement in both eyes. Moving on to alternate cover test, it detects the maximum amount of misalignment, that is latent as well as the manifest component. Here you are switching the cover simultaneously, repeatedly between two eyes, and you are watching the movement. The aim is to maximally dissociate the eyes. So after this test, the patient will be either the aphoria may break into atropia, that is latent may manifest as manifest squint, or a manifest squint may increase in its amplitude. These are the test results we obtain after the cover test. Then other signs like latent nystagmus and incomitance also may be picked up. Moving on to dissimilar image test. It was mentioned before about the Maddox-Rod test and double Maddox-Rod test are the commonly used. It was previously told by Simon sir about Maddox-Rod. You get Maddox-Rod converts a point source of light into a line image. You can see it here. So patient fixates the light at 6 meters, Maddox-Rod in front of one eye, and this is what you get if there is no misalignment. And misalignment can be demonstrated easily like this in these two cases, and it is all used to measure phorias for distance. Double Maddox-Rod is similar to Maddox-Rod test, but here you have two Maddox-Rod, one is red and one is white, and if it is normal, you get the result as two lines will be parallel. If there is cyclodeviation, one red line will be inclined. Maddox wing test is actually not a dissimilar image test, it's a dissimilar target test. This is the instrument. When you look through the patient this is done at 33 centimeter. Patient looks through the right eye, sees a vertical and horizontal row of numbers indicating the amount of deviation. And left eye sees one vertical white arrow and a horizontal red arrow. This is basically used to measure deviation, that is heterophoria, that is latent deviation for near. Due to the shortage of time, I'm not going into dissimilar target tests. They are very rarely done, and only to assess complex case of strabismus. At this point, I would like to conclude by saying ocular misalignment in children, it should be detected very early. Hirschberg test may be used as a preliminary assessment of deviation, but if you want to report the presence or absence of a strabismus when you are asked for it, the objective method like cover tests are mandatory. Thank you.
Thank you, Dr. Sujata, for that very elaborate but nevertheless touching upon all the relevant ocular alignment tests. The next talk is by Dr. C.V. Anthreos. He will be talking on phoropter. So we're all familiar with Sir. He's currently the medical superintendent and professor and head of the Department of Ophthalmology at Jubilee Mission Medical College, Thrissur.
Dr. Nina, short of time, I will just touch what is phoropter. Sometimes Viva, they can ask what is phoropter. So when you go into the clinic, what do you see? Whether the clinic is clean, staff is polite, the instruments are sophisticated, is it computerized? So these are the appearance of the clinic, new clinic. So these are past. Dr. Simon has already covered the trial set, trial frame. So these are all old machines. So this is a new OPD, eye testing unit with the phoropter, with the autorefractometer, this chart projector, everything. So
you have started sharing your screen, sir?
It is not coming?
No.
Sorry.
Sir, go to the share screen. Yes, sir. Coming.
And now it's visible, sir.
So I will just touching what is phoropter. So they say Viva or exam, they may short answer what is phoropter. So this is a old type of clinic, whether the clinic is clean, whether staff is polite, whether instruments are sophisticated or computers. So it's the appearance of a clinic. So a patient will appreciate all these things. So this is the old clinic. Dr. Simon has already covered what is trial set, trial frame, or the lensometer, all these things. These are the ancient or old type of clinic. We are all practicing like this. But see, this is the appearance of a new clinic with all the phoropter, this lensometer, projector, everything. So this is the latest clinic. So what is phoropter? It is an ophthalmic device designed to provide a convenient way of placing lenses in front of the patient's eye to measure the refractive status like subjective refraction, phoreas, ductions, astigmatism using Jackson cross cylinder, etc. So history of phoropter, it is discovered by Saigon in 1917. It was called a optometer or phoro sky optometer, etc. Now there's a manual phoropter and digital phoropter is available. So what are the components of a phoropter? It's a battery of spherical and cylindrical lenses, Mardos rod, Mardos wing, filtered lenses, Presley prisms, Jackson cross cylinder for astigmatism. These are the components of a phoropter. So definitely you have to change from the old trial set into a phoropter, because especially in the COVID era, there's no need of going close to the patient. So you can have a social distance of more than 1 meter or 2 meter. So patient will be very much impressed. It is an instrument with the unique design lens holder, allows the to test the lenses easily and efficiently. There's no need of wiping the lens, dropping the lens, or misalignment of the frame, nothing will be there. So there's a two type of phoropter. One is a manual phoropter. Second, modern latest is the automated phoropter. So what are parts of a manual phoropter? There's a number of knobs for adjustment for spherical cylinder, axis, etc. So at least 4 knobs are very important. One is for spherical lenses. Second is for cylinder lenses. Third one is for the cylinder axis of power, etc. So these are different knobs available on the phoropter. You can rotate and you can adjust the things. The procedure, the patient should be sit behind the phoropter, look through the chart at a distance of 20 feet for distance and for 6 inches for near vision. Then the optometrist is then change the lenses and other settings by rotating the knobs while asking the patient for subjective feedback on which setting gave the best vision. So they can rotate. There's no need of changing the lens. Automatically, the lens will come and by rotating the knobs. So then there's a modern automated phoropter. This is the things, there's no need of rotating. Everything is a remote control or finger touch. You can control everything. So that is advantage of automated phoropter. One button to start the test, then contains memory system or data can be saved and you can take a printout, prescription printout can be taken easily. You can also measure the phoreas, ductions, IPD, convergence, stereopsis, and all the refractive errors like myopia, hypermetropia, astigmatism, etc. So now they came the digital phoropter. Along the phoropter, you can connect to the auto refractometer, the auto reading, you can incorporate into it. You can test all the spectacle patient has brought. You can have a lensometer reading and be incorporated. There's a control unit. It can be connected to the printer. You can take the final printout, and it can be connected to the network also. So you can send to your wife or relatives or to the optical shop. Everything is now available. Now, along with phoropter, you should have to use a chart projector also. So that you can, main advantage is the distance you can adjust. Instead of 6 meters, you can have 4 to 8 meters distance can be adjusted. You can have color vision testing. And digital auto chart projector is available. So color vision, all this testing is possible. And with a remote control, you can control everything. There's no need of going to the patient or rotating the drum or anything. Now, the latest phoropter available is mainly by the research company. There's quite expensive, but all these machines are available, German company. Then the Marco company, American company is also, this is the machines available. And now Illuminator phoropter is also available. So even the dark light also, you can do the things. So main advantage, I told you, it is more comfortable for the patient and technician. Lens will not be scratched or dirty. And data can be saved and stored, and printout can be taken. And disadvantage, it is mainly a subjective response you are taking, mainly for subjective refractometry mainly. And the machine will hide the face of the patient, and the machine is little expensive. And Simon has told that a box, you can do a trial set, you can carry, but this phoropter you cannot carry, it is not portable. And there's a restricted field of vision also. So definitely you have changed for the ancient, this trial set. Sorry to Simon, but you have to go to the new technique of phoropter. So now it is called introducing digital eye examination. All these gadgets are available. You can digitalize your clinic. And this is a modern eye clinic or your consultation room. And when the patient enter into the room, they will say, wow, so that's the effect of this phoropter and all these gadgets. So definitely they will pay you more. Instead of 200 rupees, they may get 300 rupees. So all my younger ophthalmos going to be in future, they can have all these digital eye examination unit. So thank you very much. This is only a positive phoropter what is available in the market. So thank you very much for patient hearing.
Sir, that session was very fantastic, sir, and your talk was marvelous, digitalizing everything. For want of time, we'll be behind about 12 minutes. We'll move on to the next session. I request Mini Madam to invite the other next
We'll move on to the next session on slit lamp examination. Dr. Freddie Simon will be the chairperson and Dr. Sija will be the moderator of the session.
Thank you, Raju.
Thank you, sir.
Welcome to the slit lamp session. We're running a bit late, so I think I'll start. We have 3 topics on the slit lamp. One is the basics of slit lamp, the examination, and the drawings, anti-segment drawings. So I want to thank the KSOS for giving me this opportunity. I'll start with the first topic, which is the basics of slit lamp examination. So my talk will go through a bit of the history of slit lamp examination, the types, the history of slit lamp, the types of slit lamp, and the parts of the slit lamp. The slit lamp is basically an illuminated microscope where we can examine the anterior segment, even the posterior segment, stereoscopically. The history of the slit lamp, though Gullstrand is credited with the invention of the slit lamp, a lot of people who came before him who played their own role. So Perkinjean, early as 1920s, he used an illuminated microscope to examine the iris. Then Louis de Wecker actually created an instrument, a portable instrument, which is a uniocular instrument to examine the anterior segment of the eye. Well, it was in 1891 that Albert and Greenough created the first binocular microscope with a stereoscopic view. And Zabsky in 1897 created the binocular microscope, which looks similar to the slit lamp we use now. Well, in 1911, Albert Gullstrand introduced the illuminating system, and for the first time, they had a slit diaphragm. So he is credited with the invention of the slit lamp. And just a point of note that Gullstrand is still the only ophthalmologist to win a Nobel Prize. What are the types of slit lamp? There are basically 2 types, depending on the illumination, where the illumination comes from. One is the Hack Street model, where the illumination comes from the top. And second is the Zeiss model, where the illumination comes from the side. This Zeiss model is a more compact type of slit lamp, but the Hack Street model has advantage that the illumination arm can be tilted. This is the knob which we use to tilt it, the lever which we use to tilt it. The advantage of tilting the illumination arm is because when we do a mirror examination, like a gonioscopy or a 3-mirror examination, we can reduce the glare. What are the parts of the slit lamp? Basically divided into 3 parts. One is the illumination system, one is the observation system, and the mechanical system which holds both of these together. So this is the illumination system, which has a housing for the bulb. It has a measurement system. It has different filters and a handle to rotate the measuring system. Illumination, what we call is a Kohler type of illumination, where the light source goes through a condensing lens, goes through a slit and various filters, and goes through a projecting lens into the mirror. From the mirror, it is projected into the eye. The peculiarity of this system is the light source is focused into the projection lens, and the slit is focused onto the eye. So this is the light source, which can be a halogen lamp or a LED lamp these days, a condenser lens. Then it has the slit system, then passes through various filters which you can choose, goes through a projection lens, and then into the mirror, into the patient's eye. Well, you can use the scale to measure any lesions on the cornea, where you can measure it vertically, and this is the knob which you use to turn the scale. And you can measure it, you can change the slit to measure it horizontally or obliquely. Well, there are a lot of filters here, and you can choose what filters which are used. We all know about the cobalt blue filter, which we use for the fluorescein dye. There's the red-free filter which we use to see the blood vessels and hemorrhage and scleritis. Natural neutral density filter, which is marked with hashed lines to decrease the brightness to make it more comfortable for the patient. Then you have a gray filter marked by a thick line, which again reduces the illumination for the patient. Yellow filter is not present in all slit lamps, but it's usually in the observation system, supposed to enhance the fluorescein staining. And then you have a diffuser. This is a diffuser, which is usually kept in front of the mirror, so that you get a diffuse illumination to examine the eye. The width of the slit can be adjusted by this knob in the Hack Street model, and you can get it to different width sizes you want for different types of illumination. Well, the observation system. The observation system is basically a binocular microscope. It has an eyepiece, it has a prism housing, and it has a magnification and objective lens. But look at the magnification. Basically, there are 2 types of magnification, the Greenough type and the Galilean type. The Greenough type is just a flip magnification. You get only 2 magnifications, 1x or 1.6x. It just changes the objective lens. While the Galilean microscope uses a convex and a concave lens, a combination of the 2, and generally you get around 5-step magnification. Another way you can change the magnification of slit lamp is by changing the eyepiece. Certain slit lamp manufacturers give you 2 sets of eyepieces, where you can change it either to 10x or 12x eyepiece, and you can get more magnification. Well, there is, in the eyepieces, you can adjust the eyepieces according to your refractive error, either plus or minus, or if you're using glasses, you can leave it at 0. And you can adjust the IPD by just moving the eyepieces around. Well, this is the optics of the observation system. This is the object or the eye. It passes through an objective lens. Then it passes through the magnification system. In this case, the Galilean telescope is shown. Then it passes through a prism system called the Poro-Ab prism system. What this does is, 1, reduces the size of the observation system. Second, it turns the image upright. Otherwise, we'll be seeing an inverted image. And then you have the eyepiece. Then we go to the third part of the slit lamp. It's called the mechanical system. This consists of different parts. One's the forehead band, where you want the patient to oppose his forehead to. You have a canthal alignment, where the lateral canthals are aligned, so you can move the slit lamp and you can examine the eye. Then you have a chin rest. You have a hand grip for the patients. You have a lock if you want to lock the slit lamp. You have a lock if you want to lock the observation system and the illumination system together. You have a joystick to move the slit lamp front or back or up or down. You have a pass switch. You have the rheostat, which can adjust the illumination. You have a chin adjustment knob to adjust the height of the chin rest. And you have a fixation target. And you should understand both the observation and illumination system are coupled. That means both are focused to one point. This is important to know. For some illumination, we might have to decouple. And both rotate around a common axis, both the observation system and the illumination system. They can be rotated together or separately. And sometimes in some illumination, we have to decouple the system. That means we have to take the light away from the focus. And this is the knob to decouple the system. You just loosen this knob and twist this illumination system and decouple. With the slit lamp, we use a lot of accessories. I won't go into the details, just mention them. You can have a camera system. You can have a side tube. The observer can watch, use different types of mirrors and lenses. And you use the approximation tonometry. So to conclude, the slit lamp is a simple but important instrument for any ophthalmologist. And it is essential that every student has good knowledge of the working and the various parts of the slit lamp. Thank you. Okay, we'll go to the next session. Next.
Hello.
Dr. Sija, you're not audible. Okay, anyway, Dr. Freddy, it was a fantastic
segment examination.
You can introduce the next speaker.
Thank you.
It's okay, Dr. Freddy, you can introduce. She's finding it a little difficult. Otherwise, I'll introduce. We have the next speaker.
Okay.
Dr. Azim from Brunei, a very good friend of mine, is going to present on the anterior segment examination using a slit lamp. Over to you, Dr. Azim, my dear friend.
Hi. Hello, everyone. Hi, PGs. How are you? Congrats for getting into ophthalmology. It's an exciting, wonderful, and a challenging field. I'm sure you'll never regret getting into ophthalmology for sure. So today's discussion is going to be a practical topic, a topic on equipment you're going to use day in and day out in your field. I'd probably call it a breadwinner in ophthalmology. A good slit lamp can actually pick up a lot of many diseases. Many of them very subtle. It can be picked up much early in the course of the disease. So all it needs is some tips and tricks, how you can pick up some subtle findings and how we can do a good slit lamp examination. So today we're going to see something about it. And we're going to see something about a cool topic. So just sit back, chill out, relax, and then enjoy the talk. However, remember, I'm going to give you some tips and some questions hidden in this for exam questions hidden in this talk. So do pay attention to make sure you catch all those questions. Okay. So let's go into the talk itself. My window's narrowed. I can't see my view full screen.
You'll go to the top slideshow.
Top slideshow hidden by the bar.
I can see it from here.
Yeah, okay. Maybe I've got a bar blocking it. Okay, no worries. Didn't get it out.
From the beginning,
Yep.
Go to the left.
No, it's actually gone into the.
Do one thing. Give me the remote control. You just allow me to control you.
Yep.
I've done it. You've allowed it?
Just a minute. All this has gone into the Windows mode.
Yep. Suraj,
Yep.
You can allow me.
Yep, I'm just doing it right away. Hold on.
You got it? Just say yes. When I send you a message, you just say okay. Did you get my message?
Yes. Yep, done. I've got these pop-up boxes blocking my view. Thanks, Dr. Rajiv. Thank you, so kind of you.
Yeah.
Thanks.
You can continue.
All right, so now here we go. Okay, so I thank the esteemed faculty of the KSOS, Madam Meena Chakravarti, Dr. Mahesh and Dr. Rajiv Sukumaran for giving me a chance to be here. And of course, I would like to thank Dr. Freddie Simon and Dr. Sija for the same opportunity as well. So I start with paying respects to my teachers, but for whom you wouldn't be what you're here. So as postgraduates, please remember that you should always remember and respect your teachers. And when you become teachers, make sure you carry on the good information and the good work your teachers are doing now. All of them are spending a good Sunday for you. And you know, when you start practice, how valuable a Sunday is. So I have no financial disclosures. I acknowledge all the sources of internet information which are used for purpose of teaching only. And it's not an exhaustive review, but it's just to kindle a kind interest in the subject. So this is how I plan to go through it. Some basics, some types of examination theories, some special situations and procedures that could be done in a slit lamp. And also, we can also talk about do's and don'ts and how to take care of a slit lamp. And that's very important as well. So a slit lamp for an ophthalmologist is like a stethoscope to a physician. So it's of three parts, which has been well covered, which is of the optical system, the illumination system, and it derives its name from the slit lamp by a microscope, which means the lamp is here, which creates a slit and viewed by a microscope. It's by Gulstrand who introduced the slit concept, and it's really evolved from the primitive stages to what it is now. So we have the basic model, we have the photo slit lamps, we have the portable slit lamps. We do have accessories which are there, which can be used with the slit lamp as well. Lasers can also be used with the slit lamp. And it's basically three components: the structural one, the illumination one, and the observation. So in the examination, they ask you about the function of the slit lamp. This is how you have to talk about. And similarly, when they talk about each setting they use in a slit lamp, remember to include A, B, and C for each of this particular view you're going to talk about. So it has the structure and the three parts: illumination and the observation. The structure is made of the forehead band, where the patient rests the forehead, the chin rest, where the patient keeps the chin, the adjustable height, the hand grip for the patient, the fixation light, where the patient looks at, and the joystick controller to move the slit lamp, and also the lock for the slit lamp. And when you have this is the joystick which moves in different directions: right, left, top, and bottom. And also we have the canthal marker here, where it's important that the patient align the lateral canthus with this for you to get a proper view. It's important to make sure the forehead is pressed well and the chin is pressed well. And this position makes your life very easy. This is a common mistake people do when they're learning the slit lamp. Make sure the patient is seated in this position before you start. Your life will be really easy. Similarly, we have a top light illumination system and a bottom light illumination system. The rheostat and the switches are the one which is important, which starts the light. We do have the light source. We have the display in millimeters to indicate the length of the light. We have the different filters, height adjustment knob, and the swivel, which will swing the light horizontal, vertical also. So when you have the filters, we have different kinds of filters available. This is an overview of the different types of filters which you should remember in the examination. We'll just see a few of them as we go through. So cobalt blue is a filter which is used to illuminate when you use a dye called fluorescein. And this picks up in a contrast areas which are denuded in the cornea. We do have neutral density filters. For example, here, if you see the light is flooded, when you use this filter, subtle changes like the vessels can be picked up better. So neutral density is used to decrease the amount of light so the patient is comfortable and also pick up subtle changes. The reflecting mirrors are the ones which direct the light from the lamp into the patient's eye. They have two types, the bottom and the top. A point of note, the top one has a front coated mirror. Unlike the mirrors in your house, this mirror is coated in front, so which means you're going to wipe this mirror every day. You're going to take out the coating. So remember, if it's dust, you should blow it. We should not wipe it with a rough cloth. We have a column tilt function. What it means is the light is usually vertical. You can also tilt it so that we can see different deeper areas of the eye, like the fundus examination, which will be dealt with a bit later. So when you tilt the stick lamp, it tilts this way. Remember, this is possible only in the top illuminating light system model. How you do it? You've got a small knob here and a knob here, and this knob is released. When the knob is released, it shifts off axis. In addition, we have a knob here which tilts it on the oblique axis, which is used in special circumstances, which you'll see later. The third component being the observation system is the binocular system, where you see with both eyes to see a single vision. You have the magnification factor here, and this is very important as well. You should always remember to make sure either your refractive error is corrected on the eyepiece. It could be different in each eye, or you connect it to 0, and then you can focus with your joystick. This is another common tip which is important for beginners. Magnification system. Why do you need a magnification system? You see the eye from here. It can slowly magnify based on the extent of the magnification factor used for deeper evaluation of a particular tissue. So let's recap what we have learned. We have learned it has structure, illumination, observation. Structure has an objectival frame, the framework, and the chin rest. Remember the alignment part. Illumination has the light, the rheostat, the different filters, vertical height, horizontal height, oblique height, tilting. And the observation system, which has a binocular system, remember you should make it 0, 0, align the interpupil distance, and get the magnification to the minimum before you start, so you get a broader perspective. Now that we know how the basics are, let's go slightly forwards. Before you start, remember to clean with alcohol wipes. Make sure the instrument is clean between patients. Make sure your seat is comfortable. Patient's seat is comfortable. A small tip, try to avoid using chairs with wheels for the patient chair, because there have been instances, especially obese patient, when they try to sit down, the wheel tends to move. So it's better to have a chair which is fixed. Chin rest paper ideally change between patients. Barrier precautions because of COVID. You have to use barrier to make sure you're safe. That's very important. The illumination system, remember to check the filters, make sure it's not in the wrong filter. Beam specs to keep it minimum, and start with the lowest illumination. It's like starting a car. Keep it in the lowest illumination before you do. Observation, get into 0, 0, adjust the interpupil distance, and keep it at the low mag before you start. Once you do this, you're ready to get started. Barrier is important. Remember, barrier precautions are very recommended for protection, especially in this season. It can also be continued later for your own safety. Positioning, ideally sit seated so that you don't couch behind. The patient is also comfortable. You're also comfortable. Remember your patient's canthal angle, as I mentioned earlier, the forehead and the chin to be aligned. This is very important for you to have an enjoyable slit lamp experience. The rheostat starts the engine, and then there it goes, and you have all the settings which I told you earlier. Always remember to get the beam away from the eye. Don't keep it on the eye. Keep it full light, then start it in wide go. Patient gets startled. Before you start again, remember your hand. Okay, one hand is on the joystick, one hand is on the light. So that if you are used to the stick lamp, you're not supposed to take out your head, look where the settings are and go. It's like driving your car. When you drive your car, you know where your gear is. You don't look for your gear every time you change your gear. Like that, if you're used to a stick lamp, you know where the settings are. One hand, whichever depend on your dominant hand, one hand is on the joystick, one hand on the illumination, which will tilt the beam, at the same time adjust the width also. Okay, look here, one hand on the joystick, one hand on the illumination. And when using special lenses for retinal examination, which they'll explain later, you have to hold it in this way. Remember that you should support your elbow so you don't have pain here. Otherwise, at the end of the day, you lose a lot of slit lamp, you go home and you say, I'm tired, I get pain here. That means your ergonomics is wrong. Get your ergonomics right. That's very important. Learn it from the beginning. So now that you know what to do, how it is done, you see what are the types of visualizations you can do. So we have direct types of visualizations and indirect ways of it. Direct is just where you actually look. Indirect is you put the light somewhere and you look somewhere else. Let's see one by one. When they ask you in the examination, different types of illumination, this is a common structure you can use. When is it used? When you have to use in clinical situations, what is the light source and filter? What is the angle you have to keep it? What magnifications? Special precautions. The tip is, even if you don't know anything, you just remember this very well and write it down. You can fill up something, you still get some marks. It's a shortcut anyway. Okay, so diffuse illumination. How does it work? It's like a torchlight. If you want a torchlight to see the eye, this exactly is diffuse illumination. This is a view from the top. This is how I placed it. If you view from the top, this is where your eyepiece and head is going to be. This is where your light is going to be. If I keep the light here, that means your left hand is holding the illumination, the right is holding the joystick. That's what it means. If the light is on the right side, your right hand is going the light and the left is going the joystick. Make sure you're ambidextrous. It'll be helpful when you're doing your physics later. Okay, so this is diffuse illumination for you. Right, so why is it used? To get an overall impression of the eye. Clinical situations, you just see the lids, adnexia, whatever's on front, whatever's externally you want to see, that's what you use it for. Light, white light or yellow light, preferably a diffuse filter, which was already explained very well before. Angle along the filter, and it swings along with the light, sometimes in the side, sometimes in the straight. Magnification is lowest because you want to see a bigger view. Higher the magnification, smaller the view. Lower the magnification, bigger the view. It's like seeing a forest from the top in a helicopter. It's very comfortable for the patient. If you just quickly scan left to right, very quickly you can do it. Okay, this is a diffuser. You put the diffuser in front, it becomes in a very diffuse way. It can be done with a diffuser like this, or you can use from the side, or you can see, this is how you can see. For example, if you turn the lid over, this is how you see inside the tarsus. And this is how you can see the lid margins. So this is helpful to find out gross lesions. If you don't use a diffuser, you can still use your normal spot, but make it big. But you see a round one, you won't see a diffuse area, but you can still make it out. So this is how you use it without a diffuser. That was diffuse illumination for you. One already ticked. We go for the second one, which is a focal illumination. What is it? You're going to see a single portion only. A focal illumination allows you to see one part of the eye only. Okay, so it can be like an optical section. You see, this is like a section. Suppose you take the eye and you cut it, this is how you'll be seeing it. It's an optical section of the eye. And then what do you see? Corneal lesions, anterior segment, lens, vitreous. You adjust the width. You can get it very fine, you can get it medium. Usually it's from the side, and the magnification slowly increase it so that you can get. Remember, if you're going to keep it for long, if the illumination is too bright, the patients will not be too comfortable. Let's see some examples how it works. A narrow beam here, a moderate beam, and a broad beam. This is how we quickly see. Here I show the different height adjustments of the slit lamp. You can see the swinging of the slit lamp. If you observe, the pupil constricts when the light is more. So that means that more light is going in, patient is going to have some photophobia as well. So this is in average a quick overview about focal illumination for you. In focal illumination, you can make it a very narrow slit. A very narrow slit for conjunctiva. For example, this is a lesion in the conjunctiva. It looks like a solid lesion, but if you put a slit, you know it's not a solid lesion. Sometimes you can also see the cornea. Light is coming from this side, remember. This is the front, this is the back of the cornea, this is the iris. So here is the example. This is a foreign body in the front of the cornea, anterior to the cornea. This is how it looks. Anything in the back of the cornea will be behind on this side of the slit, like keratic precipitates here. Or a corneal ulcer, you can see the slit changing its shape here. In a corneal ulcer, when this thing is uniform, or a keratoconus, the shape goes out. You can also study the shape of the cornea at the same time. Okay. This is a grading of the anterior chamber, another exam question which you have to know. Next, we go for the lens. So see, again, the light is coming from here, the front of the lens, the different layers of the lens which you can see clearly. Okay. Sometimes you can go for a moderate beam, slightly more broader. That will give a more information for you. For example, if I use a moderate beam of the same condition, which is decimus membrane folds, a moderate beam gives the distance of the extent of the lesion, whereas the slit gives the extent of the depth of the lesion. You can see here, this is the front light coming from here. This is the front, this is the back. You can see the folds in the decimus here. So this is the difference. So you can use this for certain circumstances, moderate for certain circumstances. You can pick and choose. Then you go for the anterior chamber. What do you look for in the anterior chamber? When there's inflammation of the eye, then leads to some cells formation. Eye is the only organ in the body we can study live physiology directly. And this is one of such physiology which you're lucky to see. This in good magnification, proper light, proper 4 mm by 1 mm setting, you can see the cells here. You can see the cells in dynamic motion. So this is how you see the cells. It's by an effect called Tyndall effect, where you can see the cells moving because they reflect the light back onto you. In a section, you'll see the cells here. And when you need to see the flare, this is how we see the flare. This is again another exam question. They'll ask you how do you grade the cells? How do you grade the flare? When you get them, what to differentiate and how to differentiate the two. Okay, but I'm just, my idea is just to give you an idea how it looks like. So we have a broad beam, we have a narrow beam, we have a spot evaluation. A tangential beam is when you go further away. When you go further away, you can see the tangential study of the iris. Like for example, if the light is coming 90 degrees, it's like somebody keeping a torchlight like this and evaluating the iris. When you see the depth of the AC, This is a tangential beam for studying the iris. You can also see some nice, beautiful nodules in the iris, abnormal vessels going on in the iris as well. See here, when you see, all you have to do is very quick one. You just have to quickly scan from one side to the other. If you spend the least time across the pupil, when you go across the pupil, just go across. So you just go left, right, top, down. That's why quickly you scan if you want to scan the surface of the iris, for example. This is an example of how you do a focal evaluation for a quick overview of what's going on. Indirect examination is when how he's using it is anything close to you, shine light and see just close to the lesion. So you can adjust the breadth of the beam. This is how you see any lesions close to it by the side scattered light only. It may get a bit uncomfortable for the patient. Another useful one is called retro illumination. As the word goes, it's back, illumination from the back. So you shine a light here, it goes all the way to the retina and reflects back onto you. And that view gives you an idea. This is an intraocular lens, which you can see here, the backdrop of the retinal red glow. So what is it used? Anything close to lesion, corneal section, it's adjust the breadth of the beam, slight angulation are usually axial, and you have to increase the magnification if required step by step. And it can get uncomfortable because the light is going all the way into the retina. So for example here, this is how retro illumination looks like. You can see in the background of the iris, you can see the nice, beautiful blood vessels. Okay, let's compare. This is the same picture by diffuse illumination on the left. You see, you can see the gross extent of the lesion, but the retro illumination gives you an idea about the extent of the blood vessels, extent of the lesion. This is how retro illumination will come into use for you. Retro illumination can also study fine corneal vessels, nice, beautiful sutures, the depth of the sutures, the extent of the involvement, iris window defects, atrophies, posterior capsular thickenings, decentration of the IOLs. So this is what retro illumination is useful for. The next one you go for is specular. Specular is speckled. So specular reflection usually is used to see the endothelium. Can be done for other layers as well, but for endothelium. How does it look like? The light goes from one side, gets reflected like a mirror from the endothelium, and in high magnification, proper lighting, still patient, proper fixation, very quick examination, you have to do this. This is very useful if you're doing a cataract preoperative evaluation, because if the endothelium is not healthy, later when you do a cataract surgery, the surgery could go wrong. Okay, so specular examination, think of endothelium, think of high mag, still patient, high illumination, and a proper quick reflection off from the endothelium. Okay, so we've seen quickly diffuse, you've seen focal, you've seen tangential, you've got retro, you've seen indirect. Now you're going to see sclerotic scatter. What is sclerotic scatter? Sclerotic scatter is when you decenter it away, one goes away from the other. Use a knob here, which is seen here. This knob, you decouple the knob, and then the axis tilts. You see here, this is not at right angle. This is tilted away. This is what you look for. How does it look like? I'll give you an example. This patient comes to us with inflammation of the eye, recurrent inflammation. You see a white area here. You don't know how much is the extent of involvement. Okay, this is diffuse illumination for you. In diffuse, I see this is a problem. Then what I do a sclerotic scatter. I shine the light on the side. Now you can see the extent. How does it work? The cornea is like a clean mirror. You have those fiber optic cables, Ethernet. So cornea works like a fiber optic cable. When light goes on one side, it gets internally reflected, goes all the way and exits from the other side. You see, light goes here on this side, exits from this side. When it's traversing here, there's no opacity. It's very clear. When there is an opacity, it reflects back onto your eyes, and that's how you pick it up. So it's they'll ask you total internal reflection principle, scattering of opaque media, any media density. These are some catchwords you have to put in your examination. Okay, so this is how you can pick up in a sclerotic scatter. Later, you can further go deeper inside and check the vitreous as well. So you can see here, this is the iris, the front of the lens, the back of the lens, and anterior vitreous opacities. So we can also check the vitreous and also check the fundus with the use of special lenses, which will be dealt with later. But fundus examination stereoscopically, unlike a direct ophthalmoscope, stereoscopically, we can see a beautiful fundus examination with a slit lamp. And other procedures can also be done. Subtarsal foreign bodies, some small procedures can be done in a slit lamp. Okay, so this is quickly an overview about what all things can be done. Let's see some practical examples how we can put it into play. This patient came to us as a referral as a deep stromal foreign body in the cornea. When we see in diffuse illumination, it doesn't give much detail. So what we do, we go for iris retro illumination. Look, you can pick the foreign body like a dark in the background of the bright illumination. So what do? You have to remove it. The foreign body was removed. Now comes the question, have I removed it properly? Is there anything left behind? So how do we check? The view didn't give me any idea. So I go back to retro illumination. Here you can see beautifully, this retro illumination gives us an idea that the foreign body has been totally removed. So this is how practically in your setup, you can use it. You don't have to go through 1, 2, 3, 4, 5, 6 for every patient. You do 1, 2, then you decide which one you have to do, and then you follow up. Like for example, this patient came with drop-in vision. He's got a whitish lesion here. Where is this lesion? Is it in the cornea? Is it in the lens? I don't know. So I do a focal slit examination. I can see it's in the lens, the front of the lens, the back of the lens. So I know this is the back of the lens. My next question in my mind, how big is it? Is it just a small or a big one? Then I go for retro illumination. You see, so I saw a diffuse illumination. I quickly jumped into focal. I saw the depth. I quickly jumped into retro. I can see the extent. So this is how you have to learn and play around with your different settings for your slit lamp. Okay, see here again, this is how it gives you an idea about the extent of the lesion. Okay, this quickly is an overview just to see the different kinds of setup. But then not all images or not all structures can be very clearly visible. Sometimes you may need a contrast. You see, when you do a histopathology slide, you put stains because without the contrast, you can't pick it up. Here we use stains as well, but these stains are called vital stains. So why they're called vital stains? Because you put them when the patient is still alive. Okay, so what then again, this I'll give you another shortcut. These are the broad framework to use when they ask about stains. You know it or you don't know it, just memorize this one first. What are the stains? Why to stain? What are the types available? How do they work? When to use them? When not to use them? That's also important. How to use them and what should you tell the patient? This is practical point of view with the last one. So this is in general, all you have to do is fluorescein. Remember two things. Fluorescein stains when there's a tissue which is denuded, no tissue. Rose Bengal and lissamine stain when the tissue is damaged. Both do not stain when the tissue is healthy. Point number one. Point number two, fluorescein, you have to use yellow filter. Whereas Rose Bengal and lissamine green, you can use white filter. Point number two. These are the shortcuts. Point number three, Rose Bengal, as the name suggests, is rose, red. Lissamine green, as the name suggests, is green. And fluorescein is between the two, yellow. Okay. Three things, whether you know or not, whether you remember anything or not, you just write this, you'll get at least 40% marks. Okay, fluorescent stain is used when it uses the principle photoluminescence. Certain catchwords you have to remember. What happens when light is shone on it in one wavelength, it absorbs it and exits it in another wavelength, a longer wavelength, which means blue goes in, green comes out. Okay, this is when the phosphenes are excited and they release it upon stoppage of the light or when the light is still on. There's a difference. If you're really interested to get more marks, they'll ask you about fluorescence whereas phosphorescence. Fluorescence is a property, as long as light is coming, this light keeps going. You switch off, this goes off. Phosphorescence, you keep shining, you stop the light, it still keeps fluorescing. That's phosphorescence for you. Okay, let's go back to this quick one. So this is used only stains the damaged tissues. It has a use of phosphenes and it exists. Blue goes in, a lower wavelength, yellow comes out, longer wavelength of green comes out. What filter to use? I showed you earlier, blue filter. You have to excite, it's called an excitatory filter. It also blocks the returning blue light coming out. So what do? You have to use it, and specific indications were diagnostic, therapeutic, like Goldman, contact lens fitting, checking up some tarsal papillae and wound leaks. Let's quickly see one by one. Tarsal papillae, if you see the image on the left, is not very clear. You put a stain, you can pick up some contrast, that gives you a contrast. An abrasion patient coming to you, you stain it, this is how it looks green. But you put a blue filter, you see the contrast it gives. Another example, this patient came to us with recurrent irritation, foreign body feeling, not feeling comfortable. Diffuse illumination doesn't give you much. You stain him, then you know it's a case of recurrent corneal erosion. This is a dramatic way and you can diagnose better. That's why you have to use a stain. Another point, remember this patient, any patient seeing an isolated abrasion, complaining of foreign body, please remember to evert the lid. This is a subtarsal foreign body here, which has been causing scratching here, causing an abrasion there. So remember always, no examination is complete without everting the lid. Remember that. Sometimes what happens when there's a leak or a damage, then you put the fluorescent stain, the fluid coming out will change its color. Like here beautifully you can see, when there is a leaking going on here, by applying the fluorescent stain, the leak, it's called a Seidel test. Another exam question, Seidel test. Where do you use it? Trauma, post-tabeclectomy. You feel the AC shallowing after surgery, you put sutures, you're not sure if you've done the sutures. Corneal transplant, you put a suture, you're not very comfortable, you think it's leaking. To know if it's leaking or not goes your Seidel test. Okay, another exam question for you. So this is also called a breakup time. Normally you don't see tear film. Tear film is transparent, right? So now if you want to see a tear film, you have to stain it. So normal tear film, when you blink, it remains in the front of the cornea, keeping it cool, like your car windshield wiper. But some patients, it becomes dry very fast. So those patients are not comfortable. They call them dry eye patients. So how do you know they're dry eye patients? Is you have to stain the tear film to see how it's working. So by putting a drop of fluorescein, it stains the tear film. Then the tear film, as long as it's in contact, it remains green like this. But when the tear film dries out in certain areas, you can see, you just watch here, it'll become black. So this is where the tear breaks up. So you have to assess the time where the tear breaks up. It's called the tear breakup time. So the tear breakup time is very small, then the eyes are very dry. So the purpose of fluorescein is to assess the tear structure, tear integrity, tear breakup time, and the tear flow. All right. So this is tear breakup time for you, one of the uses. Sometimes some irritation can be there. You can use a stain to see where the subtle changes in the cornea are. And for contact lenses also, you can put a contact lens, and this is where you can see the film of the thing under the contact lens when it's blinking. It's called a Jones test. So when you put normally the tear film is flowing out. When the tear is flowing out, you can see it draining out and it's positive. But sometimes what happens, the tear doesn't come out really. Then you put a stain, you flush it out, and then you see here. So it's called a Jones test. All you have to know is it assesses the tear flow function. In small children, you know the tears are flowing out. Just put the drop and you assess it coming out. Or in adults, you put it here, test it here. You know, if people would have felt, put eye drops, you feel in your throat. That means your tear duct is normal. This exactly is the same principle. If it comes out here, it's good. If it doesn't come out, you flush it. It's called Jones test 1, 2, which you can probably lead up later as you go through your course. Okay, it's also used for other procedures like Goldman, which again they'll discuss in the glaucoma subject. How is it available? So small practical point. It's available as strips, is available as minims, which is preservative free, available as reconstitution. Most of us, we use reconstitution when we were students, but the thing is, reconstitution, the problem is it doesn't have preservative. After 24 to 48 hours, it can get pseudomonas. So it's here to be very careful to make sure that you don't touch the tip, you don't contaminate the liquid. Sometimes if it's old, please don't use it, because a patient comes to you with corneal abrasion, you're going to put this drop and give him a corneal ulcer. So remember, if the fluid is there, if you make sure it's clean and fresh, otherwise please don't use it. The safest one is this strips or minims which are preservative free. Rose Bengal, almost similar, everything similar, just follow the same, except it stains only damaged tissue, not denuded, doesn't stain normal tissue. Remember that. The forms are the same, 1, 2, 3, you can fill the same. Used in dry eyes. Okay, again, dry eyes. But you have to remember one thing, patients will have a lot of burning. Rose Bengal, remember burning, B for B. Rose for color, B for B, burning. Okay, when a patient is wearing contact lens, don't put it. He's going to be after, he'll kill you because you're going to stain his contact lens. So remember, any stain before you put, ask the patient, are you wearing contact lens? Soft lens. Soft lenses you cannot put. Okay, then how does it stain? It stains red and is using a white light. Some examples here. You can see here how it's stained. It also stains corneal tissue. Like here, for example, herpetic. When it's herpetic, you see these cells are damaged, which is stained. The fluorescence stains the bed. The fluorescence stains the bed. Then the Rose Bengal stains the margins. Okay, right? You can also use both. It's called dual staining. You can use both to get a better picture of what's happening. Quickly, okay. So you 1, 2, 3. Lissamine green. Exam question. What is the color? Lissamine green. Green. The examiner may say, what is the color of lissamine green? That is, catch the catch. Okay, lissamine green. Now, how does it work? Same. Minims, constitution, all the same. I told you the broad skeleton. So the shortcut is you just remember the skeleton. 40% you can write. And then once you remember the skeleton, just remember what is it different in each of it. Just remember that. So all you have to try to write the skeleton, see what's different, and put it inside. You'll still get it. Okay. So conjunctival stain and dry eyes. This is more comfortable for the patient. That's how it's different. Cannot put on contact lens. It's green in color. Just 3 points how it's different than Rose Bengal. Okay. So it's also useful for a condition called lid viper. This happens in dry eyes. The epithelium becomes changed in their architecture, which will take up the stain. So any patient with irritation, always flip it up and look inside for foreign body, tarsal papillae. If required, you stain the margins. This will give you a lot of idea. Now for common mistakes, what you should not do. Look here. Here the patient is not keeping the forehead. I told you the most important thing which will make your life very easy. This, and this. Make sure you does this done and the patient is comfortable. Your life is very easy. You can get very good examination. Very easily you can do. Remember, you don't slouch back. If you don't want to go back with a back pain, don't do this. If your chair is not good, don't challenge yourself. Make yourself comfortable. Never do this to the patient. Don't keep the light full. I told you, remember, always keep the rheostat low, switch it on with the beam away, then you bring. So patient will be confident. Otherwise, patient will be scared whether they're going to hurt the patient. When you're doing procedures, another tip. Sometimes these procedures you do when you go close. Difficult to gauge 3D. So what do? Sit from the side, Use the slit lamp and just move the slit lamp close to the patient, just 1 inch away. Then you start focusing and do it. It's like a camera. You have a huge zoom lens. You cannot do fine focusing all the way for a tree away. You just do the main one, then you do the fine focus, the same thing. You move the slit lamp, see from the side, go close to the patient. Patients also trust you. Then you go to the ocular, then you move side to side, very comfortable. Sharps, never keep the sharp pointing towards the patient and go with the slit lamp like this. Very dangerous, remember. Keep it away, rest it on your frame. Do it. Once you're confident, bring it into your field, then slowly go in. All right, there's some small tips which is important. Remember to sanitize all points, ensure barrier protection because you make sure you're safe. Make sure they reset the thing at the end of the day, low light, so that the next examiner, next patient will be okay. Dust protection. Don't use strong caustics. Mirror care, I already told you. And always remember, this machine will be used by different people. When you sit, organize it and set it for yourself before you move. It's like when you move to somebody, your friend's car, you adjust your seat first. You don't go by there sitting and drive it, right? You set and adjust your seat first before you drive. That's exactly what you should do. And the most important, we've got an excellent panel of teachers with you. All of them very patient and willing to help you. All you need to know is go and ask them. Go and ask them, tell them your problems, just keep practicing. And another most important thing which I did when I was a student, you sit in front of the slit lamp first. You sit, ask your friend to examine you. 2 things you will know. 1, how uncomfortable it is to sit in the slit lamp. 2, how much the light can be so bright. Once you do that, you're going to be empathetic to your patients. Patients will cooperate longer. Keep practicing, practicing, practicing. I'm sure you guys will do well. Thank you.
Thank you, Dr. Azim. It was an exhaustive and informative talk. Now we'll go to the last talk of our session. It's on slit lamp drawings for anti-segment. I call on Dr. Silja S. She's a faculty at the Alleppey Medical College.
Thank you, sir. So now we have seen how you elicit findings with slit lamp. Now we go on for the drawing. So in this session, we'll have a methodical documentation of anterior segment findings using standard color code. Why you need to draw? First, because of standardization of documentation. Documentation has been the cornerstone of clinical science, but now we are rarely practicing it. It has become a lost art. And we make excuses like it's time consuming, it's of no use, etc. But it helps us very much. It helps medical legal aspects, then easy follow, especially in an institute where each time the patient is seen by different doctors. Once you have a proper drawing, it's easy to follow. Then for teaching purpose and cheaper option than anterior segment photography. And last but not the least, it enhances the clinical skills. Because unless you are not documenting it, you have not probably seen it correctly. Because once you start drawing only, you will understand that you have not seen the finer details of the lesion. And so, because of this documentation, your observation skill will improve. And it is not time consuming. Once you start doing for all the patients, it becomes integrated into your system and it will not be time consuming at all. What are the requisites? What you need for drawing? Mainly color pencils. 6 common colors used are black, blue, brown, red, green, and yellow. And you need an eraser to some changing and stencil. So coming to cornea. Cornea, we should always have a frontal view and a cross-sectional view. Because we need certain details. We need to know the location, whether it's central, paracentral, or peripheral. We need to know the depth of the lesion. In the cross-sectional view, the anterior line corresponds to the epithelium and the posterior line corresponds to the endothelium. So from there, we can assess the depth of the lesion. And for lesions with thinning and all, we have to mention how much percentage of thinning is there. Then dimensions, vertical and horizontal dimensions are required. In some cases, we have a shorter dimension and longest dimension also we measure. And if you follow the Clocker rule, we have a perfect drawing. In case of some abscess or scar, where the posterior cornea is not clearly identified, we depict it with dotted line, black dotted line. Now coming to the color coding, black color is commonly used for outlines of cornea and the lid, then scars, opacity, degeneration, foreign bodies, sutures, contact lens, band keratopathy, corneal nerves, and corneal fractures. You'll see some of them. This is a case of a corneal scar. You'll see in the central area, and it is marked with black color. And depending on the density of the scar, we can make the shading darker. So if it is a left dent scar like nebula, we can make it like a zebra pattern. And darker scar, we have to give it more darker shade. And similarly, you have to make it in the cross-sectional view also, depending on the depth of the scar. The case of arcus degeneration, seen at the periphery, and you can see a clear interval at the loop. Dystrophy. Here, it is very important to have a cross-sectional view because anti-coronal, the frontal view will not make out. We'll be seeing only here you can see that there are few ill-defined black opacity. But from this, you can't make out whether it is at the epithelial level, subepithelial level, or the stromal level. So now we have to look at the frontal view, the stroma. So we have limited our differential diagnosis. It's the case of a granular dystrophy. Foreign body. Here, the location and the depth is very important. It's a superficial foreign body, so I have marked it like this. So some foreign bodies, it will be deep. So when you refer the patient also, it is very important you mark it properly so that the treating surgeon, it is very easy to remove and also for medical legal purpose. And if you see any infiltration surrounding that, you can give a yellow line surrounding the foreign body. Suture. This is the post PKP. So it depends what is the type of suture that you have to mention. It's an interrupted suture or it's a continuous suture, then site numbers, and also if there is any low suture, we can point out the low suture. And in the cross-sectional view, you can see the thickness, the depth at which the sutures are taken. Corneal nerves. Their prominent corneal nerves are seen in conditions like keratoconus, then multiple endocrine dysplasia, neurofibromatosis. So corneal nerves can be depicted with the black wavy line. Contact lens. Bandage contact lens, it covers the whole of the cornea. So it is given as dotted line surrounding the limbus. Outside the limbus, you get that black dotted line. Whereas rigid gas permeable lens stays within the cornea, so the dotted lines are within the limbal line. Now coming to blue color, it is mainly for edema. In epithelial edema, you see microbullae and macrobullae. So this picture you can see that patient is having both microbullae and macrobullae. The arrow points towards the macrobullae. The microbullae is shown with blue ring, small blue ring, whereas macrobullae is slightly larger. The macrobullae, the microbullae. Stromal edema is shown with diffuse blue shade. And if the stromal edema is thick, you can see that the thickness of the slit will be increased. So that can be shown as posterior bowing of the posterior boundary can be shown as little bowing of. So this is the stromal edema. There is a Descemet's fold that is shown in wavy pattern, blue wavy line. And that also depending on the pattern. In some cases like impending perforation, you will see that the Descemet's folds are more radiated. So draw light. Now coming to brown color, mainly pigmentation. Pupil and iris is also shown in brown color. Krukenberg spindle. Here you see fine endothelial pigments at the endothelial level. They are shown in the frontal view. They are mostly arranged in seen in pigment dispersion syndrome and fluid exfoliation, and it is shown in a spindle shape. And posteriorly, you can see the endothelial level is the pigment line. This is the case of a posterior synecdoche. You can see there are festooned pupil and anterior chamber is shallow with the iris boundary. So from the coronal frontal view, we can see that the pupil is festooned, and from the cross-sectional view, you can see that the iris is attached to the anterior surface of the lens with the bowing of the iris forward. So iris boundary. So from the picture itself, you'll get a clear idea. Anterior synecdoche, iris attached to the cornea. So here you can see that the iris is both anteriorly and touching the corneal surface. And if there is associated corneal opacity, you can show in the corneal section. Iris nodules, there are both Opage nodules and Busakas nodules. Opage nodules are seen towards the pupillary margin, whereas Busakas nodules are seen towards the base or towards the collar. Better always to mark the finding, but even if it is not marked, depending upon the location, we'll be able to make out which are the Opage nodules and which are the Busakas nodules. The nevus, where the lid, conjunctiva, sclera, whatever, we depict it with brown color. Now coming to red color. Red color stands for hemorrhages, then blood vessels, and post-menopause scale. It's very important. Superficial blood vessels, they are mainly conjunctival vessels. So they start from the conjunctiva, they cross the limbus, and they grow on the surface of the cornea. So here we show it as red wavy line starting outside the limbus and proceeding inward. Now deep vessels, they start from the limbus and they are straight lines. They proceed from the limbus towards the inward. They are mainly ciliary vessels. And non-perfused blood vessels, mostly seen in interstitial keratitis, following resolution, you see non-perfused blood vessels. They are shown as red dotted lines. Okay, so while drawing blood vessels, we have we have to be double sure what are the type of blood vessels. So once you start drawing only, you go to the patient again and see initial stages that what is the type of blood vessel. Initially you say, oh, there are blood vessels, but it's not like that. Go to the patient and see whether it is a superficial, it's a deep, and depending upon that, draw hyphema. Anterior chamber findings are better drawn in the cross-sectional view than the frontal view because otherwise it can cause confusion. So cross-sectional view, hyphema is shown in red color and the height of the hyphema should be marked for better follow. Green color, it is used to show epithelial defect, fluorescein staining, punctate keratitis, filaments, and vitreous. Epithelial defects, here you can see that the green outline shown in epithelial defect. If there is some infiltrate at any part, that is shown in yellow color. It is shown in both the frontal section and the cross-sectional section. Punctate erosion. They are tiny epithelial defects or tiny erosion seen on the surface which stain good with fluorescein. So, and the right side you can see they are punctate keratitis. They are more like the corneal vesicles or they are swollen corneal cells. So they are slightly larger compared to the punctate erosion. PKs are marked as slightly larger and it is seen on the surface of the cornea, on the epithelial cell. And number and extent, at least we have to mention how much, or we have to draw the extent because depending on the location, the diagnosis changes. So we have to draw accordingly, whether it's in the interpapillary area, whether it's in the lower cornea, upper part of the cornea. This is subepithelial keratitis. Here you can see that the lesions are slightly larger and the location also comes under the epithelium. So that's how you have to differentiate between punctate epithelial keratitis, SPK, and subepithelial keratitis. Coming to filaments. Filaments are mucous strands covered with epithelium attached at one end to the cornea and they move freely with IVT. They are shown with green wavy lines. Stains, as already mentioned. So fluorescent staining is shown in a green color and Rosenthal staining is shown in red color. Sometimes we do dual staining, like double staining. So there you have to show the margins. The margins are stained with Rosenthal, show that in red, and the base of the ulcer draw with a green color. Yellow color mainly for infiltrate. So and inflammation. So infiltrate, you can see in this picture there is an epithelial defect which is shown in green color with an adjacent or surrounding infiltrate that is shown in green color. And in the cross-sectional view, it is up to the anterior stroma or up to the mid stroma. So that also we have to show clearly. This surrounding edema that is shown in blue color. Keratic precipitate. They are inflammatory deposits shown seen on the endothelial surface. And fresh keratic precipitates are shown in yellow color and with pigmented, that means they are getting older or they are resolution. So older keratic precipitates are shown in brown color. Hypopyon also is an anterior chamber finding, so better shown in a cross-sectional view. The hypopyon color is yellow and height should be measured. That is also for easy follow. Lens. If it is a clear lens, the outline is shown in green color. We just make the outline with a green color. But if it's a cataract, you have to make it with yellow color. And depending on the location, whether it's a nuclear cataract, whether it's a total cataract, mixture cataract, or it's a posterior subcapsular peripheral, you have to mark accordingly with a yellow color. So how to draw? Always mark the eye. That is very important. Whether you are seeing right eye or left eye, specifically mark the eye. Then make the corneal outline and make the cross-section. Then you go for the pupillary. And depending upon the shape of the pupil, size of the pupil, mark accordingly. Iris is also marked. Now coming to the lesion. Lesion, you have to, there is a case of epithelial defect and infiltrate, so mark accordingly the location, the size. Then just an epithelial edema can be shown. Can also be shown in your cross-section. Then go for finer details. There are many findings, go quadrant wise so that you will not miss any findings. If there is any pigmented lines, you can show there is any blood vessel or any staining area. There you have to draw in your cross-sectional view and mark it with percentage. Then mark the extent of the cornea or the lesion. So here it can be horizontal or vertical or shortest dimension, longest dimension. That's all given reading for. Now the iris also is. There is a hypopyon that can be shown in your cross-sectional view with yellow color. Then mark the point where you have taken the cross-section because this different area, the cross-sectional view will be different. So that given a line or an arrow where you have taken the cross-section, like in the where from where you have the cut section, you show it in the main picture. Similarly, from the picture also in the frontal view, you have to show where you have taken the cross-section.
Thank you to all the speakers. I think I'll hand it over to Dr. Rajiv.
Thank you so much. It was a fantastic session. A special thanks to Dr. Azim for taking pains in preparing such a beautiful presentation. It was very nice. And all the other speakers, Dr. Sija and Dr. Freddy, your presentations were very good. And the session went on smoothly, exactly 1 hour. We started 10 minutes late and we finished 10 minutes late. So your session is perfect. Okay, we'll move on to the next session. And I request Dr. Mini to invite the next chairperson and the moderator.
Move on to the next session on ophthalmoscopy. Dr. Mallika will be the chairperson and Dr. Arya will be the moderator of this session.
Thank you, Dr. Mini. First of all, I congratulate Dr. Rajiv and KSOS team for arranging such a fantastic program for the freshers. Directly, we move on to our topic, ophthalmoscopy. First speaker is Dr. Arya. She is the assistant professor working at RIO Trivandrum, and she will be speaking on our age-old direct ophthalmoscopy, which is very important till now, even now. So we move on to first talk by Dr. Arya. Over to Arya.
Thank you, madam. My topic today is direct ophthalmoscope. So going to the history, direct ophthalmoscope we use now was invented by Sir Hermann von Helmholtz. And it is said that the physician using a direct ophthalmoscope is like a one-eyed Eskimo peering into an igloo from the entryway with a flashlight. So for the first year PGs, in the initial days, it will be a little bit difficult to master the technique of direct ophthalmoscopy. So these are the different companies available: Keeler, Kane, Belshanen. Now, direct ophthalmoscope consists of two main systems: the illumination system and the observation system. And the illumination system consists of light source, condensing lens, reflecting prism, and series of apertures. And the observation system consists of a peephole and a bank of spherical lenses. So in this picture, you can see the parts of an ophthalmoscope. That's the head, neck, body. And this is a peephole. This is a peephole through which we observe the patient's retina. And here you can see the lens strength selector wheel by which you can select the lens power which you want, which I will be dealing in the later on slides. And this is the on-off rheostat. Now, this picture depicts the basic working principle of a direct ophthalmoscope. In this picture, you can see in the lower part, there is a lamp filament from where the light is emitted, and the light passes through the condensing lenses 1 and 2. In between is placed the aperture dial. Using this aperture dial, you can select the size of the spot, which I will show in the later slides. And from here, the light passes onto the mirror, which is placed at a 45-degree angle. In the newer ophthalmoscopes, instead of this mirror, we use a prism. From here, the light passes on to the subject's retina, and the light rays emanating from the subject's retina pass on to the observer's eyes after passing through these compensation lenses. So this is the basic working principle of a direct ophthalmoscope. Now, if the patient and observer are both emmetropic, rays emanating from a point in the patient's fundus will emerge as a parallel beam, and that will be focused on exactly on the observer's retina. And as you know, in a hypermetropic patient, the image is formed behind, and you have to correct it using a convex lens, and in myopia in front, and correct it using a concave lens. Now, the image that we get in a direct ophthalmoscope is virtual, erect, magnified. And the magnification we get is 15 times, and the area of retina imaged is 6.5 to 10 degree. Now, this is a video which shows the direct ophthalmoscope. In the video, Keeler's ophthalmoscope is shown, and you can see the head, neck, and body of the ophthalmoscope. Here is a lid that you can remove it, and you can use rechargeable batteries for your direct ophthalmoscope. And once charged, you can reinsert that. And whenever you start using the ophthalmoscope using a fresh battery, always use it in a submaximal illumination, and then only you start increasing your illumination for the next cases. That will help you to prolong your battery life. Okay. And now we can see the different apertures that we use. Now this is the light intensity adjustment dial. You can adjust the illumination accordingly, whatever illumination you want. Now this is the aperture dial. Using this aperture dial, you can select the size of the spot needed for your direct ophthalmoscopic examination. And there are different spot sizes ranging from small, pinhole, large, then comes the fixation star, then comes the slit and the large spot. And in which all conditions these are used, I'll be dealing in the next slide. So this is the aperture dial used to select your spot size. Okay. Next, as I earlier mentioned, you can select the power of the condensing lenses also. This depends upon the refractive status of the patient as well as the observer. If the patient is a myopic patient, then you will have to adjust the power of the condensing lenses to get a better view of the retina. So you can move your condensing lens, that wheel system, and select the minus lenses, which ranges from -1 to -25. Also, if the patient is hypermetropic, you change to the opposite direction where you select the plus lenses. So you get a better view of the retina. So what power of the lens you have selected, you can see in the small illuminated slit as shown in the video. So selection of the condensing lenses is also very important to get a good view of the retina. Now next comes, you can see in the video, there is a small node as shown here. And on selecting that, you can change into the red-free filter. And the red-free filter helps us to examine the nerve fiber layer. This is a red-free image. You get a red-free image of the fundus, and also blood vessels and hemorrhages are also better made clear in that. Okay, so these are the different spot sizes as I showed in the video. Now, methods of ophthalmoscopy, that's a distant direct ophthalmoscopy, which is done at 25 to 40 inches, and a direct ophthalmoscopy where you approach closer to the patient. What are the steps in performing a direct ophthalmoscopy? At 1 meter distance, you get an overall idea about the lid and orbit, and examinations 22 to 25 centimeters provide you a view of the media opacity. Third step, you move closer to the patient, you increase the power of the condensing lens so that you get a better idea of the AC details. And then fourth step is that you reduce the power of the condensing lens, you get a view of the vitreous details can be made out, and then you come closer, you view the retina. In the initial stages, it will be difficult for you to view the optic disc at the first sight itself. You will be seeing some of the blood vessels. So what to do? You localize the blood vessel, follow the blood vessel, and finally you will reach the optic disc. And then you can move temporarily to reach the macula. Then trace the blood vessel to the periphery to reach the second and third order blood vessel. Now, there are some tips for direct ophthalmoscopic examination. You can slightly tilt the ophthalmoscope and view obliquely. Also, rather than going straight ahead of the patient, you can approach from a 15 degree. Use always a small aperture for a smaller pupil to avoid the unwanted corneal reflexes. Now, the fovea lies 3 degrees temporal, disc lies 10 degree nasal, and peripheral retina 16 degrees temporal too. So, if you have a basic idea of this, it is better to it will be easier for you to visualize the retina. The patient should be asked to look straight ahead, straight steady, and frequently blink during your examination. And always use your right eye to view the patient's right eye and vice versa. And the examiner should keep both their eyes open during the examination. And the single disadvantage of this direct ophthalmoscope when compared to the indirect is that you don't have stereopsis here. And normally the examiner should continue to wear his glasses while the patient has to remove his. But if you wear the glass, your field of view will be reduced. And the ophthalmoscope can also be used to assess the amount of disc edema as well as the extent of an intraocular mass. That is, first you focus on a blood vessel, then on the disc, and then you change the condensing lens power to get a better view of the disc. How much power you have to change will give you an idea of the diopter of disc edema. Now, this is a video showing how to do a direct ophthalmoscope. Always take aseptic precautions. And you put dilating drops so that you dilate the pupil and get a better view of the retina. Dilated examinations gives a better visualization of the retina rather than through an undilated pupil. If you are viewing through an undilated pupil, always use a smaller spot size. Now, before starting direct ophthalmoscopic examination, always confirm about your illumination, whether your instrument is working, and select the spot size, what spot size you need. Stabilize the patient, ask the patient to look straight, then put your hand over his forehead or shoulder so that you stabilize the patient. Ask the patient to look at a distance. You do the distant direct ophthalmoscopy. And in the distant direct ophthalmoscopy, you may be able to visualize the media opacity. And if you visualize the media opacity, you can assess whether it is anterior or posterior by a simple test. You can ask the patient to look in the 4 cardinal positions, that is lateral, medial, up and down. When the patient moves his eyes, look whether the opacity is also moving and how does opacity move. When the patient moves his eyes, if the opacity is also moving along with that, that is, if the patient is looking towards the right, the opacity is also moving to the right, it means that it is anteriorly located an anterior chamber abnormality or a corneal abnormality. If the opacity is moving against, it means that it is situated posteriorly towards the lens. So this is a simple test to assess the location of the media opacity. Now you can see in the video, the observer is approaching closer to the patient, having a view of the retina. Once you see the optidis, then you ask the patient to, after assessing the details of the optidis, ask the patient to look into the light so that you can get a detailed view of the macula. Now ask the patient to look in all the 4 directions so that you can visualize the periphery of the retina also. So this is how you basically do a direct ophthalmoscopic examination. And these are the things that you see. You can visualize the optidis, optic cup, then move temporally, visualize the macula. The darker ones are the veins and the lighter ones are the arteries. This is an all droplet reflex that you get in keratoconus by distant direct ophthalmoscopic examination. So distant direct ophthalmoscopy is always important. Now, how to care for your instrument? The battery should be fully discharged and recharged once every few months, and always use submaximal illumination for the initial 1 to 2 cases. Then the condensing lenses are stuck to the dial using a glue which is solved in acetone. So never use these solutions to clean your ophthalmoscope. It will damage your instrument. And it can be cleaned using a mild alcohol or detergent, and a cotton bud is used. Then always store the ophthalmoscope in the case when not in use. If it will be unused for a long time, you remove the battery and store. So thank you.
Thank you, Dr. Arya, for that wonderful presentation. Now we move on to our next talk by Dr. Biju Raju. He is a renowned retina surgeon from Kochi. He is working in Kochi Ranjini Eye Care Hospital. Over to Biju.
Thank you very much. Good morning. I would like to thank Dr. Rajiv Sukumaran and KSOS for this opportunity to be part of this program. These great men have contributed a lot to make ophthalmoscopy the most important invention that shaped the evolution of ophthalmology. If ophthalmoscopy shaped the evolution of ophthalmology, then Professor Charles Shippens shaped the evolution of vitreoretinal subspecialty with the invention of the binocular indirect ophthalmoscope. As you know, the retina can be viewed using a direct method or an indirect method. In the indirect method, the retina is viewed indirectly by viewing an aerial image formed by a high-power plus lens called the condensing lens. This table highlights the main differences between the two techniques of ophthalmoscopy. The most important advantages of the indirect method over the direct is that the indirect method offers stereopsis and a larger field of view, both of which are absolutely necessary to evaluate a retinal detachment. Scleral depression, which is an essential part of peripheral retinal examination and management of peripheral retinal lesions, can be done only with the indirect method. Because in the indirect method there is a safe distance of almost 1 meter between the patient and the examiner, during the time of pandemics like COVID-19, it is far safer than doing a direct ophthalmoscopy, which obviously should be avoided at present. There is a whole chapter on optics of ophthalmoscopy in most textbooks, and I would like to refer to the fine chapter on optics of ophthalmoscopy in Duane's Ophthalmology for further reading of optics. However, I would like to stress on two important aspects of optics related to indirect ophthalmoscopy. The first and the most striking feature is the use of a high-power convex lens, as I mentioned earlier, called the condensing lens, which makes the eye highly myopic. This results in a real, inverted and laterally reversed image close to the principal focus of the lens. In addition, as you see in the direct method, the rays of light emerging from the periphery, that is, the rays 1 and 4, are not reaching the examiner's eye. But in the indirect method, because of the condensing lens, the peripheral rays of light are also brought to focus at the plane of the aerial image, thus enabling peripheral viewing of the retina. In a binocular indirect ophthalmoscope, the optics convert the examiner's interpupillary distance or IPD of approximately 60 millimeters to 15 millimeters using a set of mirrors, and this allows for stereopsis as both eyes simultaneously perceive a slightly different area of the aerial image. Another interesting aspect in the optics of indirect ophthalmoscopy is the amount of accommodation an examiner needs to exert to see the aerial image when there is a gross refractive change from emmetropia. Here, in an emmetropic eye, the examiner will have to accommodate for a distance of 40 centimeter to see the aerial image which is at the principal plane of the 20 diopter lens. The dioptric equivalent of 40 centimeter is 100 by 40, that is 2.5 diopters. In a myopic eye, the combination of the condensing lens, that is plus 20 diopter, and a myopic status of -5 acts as a more powerful condensing lens, and thus the examiner has to accommodate only 2.4 diopters, 0.1 diopter less than he would if the eye was emmetropic. Now let's see the opposite scenario where the eye is plus 5 diopter hyperopic. Here, the examiner will have to accommodate for a shorter distance, resulting in an accommodative component of 2.6 diopters, which is just 0.1 diopter more than that in an emmetropic eye. Thus, we see that gross changes in refractive errors will not lead to gross changes in the accommodative demand on the examiner. That is why gross refractive errors do not have an impact on the clarity or focus of the fundus image with indirect ophthalmoscopy. Whereas, in the direct method, one needs to interpose the appropriate correction lenses on the recourse disc to adjust the focus in eyes with refractive errors. Now let's look at the instrument itself. There are two commonly available models of binocular indirect ophthalmoscope. The head-mounted model is more sturdy and the more popular one. The spectacle mount is used for convenience and maybe portability, as it can be hung around the examiner's neck when it's not in use. The instrument has an illumination source, observation optics, and a housing which includes the power supply and electronics, and a headband for mounting the instrument on the examiner's head. The knobs or levers on the sides are for changing the illumination spot size and for using filters like cobalt blue for fluorescein angioscopy, the green for a red-free examination to look for nerve fiber layer defects, and the yellow filter is supposed to be more friendly in light-sensitive eyes. Preparation is as important as the examination technique. The indirect ophthalmoscope should be mounted comfortably on the head, with most of its weight resting on the top band, rather than tightening the circumband or the circular band that goes around the head. The IPD can be adjusted using the sliding eyepieces. And this is a small pupil versus a large pupil setting. This is a small pupil setting, and that's a large pupil setting where the illumination and the observation columns are farther apart. Now let's mount the indirect ophthalmoscope. As I said, adjust the eyepiece so that you get the maximum field of view. Then switch on the indirect and shine the light onto the wall or to the tip of the thumb of the examiner's extended hand to ensure that the light centers in the field of view at that distance. One eye and then the other should be closed to check this, adjusting the interpupillary distance of the oculars as needed. The lens holding hand is the most important part of the whole system that gives a steady, clear image. Always start holding the lens in the non-dominant hand. In the long run, it will help you draw fundus diagrams with ease, as your dominant hand is free to draw what you see, and as and when you see it, and that speeds up your examination. Grip the lens with the tip of a flexed index finger and the ball of the extended thumb. This allows for moving the lens with varying degree of flexion of the index finger towards and away from the eye. Another important aspect is that one has to support the lens holding non-dominant hand on the forehead or cheek of the patient. Most of us use the extended third finger of the hand or the third and the fourth finger. All these points serve four purposes. Firstly, your hand is perfectly supported and steady. Secondly, the grip on the lens between the tip of the flexed index and the ball of the extended thumb help you move the lens towards and away from the eye. Thirdly, you can use the third finger to retract the upper lid as seen in this picture. And fourth purpose is to act as a pivot for tilting the lens. When examining with the indirect ophthalmoscope, the examiner makes sweeping movements to observe the retinal details. For this to happen, this imaginary line connecting the visual axis of the examiner, the lens, the patient's pupil, and the area of that fundus that is observed should always move together. And this is possible only by moving the examiner's head and tilting the lens simultaneously. Scleral depression is the most technically demanding ophthalmic examination technique. One can use various depressors that are available and can even use a cotton-tipped bud. In fact, during this current pandemic, these buds are recommended for use as scleral depressors. Scleral depression makes it possible to visualize that part of the fundus that lies anterior to the equator. A second and perhaps more important function is to enable the observer to palpate the retina and to examine the peripheral retina dynamically and from multiple angles in ways that can be only appreciated with scleral depression. The technique enables visualization of a retinal flap as it rises from the crest of an indented mound, differentiate a retinal break from a hemorrhage, and see a tuft clearly with its vitreous attachments. This is a case of atrophic holes with a subclinical retinal detachment. You can see the movement of the mound of the depressor. With experience, you can go all the way up to the ora serrata and the pars plana. One of the important landmarks in fundus evaluation as well as drawing is the equator. The anatomical correlate of this landmark is the ampulla of the vortex veins. Here you see the different configurations of a vortex vein in an albinotic fundus. In the next patient who was evaluated prior to cataract surgery, a horseshoe tear was detected. There was a hemorrhage close to it. As you can see, when you palpate the retina with the scleral depressor, moving from side to side and up and down, you can see that the character of the hemorrhage doesn't change. But when you look at the horseshoe tear, you can see the tear opening up, the flap coming forward, the operculum moving as you do a scleral depression in a dynamic fashion. To get an orientation of the inverted and laterally reversed image of indirect ophthalmoscopy, let us take the next case where there are 3 horseshoe tears centered superiorly at 12 o'clock. When an examiner who wants to do scleral depression at that point, he stands at a clock cover opposite to that needs to be examined. So in this case, closer to 6 o'clock. And the scleral depressor is at the clock cover that needs to be examined, which is at 12 o'clock. And the patient looks towards that clock cover that needs to be examined. This is the image showing the real orientation of the retinal lesion. And this is the way we see on the 20 diopter lens. It is as though you are standing on the mount of the depressor and looking towards the disc. This is a side-by-side comparison of the actual image showing the retinal break centered at 12 o'clock, and that's the direction towards the disc. Compare with that the orientation of the image on the 20 diopter lens. Here you can clearly make out that the image is vertically inverted and laterally reversed. This is a patient with a combined rhegmatogenous retinal detachment and choroidal detachment. You can see that the retina moves relatively freely while the choroid under the retina is more rigid. And this is the way you do a sweeping movement of examination reaching up to the periphery to locate the horseshoe tear. This is an ora serrata pearl. It is a clinical curiosity. You can see the dentate process, the pars plana, the ora serrata, and the ora serrata pearl at the tip of the dentate process. They are usually seen in 20% of individuals and are thought to be drusen-like bodies in the periphery of the retina. The next patient is a young gentleman who presented with floaters following trivial trauma. He had an avulsed retinal vessel, vitreous hemorrhage, and a retinal break. Looking anteriorly, there was condensation of the vitreous which extended up to a zonular traction tuft. Here you can see the oris aorta, the pars plana, and the zonular traction tuft with zonular traction at the tip of the tuft. Because of its location in the far periphery, in the pars plana, a pars plana cyst is rarely documented. They are seen in about 5 to 10% of individuals and have no clinical consequences. They are supposed to contain hyaluronic acid. The lateral boundaries of this cyst are usually the oral base. Acquiring good indirect ophthalmoscopy skills with scleral depression gives you an advantage of venturing into the far periphery of the retina, an area not ventured by many for the lack of adequate skill and technique. I hope this presentation encourages some of you to take up that challenge. And that brings us to the end of this presentation. Indirect ophthalmoscopy is an art, and every time you get to see the spectacular image of the retina fill up the 20 diopter lens, it is absolute bliss. I hope this presentation will inspire you to genuinely be interested in performing serious indirect ophthalmoscopy, and probably inspire some of you to seriously take up vitreoretinal subspecialty as their career. Thank you very much, KSOS, and thank you very much, Dr. Rajiv Sukumaran, for this opportunity.
Thank you, sir, for that very informative and elaborate talk on indirect ophthalmoscopy. We pass on to the next session, that is 90D and 70D examination. It will be presented by Dr. Latika. She is a professor at Amala Institute of Medical Science, Thrissur. Welcome, Dr. Latika.
Thank you. Thank you, Scientific Committee KSOS and Rajiv sir, for giving me this wonderful opportunity to talk to the budding ophthalmologists of Kerala. You've just listened to two wonderful talks on direct and indirect ophthalmoscopies. Now I'm going to discuss something that combines the beauty of both, that is using a slit lamp for retinal evaluation. We need to modify the optics of the slit lamp slightly if you need to see beyond the antivitreous. And the lenses we use are usually high plus lenses. That is, you can use either plus 90, 78 or plus 60. But commonly we use plus 90 or plus 78. And it's better to start examining with the plus 90. That may be a better idea, then switch to plus 78. Limited field, so it's not that commonly used now. Next slide, sir. So the advantage of these using these lenses are that you are not going invasive at all. They are all non-contact lenses, and the image you get is almost like that of the indirect ophthalmoscope. But to say an example, if you just look at every day you look at the mirror, what you see is a laterally reversed virtual image. But imagine yourself upside down with standing head on heels. That is how the inverted aspect also comes along in these plus lenses. And regarding magnification, a rule of thumb to remember would be that if you want more magnification, take a lens that is having a power that is a 78 diopter will give you more magnification than a 90 diopter. That's because of that equation, that is magnification is related inversely to the power of the lens. So actually a 90D lens gives you a 6 to 9 times magnification compared to a 60, which will give you 10 to 15 times. But this magnification actually comes from the slit lamp magnification that you are using. And if you really apply that formula, you will see what I'm talking about. It's actually the slit lamp magnification that gives you the power. Now, you may have learned direct ophthalmoscopy first as a PG, as a fresher PG. So why do you need to switch to 90D? Even if you forget the COVID pandemic, you need to switch to 90D because, as I said, it combines the magnification of direct ophthalmoscopy with the advantages of indirect ophthalmoscopy. See, the minute you switch from direct to 90D, first you feel that the image is very small. But there are definite advantages, as we will see. And as far as the patient is concerned, it's a one-stop station. You can enter examination, both anterior and posterior segment can be completed at one go. And the instrumentation is very handy. And now it's a state-of-the-art procedure for posterior pole examination. Now, in general, it's a dilated pupil that is a must for a good examination. At least a 5 millimeter dilatation of pupil will give you adequate stereopsis, and you may darken the room and draw the curtains for best results. You have to see, one common mistake that is done, I always see PGs doing, is that they ask the patient to sit in position first and ask them to maintain a difficult position. And so that will make them more uncooperative by the time you actually do your examination. So first position yourself, then the slit lamp, and last of all, ask the patient to be in position. So let's see how all these things are done. So these are the settings. The illumination and the oculars of the slit lamp should be at 90 degrees to the patient. You can start with into 10 magnification, because that way it is easier to focus than into 16 magnification. And the intensity of the slit lamp should not be too much. Otherwise, you can even trigger a sneezing reflex on the patient. So it should be a midway intensity. The knob should be midway. And the slit beam is usually of 1 to 2 disc diameter, not more than that. Then you will lose focus. And you have to focus your beam right through the center of the pupil. Now, this is the patient positioning is as usual, but all I wanted to tell you this, that is, see, when the patient is looking through the slit lamp into the light, that bright beam will be at the fovea. So if you want to see the disc first, supposing you are looking at the right eye, please ask the patient to look to your left ear so that the optic disc will come and, the optic disc will be in the line of that slit beam. So that is how you will ask the patient to first look. Finally, only you will switch to the fovea. So next, please. So, the lens, as Dr. Biju has demonstrated beautifully, it should be held between the thumb and the index finger, just like he said, for all those 4 reasons. I'm not repeating it here, but one thing I must say is you should take care not to touch the lens surface with your fingers when you do it. And a rule of thumb would be, if you're using a 90D lens, it is best to keep it in such a way that the lens just clears the lash line. That would be around 7 to 8 millimeters from the eye. And always check from outside. That is, you tilt your head and check from outside like this, whether the slit beam is actually passing through the lens and then going through the center of the pupil. That alignment is very important. Next slide, please, sir. So this is how the image is formed. You get an image in between the lens and the slit lamp. You get, that is the image actually what you're seeing. Next slide, please. Now, I would advocate you to use the pull back technique of these 2 techniques. That is, first you go close to the cornea with the slit lamp and focus the cornea. Then further 1 centimeter back, you are on the fundus. So this is slightly a semi-quantitative method by which PGs initiating into this technique can use this step, whatever procedure you're comfortable with. Next slide, sir. So this is a small video just to show you how the slit lamp should be first adjusted. As I said, the oculars and the illuminating system should be 90 degrees to the patient and well aligned. And in yes, this is how the lamp is being adjusted. Yes, now the magnification should be 10, and the lens should be held in position like this using the index finger and the thumb. And you can use your middle finger to support your hand. As far as the intensity is concerned, it should be between the midway. It should be midway in intensity. And usual position only, you ask the patient to sit in the usual position. And these are gentle movements by which you can adjust the focus. This is what the fovea is now in focus. If you want to shift to the disc, you have to ask the patient to look into the ear. So first, it is the disc that should be examined, then the arcades, and finally the ear. Now the image, as I said, it's a virtually inverted laterally reversed image. And to record findings, you need to keep your sheet at 180 degrees, just like you would do in an indirect ophthalmoscopy. Next slide, please, sir. So now we go to some tips and tricks and troubleshooting, because you are going to get into some small trouble in a new technique. As I said, all of you would want to see in bigger. And to see big, you can do two things. One is to increase the slit lamp magnification, or you can switch the lens to a 78 or a 60D. 78 would be better. The next problem that we see is how to maximize view, because the slit beam view is very, very small in width. So to maximize view, you can either decrease the magnification if you're in high mag, or increase the beam width and then fine focus, or you can try bringing your lens a bit closer, or scan the posterior pole. That's what we actually do. You scan the posterior pole and keep the eye stationary. Scan the posterior pole with overlapping slit beams. Next, sir. Now, light is all I see is what a PG usually experiences, the glare. It is too many reflexes are there. So what can you do to reduce reflexes? So some tips would be, next, one is decrease your intensity of illumination if you are having too much light. Tilt your lens a bit. You can try decreasing the beam width, and you can shift the illumination arm slightly off center. So all these things can give you a better image like this. Next. So this is how you have reduced the glare in the same patient. Now, this is something that can happen. You are in focus, but you don't know actually where you are on the retina. This is because the patient may have shifted his position while you were intent on doing 90 degrees. So always monitor your patient's position. Occasionally, you can see from outside also. And always keep your slit beam on the central pupil. Next slide, please. Now, can I see you can very well see the periphery using a 90D. So for example, if you have to see the periphery up, that is superior periphery, you have to ask the patient to look up. And you should move your lens. The patient should look superiorly. You should move the lens slightly up and tilt the lens slightly towards you. That is, the top portion of the lens should be tilted slightly towards you. And look through the center of the lens, because the peripheral retina will fall towards the center of the lens. So the gaze of the examiner should shift towards the center of the lens, while the gaze of the patient should shift superiorly. Okay, so that is how you can see the periphery, and this can be done in all quadrants. Next slide, sir. Now, sometimes you see everything, but still you see it is not that beautifully seen. So in such cases, you can dim the lights, and you can optimize your slit beam centration by the slight circulatory lens movements. These circulatory lens movements are very helpful in bringing things to fine focus. Next slide, sir. So these are all the newer lenses available. You can have increased field of view, or you can even see through a small pupil. Incidentally, small pupil vision is also possible through a normal 90D, but it requires a bit more practice. So all these are the newer lenses. We have 3 generations. Next slide, sir. So we have actually 3 generations of lenses, classic and super and digital. So whatever you use, whatever lens you use, next slide, sir. It is not actually the lens that is important. It is your practice. It is practice, and more practice alone that will make you perfect. So next slide, sir. So thank you all for your attention, and I hope this will help you in some way.
Thank you, madam, for that very informative and precise talk. I hope it will be very useful for the first year PVs. Now we move on to the next session, talk by Dr. Biju John, sir. Dr. Biju John is a professor at RIU Trivandrum. Welcome, sir.
Hope my screen is visible.
Yes, very much.
Yeah, okay. So I will just start. So I think, good morning, everybody. And at the outset, let me thank KSOS and Dr. Raji for giving me this opportunity. So you have listened to two beautiful talks illustrating the use of, one is the indirect ophthalmoscopy and second is the 78-day slit lamp biomicroscopy by two stalwarts here. And as Dr. Biju Raju has put it, it is bliss really seeing the 20D lens getting filled up with that beautiful image of the retina, or the 78D lens, seeing the disc of the macula through the 78D lens. But you all know that the way to bliss is actually laden with some thorns and stones, because it's said to be a narrow road. And this thorns and thorns is the vertical inversion and the lateral reversal. I mean, nobody would like to see things upside down. So this is something which I think the newcomers will, will take some time to get used to it. And the way to do that, or the shoes that is going to help you or protect your feet from the thorns and the stones, is the fundus drawing. So the way to get over this problem, the way to learn indirect ophthalmoscopy is do the fundus drawing along with that. Please don't be lazy about this. Please don't neglect it. Okay, so let us just go to the okay, it seems that there is
your presentation is gone.
Okay, I'll just share it once more.
Yeah. It was there already, but yes, it's come back.
The thing is that I just want okay. Okay, I think now things are moving. So, so this is what we are going to draw. Okay, this is the picture of the fundus. This is the left eye fundus. You can see that the optic disc is on the left side. There's a horseshoe tear here, and this is the chart that you are all going to use. This is the Amsler-Dubois chart, and it will be there along with your indirect ophthalmoscope. A few copies will be there. You will have to take the photostat of these charts and keep them ready. And you need some of these colored pencils also. So this chart, you can see there are three lines. The innermost line represents the equator. The second line is representing the ora serrata, and the outermost line is actually the junction between the pars placata and the pars plana, corresponding to ciliary processes. The first thing that you are going to do is to actually draw the optic disc and the fovea, and then the ora serrata. You can see that the ora serrata have been marked. You can see that the processes, the dentate process is actually much more prominent on the nasal aspect than the temporal aspect, and that is what we have drawn. Now, and the side is also marked here. OS means left side. So you can see that there are meridional lines, 12 lines, which actually divide these charts into 12 clock hours. So this is the chart. Now, the next thing, so this chart would be placed probably on the side of the patient. The patient would be lying supine, or on the chest of the patient. And the first thing that you'll have to do after this is to actually invert the chart. Okay, turn it upside down so that now the 12 o'clock of the chart is towards the patient's feet, or 6 o'clock. Okay, this is your way to overcome the inversion of the image. Now, the image in the lens will be corresponding exactly to the drawing chart. After this, it is better not to think of superior, inferior, temporal, whether it is reversed or not. Now, we are starting the examination. So here comes the lens. So as Dr. Biju Raj has already told you, stand 180 degree away from the area being observed. I'm just starting with the posterior pole. So this is the image. This is what I'm seeing. You can see that the image in the lens is vertically inverted to what you see here and laterally reversed. So this is the area where you're seeing, this is what you're seeing. You just need to copy whatever you are seeing here onto this aspect. See, this lens, this vein that I have drawn is exactly as I see in this lens and not as in here. So you draw this one into this area. Now, next thing, I'm going to look at the 1 o'clock meridian. So I would have it to stand 180 degrees from the 1 o'clock, which will be at 7 o'clock. Now you can see that because of this inversion, the 1 o'clock is automatically in this area, which is closest to me. That is because of the inversion. So that is what I'm doing now. See, the 1 o'clock area, this is almost here, closest to the area where I'm standing. And now I'm just drawing whatever I'm seeing here exactly as it is in the lens to this particular area. You can see this line, which is the boundary of the detachment here, as I'm seeing like here. And this is the edge of the hole, because I'm seeing only the edge of the hole here. And these vessels has also been drawn like this. So this is what is actually happening, but this is what you are seeing. So up to the mid periphery is completed in this quadrant. You are drawn from here up to the mid periphery, it is completed. Now you'll have to go to a little more to the periphery so as to see this break. For this, as Dr. Biju has already mentioned, you need to ask the patient to look a little towards the 1 o'clock, and you might actually need to tilt your body a little more backwards in order to enable you to see into that area. So that is what is happening now. See, now that hole is coming into view, and I'm just drawing here. Again, exactly as what is seen in this lens, this is being transferred to the this chart without worrying about inversion and all those things. So now you can see it is complete. So one quadrant is completed. From the disc, you are drawn up to the periphery, including all these breaks and including the boundary of the retinal detachment. And now you go to the rest of the quadrants. You repeat this process in all the clock hours. You just repeat this process in all the other clock hours, and that is what being done. So each time you just draw the things that you see in the lens in that area of the chart which is closest to you, and finally this is what you get. And this color coding, that is the aura serrata, is generally drawn in blue. And next what you do is that you just reinvert the chart, and now you can see that you have got an exact replica of what you are seeing here in your chart. Okay, so you never have, during this time, you do not even think of the reversal or vertical, all those things. Now, so this is how you need to do. And if you just keep on doing this before, much time, in 25, 50 times you do this, things will be very easy and you will never be bothered about the vertical inversion or lateral reversal. So this you have to do diligently. Now, next is the color coding. So while doing this initially, we would be generally, doing the drawing or marking the boundaries or the landmarks with probably the lead pencil, or you can directly use the color pencil also. So let us say these are the common colors that we use. These are red, then blue, green, yellow, brown, and black. So first let us see the normal landmarks. So he has already drawn the optic disc, which is in red, the fovea, a cross, a red cross if it is attached, blue cross if it is detached, the aura serrata is in blue, and the attached retina, it is in red. But remember that this is regarding the detachment. When you are drawing the fundus of a patient like a diabetic retinopathy, where there will be a lot of other vascular changes and hemorrhages that you will have to mark, it would be better don't shade the entire area with red, because it will be very difficult for those hemorrhages to stand out. In that case, you can just leave it like that. Or the detachment, you can just shade it or just do it with red cross lines. Okay, and the pars plana is brown. And the veins, of course, you draw in blue. and the artery is represented. Generally, only one artery is represented in red. These are the vortex ampullae, which also Dr. Bijuraju has showed very beautifully. And then comes the ciliary nerves, which are drawn in solid yellow. So that about completes the normal landmarks. Then the next thing you will have to consider in two different headings. One is the features which are commonly drawn in detachment charts. So let us just talk regarding that. Now, first of all, blue color, solid blue color. What are the lesions which you represent in solid blue color? These are the ones, the detached retina. So the detached retina and the outlines of the breaks. See the detached retina, which is shaded in blue, outlines of the break, whether it is horseshoe breaks or whether it is a round hole, you always do in blue outline. Then the meridional folds, the star folds, the traction tuft, these are all in blue. Outlines of retinal dialysis. So any break, most of these breaks you need to outline with blue only. Again, a lattice degeneration. Here you are using blue hatchings. It is blue cross lines or cross hatchings, not solid lines, but blue cross lines or cross hatchings. That is used in lattice degeneration. You can see it is a blue outline with cross hatchings. Then the inner layer of retinoschisis, white without pressure, the rolled edge of a flap tear. Here you will be using this cross hatching because the area is large and you don't want to shade it like that. Now, a giant retinal tear like this. So can you guess, what will be the color coding in a giant retinal tear? Being a tear, the outline would be in blue, but the inverted flap here, you will be using cross hatchings. See, cross hatchings like this. So the outline is in blue, the inverted flap is in cross hatchings. So that is our blue. And what is this? A blue dotted line. This means that the fluid is just shifting there. This is to mark a shifting fluid. So when you have a blue dotted line adjacent to detachment, it shows that the fluid is shifting. Now, solid red. So all those breaks, the inner portions of these breaks are all to be shaded in red. See, all those previously outlined with the blue, now we are shading with red. So here is the dialysis, here is the horseshoe tear, everything is in red. And the schisis, the open portion of the outer layer hole, we will be shading in red, but the inner layer hole, we won't be shading in red because we want to differentiate. That would be a different color. We will be using just cross hatchings here in order to differentiate that from the outer layer of hole. So that is what we use in the red cross lines. See, so you see, use this red cross hatchings for the inner layer hole. Again, an area of retinal thinning, you use red cross hatchings, which is outlined with blue, and the open portion of the giant retinal tear. See, whenever you see a break which is very large, it will be, it is just common sense that you cannot shade the whole area. So you generally use cross lines or cross hatching like this. So that is why even large dialysis also, many people use only cross hatchings instead of shading like that. So that is about it. Then, yeah, a paving stone degeneration. Here you used red cross hatchings with blue outlines. This is also red cross hatching, which is with a brown or a black outline. This shows chorioretinal atrophy. So this is our differentiation between a paving stone and a chorioretinal atrophy. The only difference is the color of the outline. Now, brown. So choroidal detachment, you use brown color. And a pars plana cyst is also in brown. Then this is a melanoma, which is also used in brown, but there is blue around it because it shows the adjacent X-ray detachment that is being shaded in blue. Now green. Now whatever there is in front of the retina, you shade it as green. So just remember like that. Anything in front of the retina, you generally shade it as green. So you have got a green operculum here. You can see this is an operculum of this particular break. So this is a Weiss ring and cuneiform opacities of the lens. These are all in green. What about black? Now, when you have to draw a buckle beneath an attached retina will be black, and if it is beneath a detached retina, it will be brown. These are pigmented demarcation lines. Pigments also, we use black. So these are pigmented demarcation lines. These are areas of hyperpigmentation due to cryoscars. Now we come to the features which are generally drawn in retinal vascular disorders. That is why I just removed that red shading here, because you don't generally do that. So, for example, red. Now, all those hemorrhages, all that you see generally in red, those hemorrhages are drawn in red itself. The shape will tell you what type of hemorrhage it is. So, dot and blot preretinal flames. Now, NVEs will be in red, but then how are you going to differentiate between a flat NV and a raised NV? Very simple. The flat NV you outline in blue, the raised NV you outline in green. Now, hard X-rate. The hard X-rates, then the drusens, cotton wool spots. Now, here comes the confusion because these are all in yellow. So this is the problem when we have all these things together, and people are really very extravagant when they use the yellow, and it is a sea of yellow. So when all this comes together, I think you can use these markings also, the C for cotton wool spot, the D for the drusen, and the hard X-ray can sometimes be marked with these black crosses also. So this yellow outline it's not yellow, completely yellow. It's an yellow ring in cotton wool spots. The drusen will be yellow dots. So the RX rate, so it's better to mark these things. Then intraretinal edema will be in yellow. And again, those peripheral X-rays, the sheathing, the retinitis, these all will be in yellow. This is a retinitis where there is also hemorrhage surrounding it, like in CME retinitis. Pigment sheathing will be in black. Now, again, anything which is in front, vitreous, it is going to be green. So vitreous hemorrhage is going to be green. Again, how are you going to differentiate between an old vitreous hemorrhage and a fresh vitreous hemorrhage? Again, simple. If it is a fresh vitreous hemorrhage, if it is red, you outline it is red. If it is, white, which is signifying old vitreous hemorrhage, you just leave it as green. Now the asteroid halos again in green. So this is a fibrous tissue proliferation. You just mark the area and use this cross-hatching. This is an IOL which is dislocated and lying in the vitreous. Again, everything is in green. And this is something which you can use as a last resort when you are not seeing anything. It just means that the pupil is insufficiently dilated. So it is just to convey the message that you are actually looking through through a non-dilated pupil, and so you are only able to see up to this, that is the posterior pole, and the examiners, please don't ask me about what is beyond that. Now, and finally, okay, you need to make sure that the chart would be something like this. When it is completed, you need to make sure that you also return the name, the age, and the diagnosis of the patient. So thank you. So that about finishes it.
Thank you, Dr. Biju, for that excellent presentation.
Thank you, madam. Thank you, madam, for sharing the session. And each presentation is getting better after. I don't know. I'm spellbound here to see that such beautiful speakers are there amongst us. And I thank all the speakers, and I say namaste to everybody for participating in this and making it a big success. I'm really happy. Thank you so much. We'll meet again at 1:50. Sir,
Sir, can I ask one question to Dr. Biju? Dr. Biju, this is something the PGs also asked me, and I'm also not very sure. So I thought this must be a platform to clear it off. So the cotton wool spot, regarding the cotton wool spot and the hard exudate color coding, I don't know whether I think there is something mention about a green color for a cotton wool spot. Is it so, Biju, or is it just my imagination?
You're right, Latika, because I think this the retinal drawing has, I think, evolved from the time of Dr. Stephen, because he started it. And over a time, the colors has also changed, and different people will be using different colors. The system is going to change, and what we are following may not be what is being followed in another institute. So this confusion is there. For example, cotton wool spot, there have been sort of at least 3 descriptions. One is it can be in green color. Second is it can be in yellow solid color. Third is it can be in yellow outline. And the fourth one is you can just mark it as C. So how do we go about it? I think these issues will persist. So I think you'll have to, you are better follow one system which is in your institute. But logically speaking, I think green should be reserved for what is in front and it should not be used for a cotton spot. So I would prefer yellow with a marking. See.
Yellow with the marking. Yes, that's finally what I also ask PGs to do. Because hard exudates and cotton wool spots look the same, yellow.
Yeah.
Yes, thank you.
Thank you so much. Thank you, Dr. Mini, for helping me out, sitting throughout. And I request Dr. Vinod to take over the place of Dr. Mini in the afternoon. Vinod, are you there? Are you listening to me? Okay, we'll stop with this. We'll come back after 10 minutes. Go have your lunch and come back, Vinod.
Thank you. Thank you, Rajiv.
Sunday.
Namaste to the technological guru also.
Yes. Sir, thank you so much for sharing my video.
Welcome.